We are live, please.
Thank you, Sunilji. Very good morning, everyone. And it's nice to see that we have attendees coming in and for the session of refractive surgery at 10 o'clock in the morning. So warm welcome to all of you. After the first very exciting first day, we move on to the second day of the Mos Midterm Conference. And the first session today morning is Dilemmas in Refractive Surgery. We've got some lovely cases and some fantastic expert panel. So with this intro, I would request the moderator, Dr. Nikhil Balakrishnan, to take over the session and carry forward the proceedings. Dr. Nikhil Balakrishnan. Okay, Dr. Nikhil was there. It seems that there's some technical glitch. So I welcome the chairman, Dr. Anaga Herur. She is also the president of the Maharashtra Ophthalmological Society. Yes, Nikhil.
Good morning, everyone.
Good morning, everyone. So welcome to the Refractive Conclave organized by the in the midterm MOSCON online webinar that we are doing today here. At the outset, I would like to thank the MOS committee, the scientific committee, Dr. Anaga Herur ma'am, Dr. Preeti Kamdar ma'am, Dr. Piyush Bansal sir, and Dr. Sumit Lane sir for giving us all the platform to present our work here today. We would start off with this conclave. I would like to say good morning to all the participants and to all the people who have logged in early in the morning for this refractive conclave. We'll start off with our first talk for the day. Our first talk for the day is to be given by Dr. Palak Kusumgar. She is a cataract and refractive surgeon working at Arihant Eye Hospital, Nagpur. And today she is going to be presenting her topic, PRK to the rescue. Over to you, Dr. Palak.
So good morning, everyone. At the outset, I would be thanking the whole MOS team for giving me this opportunity to present few interesting cases on PRK to rescue. Is my PPT visible to everyone?
Yes,
Yes,
doctor.
yes.
Okay. So, as we all know that PRK has been goes way long back. First procedure being done in back in 1987. So it has been there with us more than LASIK as well. So more than 40 years that we are doing this procedure. As we all know, why does PRK holds strong and still is there with us? No flap, no complication. It preserves biomechanical strength. MMC use has changed the game to a large extent, where haze was a major concern in the older days. It is no more the concern. And also, we are getting stable and long term refractive outcomes. So, when I give this talk, I want to highlight how PRK goes beyond it being the primary choice for any refractive surgery. So, I would be presenting few cases where PRK had come to my rescue or our rescue in our setup, where we could give good refractive outcomes to patient. So, this was one 24-year-old patient who had come to me post LASIK. The LASIK was done around 5 years ago elsewhere. Thankfully, the patient had his old records, and the pre-op refraction was around 5.5, which was corrected back then by microkeratome. The flap measurement, which I have written as 110, is just an assumption because the microkeratome was used. Currently, he was complaining of blurred vision, and the dilated refraction showed an acceptance of -1 diopter. His unaided vision was 618 and was getting corrected to 6/6. When I say all of this, the other examination was done, which was normal. The retina, macula, everything was normal. So now the next question was, patient had actually come for recorrection. He knew that he was wearing these glasses, and this is after follow up of 1 year that we had come to the fact that he will need recorrection. So this was the old sheet which he was carrying with him, and all the measurement was written though on paper and pen, but they were well preserved. The good point was there was axial length which was measured previously, and when again on measurement, there was little amount of axial myopia which was explaining the current refractive error. So now the question was whether we relift the flap. This was a topography well centered ablation, normal topography, decent pachy. So the question was whether we relift the flap or make a new flap or do some other procedure. So this was the anterior segment photograph where the flap edges were not clearly visible. They were very difficult to find where the flap edge was exactly. So in such a procedure, we decided to not go with the flap lift. One reason the flap edges was not visible, and frankly when taken on the OT table we did try to find the flap edges, but it was difficult. A new flap would have given us risk of buttonholing or many other flap related complication. So transepithelial PRK here was our savior, and it was done with MMC. The outcome at 3 months currently is very good. The patient is enjoying 6/6 vision and there is no haze. Coming to another case, a 28-year-old female had come for LASIK consultation with the refractive error being there and the PACI being something like 478 and 482. Patient is not tolerant to contact lenses, and there was a family history of keratoconus. Not major eye rubbing, but occasional eye rubbing. The patient said yes. So even before we were going to the proper tomography scanning, the PACI was on the thinner side. Patient did have some amount of positive family history, I would say, and patient was not tolerating contact lens. Now the patient was very motivated for refractive surgery. This was the scan, tomography scan. Otherwise, everything being normal, the PACI being 476, and such being the Badley map, the other eye topography scan, everything else was normal, but the PACI was borderline. In such a case, the question was among, of course, amongst all these three procedures. So in my practice I usually do not do a flap procedure when I find pachy something like 480 or below 500, I would say. So this was, again, we went ahead and did this corvus for the patient, and the CBI TBI was again not exactly normal, but of course it was in not so normal range. So in this particular patient, I did select trans PRK as my choice, and the patient is happy and enjoying stable refraction with no haze and no other PRK complications. Now this is the
Thank
third
you,
case.
Dr. Palak. If you could please wrap up so that we can have a discussion.
Yeah. I'll quickly wrap it. This is my last case. It is a case of refractive surprise post cataract surgery. A high myope was operated with monofocal lens, and there was a current refraction of acceptance of 2.25 with a 0.75 cylinder. So I would quickly go ahead and say that it was probably a miscalculated IOL implantation. So we had either option of IOL exchange or putting a piggy bank IOL. But for such a refraction and with some amount of cylinder being there, I chose to go with a trans PRK, and it did turn out well. Patient is enjoying 6/6 vision and has a stable refraction. So when do we choose PRK? Usually it comes to our rescue in all such cases where we have residual post LASIK error or some amount of axial myopia which we see post LASIK, in borderline thin pachy, or post cataract surgery refractive surprise. Thank you.
That was an excellent case presentation, Dr. Palak. I would now like the expert panelist, Dr. Mitali Kekan, to give her expert opinion regarding the cases that were discussed right now. Dr. Mitali Kekan is a leading cataract, cornea, and refractive surgeon She's a prolific surgeon and has presented at various different national and international podiums. Over to you, Dr. Mitali.
Thank you. Good morning. First of all, very nicely managed cases, again emphasizing that surface ablations and PRK is actually a good uh, first selection in certain specific type of cases. So I would just like to comment in the first case, good, the axial length was already recorded, so we could know whether it is actual regression or actual progress in the myopia. How did you plan the optical zone is what I want to know in this case, because if you had an idea of about the optical zone, you got it a little larger zone. How was the planning done?
So I had kept it at 6 mm, which
Okay.
was, yeah, because I had good pachy and there was no other problem with the topo. I could keep the optical zone of 6 mm in this case.
And was there any aggravated healing response in terms of haze as it was a retreatment done?
No, no, no. I think of course, the diopter which I was treating was also very small. It was just one
Right.
diopter that I had to treat. There was no
Right.
aggravated response, and MMC when we use, we usually are safe with that.
In this case, I would just like to add that record in your pre-operative assessment, recording your axial length, your epithelial maps, and doing a topo after 6 months or after 1 year is a good idea, so that we actually know whether it is progression of myopia or regression or just epithelial remodeling. Coming to the second case, I think considering the gender, the age, and probably she will have an obstetric history, so PRK
Yes.
obviously is a good choice.
Right.
And for the last case, when it comes to doing enhancement for post-cataract surprises, I think considering their dry eye status, their macula, and even centration of the IOL and capsular back contraction also needs to be considered in such
Yeah.
cases.
So I quickly went through the last case. I would like to mention that when we do post cataract refractive surprises, a good amount of counseling is needed because not every time that we would go on a bang on result, especially because we are treating with a different cornea as well. So that's what I like to mention in that case also. And of course, we need to check the IOL centration and everything else, which was done. And after that, we
Right.
came to the decision of doing trans PRK.
Just adding to the list where PRK can come to the rescue, again, it will help us with managing astigmatism post keratoplasties and managing enhancements post smile and ICLs also. So PRK is definitely a to-go procedure for such cases. We have an excellent panel today. Would request their insights as well.
Yeah, Dr. Palak, good morning. Very, very well presented. Actually, PRK many times is underestimated, and because of its, excellent post-operative outcome, similar to, and it's much, much safer. The only thing is we need to counsel the patient regarding the pain in the first 3 days. Many times use of cold BSS and the use of NaCIDs and contact lenses dipped in that. All this we can reduce, but they need to be mentally prepared because many times they compare their post-operative recovery with a patient who has undergone LASIK. So if they are mentally prepared for that, then it makes it easier. Plus, sometimes it takes a little longer for them to settle down. LASIK patients usually have the wow factor on day one post-op. So all we need to do is very good, thorough counseling and explain to them why this is different. Maybe it is a good idea to mention all this even on the OPD case sheet. Of course, it is there in the consent, but even on the OPD case sheet, the question is if there is a corneal haze, how would you treat?
So, if we see an early corneal haze, of course, we step up the steroids, and along with that, we taper it very slowly and let them be on steroid for a longer time, along with adding cyclosporin so that we have little stabilization. Of course, dry eye needs to be taken care of very nicely in such cases because that could be again one reason. Other than that, to prevent too much of haze, we do advise patient about the UV protection part as well, because if they are going on some vacation after your procedure, there is a chance of delayed haze as well if they are exposed to UV light a lot.
Nikhil, next talk.
Yeah.
Nikhil,
You
you
have
are
to unmute
Nikhil, you are
yourself.
muted.
Nikhil.
Nikhil.
Sorry, if we're finished this discussion, we'll go ahead and proceed with the next topic. The
Yeah.
next speaker for today is Dr. Kalyan Chotes. He is a cataract and refractive surgeon practicing at Shivam Eye Hospital in Nashik. He is going to speak to us today about managing a refractive surprise. Like in our practices, with all the different types of refractive procedures being done, he is going to give us his pearls about how to manage them if we have any refractive surprises. Over to you, Dr. Kalyan.
Good morning, all, and thank you for this wonderful opportunity. Uh, am I audible? And the screen is
You're
visible?
audible, but your screen is not visible. Yeah, it's
Let me
starting
check.
to.
Seen now?
Doctor, it's loading.
May I start?
No, doctor, it's not visible. Can you just
You're
stop and
present.
then reshare, please?
I'll
I'm
stop and
stopping.
reshare.
If you can just reshare, please. Since there is a bandwidth lag, now you can try resharing, please.
I'll put my video off.
Are you on a mobile data, doctor?
Yes, sir. Actually, I'm traveling, so is it
Yeah, that's
okay
good.
now? Is it seen?
No, no, doctor, you need to
Okay.
reshare, please.
Could
I'll
we
try
take the
once
next
more.
speaker in the meanwhile till Dr. Kalyan can fix up his video issues?
Go ahead, Nikhil. You're the moderator. You're the boss.
Sure. Okay.
I'll try it once. If not possible, I'll wait. Will that be okay?
Yeah, you could try once.
Yeah, I'm just trying once. If it is okay, or else I'll wait. So is it okay now?
No, we can neither see your video nor your screen, sir.
No video. I just put off. Fine, ma'am. I think you continue. I'll wait for some time.
Okay. So in the
Yeah.
meanwhile, we'll take the next speaker for today. The next speaker for today is Dr. Yash Gala. Dr. Yash Gala is a prolific cataract cornea refractive surgeon practicing at ASG Eye Hospitals at Vashi. Today, he is going to give his insights on interesting refractive surgery complications. Over to you, Dr. Yash.
Good morning, everyone, and thanks to the entire MOSCON scientific committee team for giving me this opportunity. Also, thank Dr. Zain for letting me present this case. So, I present a case of a 24-year male IT professional who came for getting spectacle independence. The unaided vision, as we can see, is 6 by 24 with best corrected visual acuity with correction of minus 4.25, myopic astigmatism in both eyes. Anterior segment and fundus examination was unremarkable. Shermer's was 15 and 20 in right and left eye. This is the dilated AR refraction as well. This is the topography of right eye with a CCT of 523 and the K1 being on the flatter side, that is 40.89, and with no evidence of ectasia and a symmetrical bow tie in both eyes. We planned the patient for SBK, microkeratom LASIK in both eyes. So this was the ablation profile. So we kept the optical zone at 6 millimeters. No financial interest. The examer laser platform was EX500 and we used the Moria microkeratom blade with blade of 90 microns and ring of plus 0, step 7.5 as per the nomogram. So after creating the flap and during examinal laser ablation, intraoperatively during laser ablation, the patient was little uncooperative. There were constant eye movement causing break in acquisition multiple times, as you can see in the pupil tracking. And thereafter, the ablation was done, flap was opposed, I shifted to left eye. Left eye was a bit cooperative and it went uneventful. Post-operatively, flap was well opposed. So on day one, patient visual acuity was in the right eye was 6 by 18, in the left eye was 6 by 6. We followed up the patient after 1 week with routine post-op regime in terms of steroid antibiotic combination and lubricating dry rub. So after 1 week, as we can see, the irregular topography. So probably intraoperatively, with a pure myopic astigmatism, what has happened is there is an undercorrection and a 10 to 15 degree cyclorotation, because of which the irregular topography, as we can see here, and the AR reading of the patient was around plus 1.5 minus 3 into 161 degrees, which was stable enough over 3 to 3.5 months. And the best corrected visual acuity with refraction was plus zero point 0.5 minus 2.5 into 160. Patient was very apprehensive during these months and patient wanted a visual acuity of 6 by 6. So we told the patient to wait for another 3 months for refractive stability. This is just the enhanced tangential map. As we can see, it was not a decentered ablation, but definitely because of the mild cyclorotation, 10 to 15 degree makes a huge difference of a loss of two-third astigmatic results. So after 3 months and looking at the stable refraction, we again did a subjective acceptance where the patient was accepting plus 1 minus 2.5 at 160 degree with the same 6 optical zone, and the thickness allowed us to go for an enhancement. So we decided to go for flap relift. This is just a small video and the trouble that I faced. So preoperatively, although I saw the patient and I could see the marking, but as we know on the EX500 platform, and generally the light is not that great like a microscope to really visualize the flap margin well. So I went as if that I was lifting the edge flap, but I was going in the wrong direction. And then suddenly when superiorly, when I came back with the Z lifter, the blunt end of the Z lifter, I found the flap edge. And then I made a groove on the superior part. And once I made that groove, uh, I could lift the flap. And then with my flap lifter, I went ahead underneath the flap. And like how we do in a femto LASIK, just lifted the flap well, and later on, sorry, is the video playing?
Yes, it's playing
Yeah.
well.
Yeah. So after the iris registration and patient did cooperate well this time, and we went ahead with the examinal laser ablation because it was a cylindrical power and the flap edge, as we can see, I protected the flap with a LASIK sponge to avoid the laser falling on the hinge. I repositioned the flap and with a routine irrigating cannula, flap wash was done. And then for 2.5 minutes, the edge were dried with a LASIK sponge. I wanted to also tell that since in the initial part of it, I went with the wrong edge of the flap and I was going circularly with the Sinskey hook. So this part of the epithelium, besides along the edge flap, beyond the edge flap, I tried to remove it with the hockey stick so that the chances of epithelial ingrowth are less, uh, which we ultimately want when we relift the flap, and also because of iatrogenic me causing that epithelial debridement in a
Dr.
subsequent.
Yash, if you could please wrap up your
Yeah,
case.
yeah, sure, sure. So as we can see, the pupil tracking in this case was well. So post enhancement, day one, patient visual acuity was 6 by 6, flap was well opposed, and I had put a BCL. So you can see the irregular flap where I went into, And on day 7, with the AR reading, patient maintained the visual acuity of 6 by 6, and there was edge scarring. And over a month, patient maintained a 6 by 6 blur vision in right eye. Patient was happy, and there was no epithelial ingrowth seen. So,
That's a
thank
lovely
you.
case, Dr. Yash. We would move on to the panelist, Dr. Saili Shirodkar. She is a cataract and refractive surgeon, having finished her fellowship from the prestigious Narayan Nethralaya. She's presented at various national and international podiums and has been bestowed with many awards at the same. Over to you, Dr. Saili. Your tips and pearls regarding managing such complications in refractive surgery.
Thank you, Dr. Nikhil. Dr. Yash, that was a fantastic case. And what made it especially unique, I feel, was that it doesn't seem like just a routine residual refractive error, but you addressed a lot of intraoperative challenges that one might face in managing such a case. And even the part about the management of epithelial ingrowth, etc. These were very valuable points. I just had a few follow-up questions. Number one, was there any reason why um, you were confident at going in at 3 months? Were there any, was the refraction stable at that point, or were there any patient symptoms that made you confident of the intervention time being 3 months exactly?
So, for the first 1 month, we followed the patient every 1 week, and later on every 2 weeks. And we did a subjective refraction each time with a topography as well. And although we didn't do a topo guided treatment here, but we went ahead on the contour platform and the topolizer, and we saw that the refraction was matching with the subjective acceptance as well because of the irregularity. We just wanted to be as it is close to the subjective acceptance. He was also accepting a minus 2.5, but when we
Okay.
actually did a subjective acceptance with fogging, so yes, with a plus 1 and minus 2.5, that was so it was a stable refraction for over 3 months
All right.
because we were regularly recording it with the topos as well, serial topos.
All right. All right. And looking at the AR, I know that the EX500 has a very robust tracking system, and it's usually rare to encounter any decentered ablations. But given that there were repeated reacquisitions, given that the patient movement was extremely uncooperative, and the bizarre AR reading that we saw post-operatively, do you think there might have been a component of decentered ablation in this case?
Uh, Yeah, maybe, but there's also a component of cyclotorsion. So what I
Yeah.
realized, I think if correct, the other panelists also can comment. What I realize is in a pure cylinder case, even a 10-degree, misalignment
Um,
intraoperatively can cause a huge default. In the spherical part, we get away because even if the patient moves and with the robust cyclotorsion compensation, I think we don't face a problem. But here, I think in a pure cylinder with acquisition breaking again and again, I think that made a huge difference with undercorrection and irregular topography. So I think,
Yeah, no, you're absolutely right, because this is something that we encounter in IOLs as well when there's a mild rotation that results
correct.
in undercorrection. Post-operatively, was there any particular care that you took in terms of regular follow-ups? Because, like you said, we already have an inherent risk of epithelial ingrowth in relifts. So, were there any modifications in the post-operative protocol or in the follow-up protocol in this particular
Uh,
case?
In the post-operative protocol, not really. I think the challenges is in the intraoperative part. So I think, as I said, I went ahead and I went along the wrong edge. So that itself made a trouble. And lifting a flap in a normal case as well increases the chances of epithelial ingrowth. So I think the edges where you're
I
actually
think,
making a groove.
paucity of time, we'll have to cut short this discussion. There was a great case, Dr. Yash. Excellent
Thank you.
tips and pearls, Dr. Saili. I think we can move on to our next speaker. If Dr. Kalyan Chote is ready, can you please share your screen and we can proceed with your presentation? Dr. Kalyan? Okay, I don't think we have him here yet. So, in the meanwhile, we'll go ahead with our next talk. The next speaker for the day is Dr. Natasha Pahuja. Dr. Natasha is a cataract refractive surgeon practicing out of Pune at Pahuja Eye Care. She has also done her PhD from Maastricht University in Netherlands. She is also the winner of the Colonel Rangachari Award and has been bestowed with many accolades at many different international and national podiums. Over to you, Dr. Natasha, who's going to talk to us about flap follies.
Thank you. At the outset, I would like to thank the. Am I audible?
Yeah,
The screen is visible?
yeah, you can
Okay,
go ahead.
fantastic. So at the outset, I would like to thank the organizing committee and the scientific committee for a beautifully curated program. I would also like to thank Zen for reaching out and making me expose all my vulnerabilities here. So this is a beautiful case, and I'm. It's literally the follies that I'm going to be sharing here. So this is a small video where a fellow was operating, and I was seeing on the screen, and this is how it goes. So uh, he had a microkeratome at his center, so we were trying to train him on microkeratome, and he operated on this patient, a 23-year-old male. The right eye was a very, very successful case, and he was very confident. And that made me very confident in his capabilities. Left eye, he said that there was suction loss, and I was hyperventilating at that time because I wasn't sure what happened. And the fellow was like, I don't know what is the issue. Why is she, so hyper about everything? And I was seeing on the screen, it felt like there was no flap. So I told him, go ahead and redock. And that's what he did. Now, what I realized was that this patient had a very high zygomatic arch. And so this patient, the pendular microkeratome from Moria basically just got stuck in that area. And he just had lifted it up. And I was holding the flap, holding the microkeratome in my hand, and I saw something which scared so much. So what had happened basically that there was one flap that was already made, and with the second dock and a second flap. So the first flap was a free flap, and it was stuck in the blade of the microkeratome. And this was how it was. So there was one free flap and a second flap where the hinge was partially torn. And here, if you see, I'm trying to just basically open up the
Is
flap
the
from the
video
microkeratome.
seen? We cannot see the
Yes,
video,
ma'am,
I think.
it's visible, ma'am.
Oh,
Visible, no?
oh, sorry.
Is the video visible?
Is I stopped it. I'm going to start again. I mean, but I'll.
Yeah, you can go ahead and continue it. It was visible, ma'am.
The video was seen very well, Natasha. So you can continue
Okay,
from where
okay.
you
You
left off.
continue,
Okay, no,
continue. Yeah, yeah.
no, my screen froze now. Second. Is my screen still visible?
No, it's not right now.
All right. Let me share it again. Visible?
Yeah.
Okay, so I'm just
Yes.
gonna go ahead to the part where we stopped. Okay, so yeah, so basically, if you see here, there was one hinge that was made here, and that hinge was partially torn. So here, what I'm basically trying to do is fished out the flap from the microkeratome blade, washed it with BSS, washed it with moxifloxacin, and trying to figure out which is epithelial side up. So just by tactile sensation, and seeing if so, this is done on the Schwind microscope, so the video is not very clear. But I was just trying to see where the epithelium, I could feel the epithelium on the forceps itself. And where I was slightly confident, I went ahead and reposited this flap. I'm just going to speed it up. So basically, this is me struggling for a good 20 minutes. Now I placed the flap approximately around the edges where felt like a jigsaw puzzle that it was sitting nicely. Um, and after this is done, I actually fold the first free flap and try to iron out the flap underneath. So this is what I'm doing. I'm trying to iron out the flap underneath where the hinge was torn. And then at the end of this procedure, I basically then folded this flap, made sure there are no folds, no macro and micro striae, which I felt was challenging, and I was expecting a very bad cornea the next day and a very poor outcome. But after I was very honest to the patient. I told that this is what had happened, but it may take time, but we will be able to fix it. So don't worry. So this is, if you see, I'm trying to just sort of very gently nudge it into the right place. Um, and at the end of the procedure, I put a fibrin glue ring all around, and this was 6 months where he had zero point 0.5 sil and 6 parts vision because there was a central scar. And this is the topography where, and this is just me at the end of 6 months, just very happy and content, luck being on my side. Yeah, that's it. I'll be happy to take any questions if there are.
Natasha, did you ablate this patient?
Yes, I did, sir.
Okay. So
I
with
did the
this
refractive correction. Yeah.
okay, with pendulum microkeratome, so as you all know, this was a peculiarity. If you take more than one flap with that blade,
Yeah.
usually these sort of complications were very common. That was the reason with every flap, they used to advise that put a PCL on that flap because it was a planar and thinner flap. Means so the standard deviation was around more than 15-20%. So normally if you intend to go for 130 flap, the flap size was 100 most of the times. And it used to
Correct.
get thinner and thinner. So many a times when you do more than one eye, you don't even realize that you have taken a flap. But you
You're
have
absolutely right.
managed
Yeah.
it very well. You have managed it very well. Means I was seeing those operating skill, I must appreciate. And probably the ironing out of flap was so proper. Probably that might be the reason that patient's recovery was very good post-operatively.
Thank you so much, sir. Means a lot. Thank you. Yeah, but you're absolutely right, sir. So, this repeat use of these microkeratome blades is one of the most common cases you beautifully pointed out. Now, this patient had, we did the right eye and then the left eye because we don't use microkeratomes as much. It's just that the gentleman who was doing the fellowship, he had a microkeratome at his center. So he wanted to learn how to do microkeratome, and that's when we fished it out of a box somewhere in 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 some wardrobe in the back.
One thing we noticed was that there were no markings on the cornea before. That is one of the, I think, a tip that in any microkeratome case where you know that there could be a free flap or anything, if you make a marking on the cornea, especially two different markings, it helps you identify the epithelial and the correct surface. So that when you're
Orientation.
replacing it, yeah, it becomes you're 100% sure that you're not placing the flap upside down.
Absolutely, I couldn't agree more. So this was a trend that we used to do when we were doing a lot of microkeratomes. As I said, no, this particular case we just fished it out and then we like, okay, fine, let's do microkeratome. But you're right, the first step should have been marking the cornea.
Yeah, and another thing is to ensure that we have the epithelial side up. The best way to this thing is if you scratch it, the epithelial side will actually cause, you can make an abrasion, but not on the stromal side. Apart from definitely the reflex, it's more matte finish on the stromal side and more glossy. But If it has been handled a lot, maybe that would not be so clear. But the best way to see is you can actually make an abrasion on the epithelial side. That will ensure that you are on the epithelial side up.
So that's what I was trying
Yeah.
to do, ma'am, with the forceps. I was trying to just
Correct.
sort of scrape off the epithelium to see which
Scrape
side is
off.
epithelium up. Yeah.
Yeah. Yeah. Yeah. Very well managed.
Thank you, ma'am. Thank you.
Thanks.
Scary, but yeah.
Very scary.
Yeah.
So, after that brilliant case that Dr. Natasha showed us, we will proceed over to the next case. We have with us today a young ophthalmologist, Dr. Gargi Wavikar, working at Wavikar Eye Care at Thana. She is also a prolific cataract and refractive surgeon, and today she is going to speak to us about custom Q LASIK for presbyopia. Over to you, Dr. Gargi. If you can please share your screen.
Yes, sir. Is my screen visible?
Yes, yes, it is.
So, a
You
very
can
good
proceed.
morning to all. And I would first like to thank the MOSCON Organizing Committee and Zen sir for giving me this opportunity and platform. I'll be speaking about a patient with a very low preoperative Q value in the negative range in whom we approached advanced monovision on custom Q platform a little differently. So we have a 38-year-old lady who came to us with a moderate grade of myopia, modest cylinder. On dominance testing, the right eye was found to be dominant. Her best corrected visual acuity was 6 by 6 N6, ruling out any amblyopia. There was no squint. She was orthotropic on both Hirschberg and cover testing. There was no history of subnormal cortical function, which can jeopardize the neuroplasticity. She underwent a thorough preoperative evaluation, a corneal topography with epithelial mapping, aberration screening on the MS-39 with the pupillography, and the corneal biomechanical stability was seen with Corvus. A dry eye workup was done, and based on all of these, as we can see, she was a suitable candidate for LASIK. So we are now in the planning station, planning the left non-dominant eye. So there are 3 steps here. Number 1 is giving the monovision, which in this case we have kept as -1 based on the patient's age of 38. The second step is changing the Q value, which we have changed to -0.6, and accordingly change the target refraction as per the Ruiz nomogram. And the last step would be to apply the wavefront optimized nomogram that we usually do. So this eye is usual. Now, in the right eye is where we deviate a little from convention. Generally, we don't touch the Q value of the right eye. I mean, the dominant eye, whichever it is. So here we have changed it from a very low -0.06 to a more physiological -0.3. Why we have done that, we'll shortly see. And then we have adjusted the target refraction, the spherical correction. So the ablation was executed as planned. FEM2 advanced monovision was done, and 2 months post-operatively, the patient's binocular visual acuity was 6 by 6 N6, and with both eyes open, she had absolutely no complaints. So custom Q for presbyopia correction revolves around 5 basic principles. The dominant eye is corrected for distance, and the Q value is kept unchanged. So with the help of the depth of focus given by the normal negative corneal asphericity, this can contribute to far intermediate vision. The non-dominant eye is kept mildly myopic, and the Q value is kept between -0.6 to -0.9. So this eye has a clear intermediate which can be stretched up to near with the help of the higher depth of focus given by the more negative Q value which we give. The goal is a good blended intermediate zone which can lead to binocular summation, better stereo acuity, and a more continuous range of vision. The Q value adjustment is basically a balance between the induced spherical aberrations and the imparted depth of focus. And the interocular difference should not exceed 0.4 to avoid contrast mismatch or glare. So this is an ideal custom Q situation where the dominant eye has a physiological Q value of -0.2 to -0.3, can see from infinity to up to say 2 meters. And the non-dominant eye can see from, let's say, 80 centimeters to up to 30 to 40 centimeters. So as we can see, the gap between these two zones is not that high, and the requirements of this intermediate zone not very fastidious. So the intermediate blended vision works very well. Now, in this case, with a very low negative Q value, the dominant eye lacks the necessary depth of focus to stretch the distance zone to 2 meters. So the zone in between near and distance is very wide and the blended vision will not work. So that was our rationale of touching the Q value of the dominant eye. This is a matrix which we have created, which is basically, it gives us a very good idea as to what could be the contribution of the dominant and non-dominant eye at various ranges. So based on the viewing distance, the ad needed at that particular distance, the dominant and non-dominant eye target refraction and Q values, we can calculate the myopic and hyperopic defocus at various distances, and we can get a fair idea as to the blend zone dimensions. And the patient's profession also weighs in here. The patient's age also weighs in here. The key factors in patient selection are an unequivocal dominance testing, ruling out anything which can jeopardize neuroplasticity, for example, a history of stroke or a coma, a road traffic accident which has led to a coma. The personality should be adaptive and adjusting, and binocular function must be good, amblyopia and squint ruled out, and other tests which can be done are monovision tests and blur tests. And contraindications include dry or unstable tear film, which can exaggerate the blur, very large mesopic pupil sizes, which can cause increased internal aberrations, small mesopic pupils, which can interfere with the corneal multifocality. And I just need 10 more seconds. And lastly, any occupations which need, which are very high stakes and which need unequivocal stereo acuity need to be avoided, like, for example, pilots, drivers, and athletes. So with that, I conclude. Thank you.
That was a brilliant presentation, Dr. Gargi. You explained very well about the basics, principles about custom queue, and also how we plan a custom queue for presbyopia correction. I would like to introduce Dr. Vardhaman Kankaria. He actually needs no introduction. He's a prolific cataract refractive surgeon working at Asian Eye Hospital at Pune. He has also a Limca Book of World Record holder for LASIK surgery and has done more than 10 to 15,000 laser vision correction surgeries, and has trained under Professor Palikaris himself. Over to you, Dr. Vardhaman. If you could give us your tips about custom queue and patient selection and how to proceed with the same.
Yeah, thank you so much, Nikhil, for the kind introduction and brilliant presentation, Dr. Gargi. I think it was very nice. I think about the custom queue, she has, given excellent pointers. So actually, what I wanted to discuss was, because this is possibly the only presbyopia presentation that we have. So I thought that I'll give some pearls for the modern presbyopia procedures, the different procedures that we have. How do we select each one of them? And what are the pointers that everyone should take into account? So as we all know, presbyopia is definitely the holy grail of refractive surgery. I think there are billions of people around there, and the success that we have seen with the younger generation in laser vision correction, we always want to replicate it in the presbyopic praise group in terms of the patient satisfaction. But of course, the presbyopic patient group is very unique. It requires a very unique systematic assessment, systematic plan, customization, as well as post-operative care is also equally important. So 5 small pointers. Number 1 is, do not discount the lenticular contribution. So I think for people who have access to look at the internal aberrations of the eye and lenticular aberrations per se, especially if they have access to the Tracy technologies, looking at what is called as the dysfunctional lens index is very, very crucial, because all these very modern corneal refractive surgeries such as custom Q or Pres Beyond work beautifully well. But if you have chosen the wrong patient and if you have not looked at the internal lens, especially in that presbyopic age group, there are some patients who are going to have internal aberrations, and some patients are going to have a progressive internal aberrations issues if they are lenticular. So always make sure that you have done a DLI or have a very careful slit lamp examination to rule out if there is any internal lenticular change, especially ask them about any recent glare phenomena that they are experiencing if you don't have access to the DLI. In DLI, it is important that, as we all know, higher the numbers, it is more is the lenticular function, and lower is the number, more is the dysfunction. So always rule them out. Number two is, of course, the dry assessment. We all know that the dry assessment is very, very important in all refractive surgeries. But most importantly, they are for the presbyopic age group because these people are already predisposed to the age-specific decrease in goblet cells, more incidence of meibomian gland dysfunctions. And because here we are looking at something like custom Q, in which we are actually playing with the aberrations, and the first refractive surface of the eye is actually not the cornea. It is actually your tear film. So if your tear film is not good, any induction of induced spherical aberrations, such as in custom cure or blended vision, is not going to work very well. So always make sure that you are very judiciously looked at the dry eye profile. You have made sure that the dry is pre-treated before you undertake these patients for either custom Q or blended vision approach or any other presbyopic laser procedures. Now, she did discuss about the cross blur, but here I would like to give a pointer that there are some patients. So I think I've always seen that most people actually do not do the cross blur and they just do what has been traditionally followed as the pointing sign or the diamond hand sign, in which you are looking at a target with a diamond preposition of the hand, and then the dominance of the eye is actually tested. But that is not a very accurate way. Always make sure that you are doing the inter-eye cross blur tolerance. And if you feel that it is not very, very not very, very good acceptance of cross blur that time, and the patient is still motivated, ensure that you give them a contact lens trial. So do not hesitate to give a contact lens trial to those patients, because you would like to definitely avoid those patients who will not be very, very adaptable to the cross blur that you'll be inducing with any of this modified monovision approach. And the most important thing is the counseling, because I think these patients have to understand few things as against our younger patients. That here we are just trying to delay the dependency on near glasses. We are not actually getting rid of the near glasses forever. So they have to know two things. Number one is that in the future, there will be a progressive decrease in the amplitude of accommodation that is going to require additional power, and maybe some people may require enhancement, or some people will have to use glasses for the same sec. And the second thing is that the amount of time they have to spend for neuro adaptation, because that is something that they have to know beforehand. If they have not been told this before, and they will actually lead to very, very dissatisfied patients in spite of doing our best. But if you have spent good amount of chair time before the procedure, if the patients are well aware about what are they getting into, these patients, believe you me, these patients are one of the happiest patients, even though they understand it's just a functional near vision that we are giving them. Do not compare the results that you have achieved for their children when you have them done a smile or a contour for them for distance only approach. And the last thing is that now it's an era where we are actually looking at multiple solutions for presbyopia. It is not only one custom Q or blended vision. Now we have plenty solutions. We have had some experience of using, of course, custom Q press beyond from size, custom Q from the Wavelight Plus, Wavelight, and we have also had some experience of using also the corneal inlays. We have done some work on corneal inlays with the FlexiView corneal inlays about 12 to 13 years back with my mentor. And of course, now there are newer ICLs or phakic lenses which are coming, both in terms of the multifocality, which is from the care group, and also from the EDOF, which is from the STAR. As of now, they are not giving very, very satisfied solution. But if the time comes that they are able to give very, very good solution, they may become one of the best ways of treating, because it's a reversible solution for them. And these people are going to require cataract surgery in the future. So basically, the cataract will be absolutely unadulterated with this. And the last pointer is about procedures such as smile with monovision in these patients. I think there is a very nice paper by Jorge Alio from Spain. Although smile works very well in younger patients, but I would like to give a red flag for patients who are presbyopic and presbyopic. The smile doesn't do as well for them for only distance correction or monovision. And that is because of some more aberrations induced because of two interfaces. So I think these are the 5 small pointers I thought that I'll give for the sake of our audience. Yeah, thank you.
Thank you, Dr. Vardhaman. There were some fantastic pearls on planning custom queue and making sure that we select the right patients to go ahead with same. We will now proceed with our last talk for today. It's by Dr. Kalyan Chote, and he is going to speak about refractive secondary piggyback IOL implantations. Dr. Kalyan, if you could please share your screen and start off.
I have already shared. Is it seen?
Yes, it's seen. You can proceed, sir.
Okay, thank you. Good morning, and sorry for little disturbance in between. Thank you for this wonderful opportunity, and let's start. So this is a case in which we have done a refractive secondary piggyback IL implantation in the sulcus for treating a refractive surprise. So she's a case of a 59 years female, had undergone right eye phaco 1 year ago elsewhere, but not happy with the outcome, and then presented with difficulty in vision in both eyes. When we operated her left eye, she was had a good outcome of minus 0.25 spherical post-op refraction. But then now she wanted some solution for the earlier eye, in which the refraction, post-op refraction was plus 2.5 diopter spherical. Rest examination was normal. When we looked at the biometry, we found that the power she needed in the right eye was 20.5, but she was implanted with 17. When we did Barrett RX calculator, it showed that she needs a piggyback power of plus 3.5. So we had a plan now to go with a piggyback IL. This was a pre-op ASOCT of the case, in which there was in the bag IOL just sitting inside the bag and a little asymmetric cover of the CCC. So what were the surgical options? One was to have an IOL exchange, in which we take the lens out from the fibrous bag, but it has a high risk of PC damage, zonules, and vitreous disturbance. Other choice is to just take the optic out and keep the haptics inside by cutting. But again, in this case also, we have no chance of putting the lens in the bag. It is going to be a sulcus implantation. And the other next was to have a planned secondary piggyback IOL in the sulcus to have least damage. The IOL options like a 3-piece IOL, which is a non-spheric one, like a Sensa 3-piece, which has a 5-degree posterior angulation. It has a thin rounded front edge, which is safer for iris touch. Other options are like Sulcoflex type of single piece lenses from Rayner, and one more from IOC, which has a 4 haptic design. So we'll come to the video at the end. This was the post-op ASOCT of that case, in which we had seen that the lens was put in front of the previous lens in the back, and when we actually measured it, there was a space of 286 micron almost. So before this, I'll just go to a bit of video and we'll come to the learnings. So is it seen?
No, sir, the video is not playing. Yeah, yeah, playing right now.
Is it playing? Okay. Okay, I think. So we had implanted the lens.
It's playing in the on a small screen. If you could just enlarge the screen of the video, please.
No, that's okay. That's all right. That's
okay.
You can continue.
Okay,
Yeah. So think of it like this. Biology is performing triage. Retatrutide and libido. So here's the problem. Retatrutide kills design.
I'll get back to the PPT. So the learnings in this case was, I think video was run through a little faster and with disturbance. We had a sensor three-piece 5-degree posterior angulation lens, which was a thin and rounded one. Barrett RS gives good accurate IL power calculation. If the CCC margin is adequate and all around, we can consider a gentle 360-degree scoring of the capsule and before implantation of the IOL. Optic capture as a secondary IOL is more challenging as the bag is already fibrosed, but we can give it a try as it gives more stability and a UVL protection in long run. But we have a risk of interface membrane between two lenses. Now, secondary piggyback IOL as a three-piece sulcus implantation is relatively when the IOL exchange is received, but the ELP is more anterior for IOL in the sulcus than when the lens is captured in the bag.
The pleasure center gets chemically castrated. Sex, food, novelty.
That was a great presentation, Dr.
That is it.
Choti.
Thank you so much.
Yeah. We have with us Dr. Somil Kothari, who is a prolific young cataract and refractive surgeon practicing at Bombay City Eye Institute in Mumbai. He's a celebrity ophthalmologist with tons of experience, having done tons of cataract and refractive surgeries. Over to you, Dr. Somil, if you could please give us your insights about the same.
Thank you. And that was a good presentation, and Dr. Chote. Now, how much time had elapsed between the primary cataract surgery and when you had seen the patient?
It was 1 year, sir.
A year back. All right.
Yeah.
So, fine. So many times we are left with post-cataract refractive surprises, like one of the other speakers also had shown their case when they had performed PRK, I believe. So there are different options of treating post-cataract refractive surgery, refractive surprises. And when the patient is unhappy, especially in this particular case of yours, when it was a hyperopic surprise more than a myopic surprise, it was plus 2.5. Definitely the patient is not going to be happy with hyperopic post-operative results. So there are different options. One of them being do a bioptics, which is called. It is basically do a refractive surgery. You treat the plus 2.5 in either the method of your choice, which should be either PRK or LASIK. That is up to the operating surgeon's choice. So that is one option. The second option, what you did was what you did was went ahead with the piggyback lenses. Piggyback lenses are an excellent choice. Very simple, straightforward, and as cataract surgeons, right up their alley, it's very comfortable for them. The third option would have been to actually do an IOL exchange, where the fibrosis of the bag would be a hindrance to in order to just remove the lens out of the bag and then replace it with another lens in the
Yes,
original
sir.
position in the bag. So these are the various options which we are left with after a refractive surprise after cataract surgery. Now, only thing is about piggyback lenses. Word of caution is we have to evaluate from the angles point of view, rule out any glaucoma or history of glaucoma or predilection for glaucoma in such individuals because you're definitely crowding the anterior segment of the eye. So also with regards to, we cannot just go ahead and put any lens inside the sulcus. That's not appropriate. The Rayner lenses, the Sulcoflex, were actually designed for using as a piggyback lenses in the sulcus. They were an excellent design. But again, because of whatever reasons, there are various reasons they are not
Not
available.
available.
Yeah,
Yes, sir.
so we have to fall back on other options. But only thing is about what you need to actually look out for is called the red rock syndrome or interlenticular opacification, as you had pointed out, in which it sometimes causes intractable glaucoma in many situations. So we have to be really wary about all these things before we go ahead with a piggyback IOL. So interlenticular opacification, just to briefly tell, it's basically a membrane which develops between the two lenses. And more so when if the lenses are in close proximity or touching each other, then that's a high risk situation where we do get this issue. So an anterior angulation of the lens, of the piggyback lens, is thought to be preventing this complication from happening, right? So that was what was the design of the Rayner sarcoflex. But very well managed, very well thought of, and very well executed plan for giving you an ultimate happy patient. Fantastic.
Yeah, thank you, sir. Actually, during the case, I was trying, since I could not, show the video completely because of some glitches. Intraoperatively, I was trying to put the lens as a piggyback to capture, considering the long-term risk of UVL touch. But I could not because it was asymmetric bag and second CCC, and second thing was it was fibro, so it was very difficult to get it under. Ultimately, I left the left try, just clean the viscoelastic whatever is possible and came out. And when I did a post-op ASOCT, I found that there was a significant gap between two lenses, which is not usually obvious when we are seeing through microscope. It was significant, around more than 250 microns of space. So the other thought, like the
I
chances of
think due to
interface membrane will
paucity
be
of
less.
time, when
Yes, sir.
we've fallen
Yes.
short of time, we'll have to cut short this discussion. But
Yes,
that
sir.
was a
Thank you
great
so
case,
much.
very well managed. And thank you, Dr. Somil, for your wonderful
Thank you,
insights.
Nikhil. Thank you.
Thank you
Uh,
so much.
I
Thank
would
you
like
all.
to thank everyone for attending this refractive session. I think we've learned a lot right from PRK, managing of complications, custom queue, and management of breast myopia. It was a wonderfully curated session. Thank you, Dr. Zen, for curating this wonderful session, and thank you, Moss, for giving everyone the opportunity. We've all learned a lot and go back with a lot of insights today.
Yeah. Great discussion. Thank you, everyone. And I think all the speakers and all the panelists have done a great job to give their valuable insights. So, very nice Sunday morning. Well spent.
Well moderated,
Yeah.
Nikhil. Right on
Well
time. Thank you,
moderated.
man.
Yes. Right.
Yes, sir. Thank you, ma'am.
Yeah.
So we move on to the next session now. This was the first session that actually got late by 2 minutes. So let me hand it over to Professor Archana Vare, the member of the scientific committee. Madam, are you there? Can you please
Yeah, yeah,
welcome our
yeah. I'm there. Yeah,
chairperson and quickly
yeah,
begin
yeah.
because we are already short of 2 minutes.
Okay. So, good morning, everybody. At the outset, I would like to congratulate uh, the uh, the organizing committee, Dr. Anaga Heru, Dr. Piyush Bansal, Dr. Preeti Kamba, Dr. Ajay Lohia, and Dr. Sumit Lahane for this wonderful midterm session. And with this, we will move ahead to our next session, that is Cataract 1. So that is the session is Dilemmas in Cataract 1. So I invite respected Padma Shri Dr. P.K. Mehta sir to chair this session. And the first speaker of this session is Dr. Pratik Lakhmawar, who's a student from GMC Chhatrapati Sambhajinagar, and now he is consultant at Hingoli. And the expert panelist for his talk is Dr. Himanshu Mehta sir. And so I welcome Dr. Pratik. I request him to share his screen and start his presentation.
Madam, just to intervene, we also welcome all our expert panel, Dr. Himanshu Mehta, Dr. Atul Kadane, Professor T.P. Lane sir, Dr. Ragini Parekh madam, and back to you and to Dr. Pratik.
Yes.
Hello, very good morning, everyone. Is my presentation visible?
Yes, Pratik, it is visible.
Okay. So first of all, I would like to thank Moss for giving me this opportunity. So I'll be presenting on a case of a juvenile uveitic cataract surgery. So the objectives of today's presentation is to understand the preoperative uveitis management before the cataract surgery, We understand the strategy that was being used for the cataract surgery and its post-op considerations. So to start with the case, the patient was a 16-year-old female, known case of HIV, was on ART, came with the complaints of bilateral gradual painless diminution of vision since 3 months. The patient was a follow-up patient of a granulomatous anterior uveitis and was well controlled with topical steroids. The visual acuity in right eye was 20/60. The intraocular pressure was normal. There were old, medium to large pigmented keratic precipitates were present, and anterior chamber was quiet. Posterior subcapsular cataract was present. In the left eye, the visual acuity was 20/50, IOT was normal, and rest of the findings were similar to that of right eye. On posterior segment, there was no any presence of vitritis or retinitis or vasculitis. All the systemic investigations that were done, like MONVI, DHA, quantiferon, chest X-ray, were normal. The CD4 count of this patient was more than 500. So the diagnosis of both eye granulomatous anterior uveitis with complicated cataract was made, and the plan was to do a phacoemulsification in both eye one by one, uh, keeping 1 week apart with posterior subcutaneous triamcinolone acetonide injection. The main considerations, the strategy was this case was preoperative whitening. It is very important to give a quiescence of around 2.5 to 3 months before cataract surgery, because it takes around 8 to 12 weeks for blood aqueous barrier to repair. So within this, if we try to do any uh, cataract surgery or any other surgery, so this might act as a secondary insult and might flare up the inflammation postoperatively. Also, the counseling in these cases is very important, because we know in uveitic cataract post-operative complications might be very dreaded, from simple such as pigmentation over IOL to anterior capsular phimosis, posterior capsular opacification, and if the uveitis was very severe preoperatively, there might be retropupillary or retroiris membrane, and that can lead to uh, ciliary shutdown, hypotony, and might lead to phthisis. So not might not be relevant in this case, but as a counseling point of view, we should explain everything to the patient. The strategy of the fake that we'll discuss with the video, and IL selection is also very important in this case. So for this monofocal IL, which was hydrophobic acrylic. So please start with the video. Is the video playing?
Yes, Pratik, it is playing.
So anterior capsule was stained with the trypan blue. So the challenges in this case was the patient was a 16-year-old, so the capsule was very thin and elastic. So I had started the capsular access with cystitome, and rest of the to achieve better control and circular around 5.5 to 6 capsular access, it was shifted to 23 gauge micro access forceps. So good 5.5 to 6 capsular access was being achieved. This was the Patwardhan's capsular access forceps that was used. So it was a very soft posterior subcapsular cataract. So after hydro, one pole of the nucleus was collapsed into the anterior chamber, and directly phaco aspiration was done. So with the help of blunt chopper, rest of the nucleus also collapsed, and with no amount of energy being used, all the nucleus matter was aspirated. In such cases, it is very important to remove all the cortex, because even small amount of cortex can lead to nidus for inflammation postoperatively. So it is very important to take your time and remove all the cortex. So as I said, single phase hydrophobic acrylic IL, advanced monofocal IL was chosen as the age of the patient was very less, and it was placed in the back. It is very important to remove all the viscoelastic material, go behind the IL and remove trapped viscoelastic material. After removing the viscoelastic, posterior subteral
Dr. Pratik,
injection
another
was
20
given
seconds
before.
and we'll stop your presentation. So please make it faster.
So this was the post-operative result. The patient was 2020. The intraocular uh, anterior chamber was very quiet. So key takeaways from this presentation is preoperative inflammation control is absolutely non-negotiable, and post-operatively also we have to follow up this patient for at least 3 to 6 months, and not like a routine case. The strategy being used for this case is uh, at least 3 months we have to keep on topical steroids and NSAIDs also.
Thank you. Thank you, Pratik. So Pratik, will you please stop sharing your screen?
Thank you, ma'am.
Yeah. I request Dr. Himanshu Mehta, sir, to give his expert comments.
Yeah, very well managed. We all know uveitic cataract can be a very dangerous thing, and these are young patients, high expectation. There could be vitritis. Doing a posterior segment thorough examination and a B scan, you can't see anything. Patient is blind. We are blind. So a good thorough examination of the posterior segment, whether or not tractional detachment or present or not, giving intravitreal steroids preoperatively. I don't know how much Piyush would agree with me on that. If you see vitritis. This is something which we should keep in mind. Case very well handled. Lot of steroids, oral and locally, and atropinizing the eye. This is all that I can say. Dr. K.K. Mehta, sir, good to see you early morning.
Always a pleasure.
Piyush, do you agree that you should be giving some steroid intravitreal or something if you feel there's vitritis or peribulbar, more steroids?
So
Well, I would have given
depends on
steroid.
what kind of a uveitis it is, whether it is a acute, whether it is a chronic uveitis. Again, we don't go in with intravitreal steroids in most situations. We look at the systemic aspect of it first. So I'm not in the favor of directly blindly, because we can't let out a message go that we can indiscriminately give an intravitreal steroid, because some of these patients might land up with complications because of that as well. Again, if your view is not very significant, and going in and giving intravitreal steroid can also be dangerous. Systemic steroids, of course, are available.
I agree with this.
I agree to disagree with him on a little bit, because giving a lot of side effect with oral, say 40 to 60 milligrams, I've seen a lot of complications. So with Ozodrex kind of medications, with a lot of uveitis, locally subtenance is my choice, first of all.
Subtenance is my worst choice. The reason for that is, in case if there is a intractable raise of intraocular pressure, it's practically impossible to get rid of it. In fact, intravitreal dose of steroid is easier to remove with the vitrectomy as compared to a subtenon. So the affordability factor, of course, not spoken of.
But Piyush, isn't it secondary glaucoma? It is not primary glaucoma.
Yes, of course.
So,
but equally damaging, if not more.
Sir, what would you do, Dr. K.K. Mehta, sir?
Well, I mean, I would like to agree with both of you, but I would have given subconjunctival steroid. No question about it. I know it is difficult to remove, but usually speaking, when it is there, in case you do get in trouble, it is not difficult to handle with oral drugs.
Correct. Dr. Lane, sir, what is your opinion, sir? Dr. Ragini, if you're there.
See, the Himanshu.
Ji, sir.
Patient is HIV positive.
Ji.
When patient is HIV positive, in this such type of patient, giving the systemic steroid will not be a good choice, because already his immune status is compromised. I think you can give local steroids before starting the surgery. It means for 1 week or 2 week, and then you continue local steroids for a longer duration. That is a good choice. Lastly, if you want to give, then you can give the subtenon or subconjunctival injection. But I will not. I will avoid before surgery. If something goes wrong after surgery, then we can have this type of choice.
Yeah, so as always, we would expect a violent reaction in the eye after surgery. Any kind of eye, the moment you touch this eye, there'll be a violent reaction post-operative. A thick membrane will form on the lens also, exudative membrane. Nice, sir?
Now, for that we'll have to. For that only we'll have to. Before
Correct.
surgery, we'll have to plan the local steroids.
Correct, sir. That's what I was just thinking.
And then
Yes.
you go for the surgery.
Yes, sir. Thank you. Thank you very much, sir. Dr.
Thank you.
Ashna?
Thank you, sir.
Yeah. Thank you. Thank you so much. So, with this, we will move on to our next talk. The next talk is by Dr. Rachna Shah, and she'll be speaking on management of PC rent. And Dr. Rachna Shah she is a consultant ophthalmologist, cataract and retina surgeon at Asian Eye Institute and Laser Center, Mumbai. And the expert panelist for her is Dr. Atul Kadhane, who's the consultant at Yash Netralaya Amravati, and he's the Vice President 1 also. So with that, I would like to request Dr. Rachna Shah to please share her screen and start her presentation. And please stick to time because we are already we are already a little bit late. Okay?
Yes, ma'am.
Okay.
So at the onset, I'd like to thank MOS for this opportunity. Is it visible?
Yes, it is visible.
Yes. I'll just start with my cases. This is a PC rent during IA. As you can see, I'm just extending the main incision, going in with the cutter and clearing up as much vitreous as is possible. We can also see a cortical piece near the wound. So once all the vitreous starts clearing up, the piece starts moving, and I try to aspirate it or gently nudge it out of the wound, sort of a thing. My irrigation is just at the wound. It is not visible here clearly, maybe in the next case. Once the vitreous, the piece is out, I clear up all the vitreous. We can also stain with triamcinolone at this stage. Once the vitreous is cleared up, we can go in with the bimanual irrigation aspiration, keeping the aspiration port away from the rent margin. Going to the other side, just aspirating the remaining cortex. So now I think I can get away with placing the lens in the bag itself because it's a relatively small lens. We just have to remember to place the haptic away from the side of the ren. Yes, and that's a good end result. And the second case was being done by a phaco trainee. Right. The visibility is slight of finishing, but we can see there's a rent during the last piece. Yeah, the capsule is being caught over here. See if you can see. And then she comes out. Ideally, we should have put visco before coming out. Here I'm just putting visco to push the pieces sort of away from the site of rind. Then I slightly extend the incision. Again, go inside with the cutter. Irrigation is just placed at the wound margin and it's slightly pressing the lower lip so that whatever cortical or nuclear material is there, I tend to nudge it out of the anterior chamber. Yeah. Similarly for the rest of it. Yeah. Generally, only once all the nuclear material is out, I go inside with the irrigation and the cutter to finish off the rest of the vitrectomy. Here I am using a dual linear mode on the cutter. So I will use the cutter itself to aspirate the cortical matter. Yeah. Yeah. This is on vacuum. And if you find that the vitreous is getting entangled, then again you can shift to cutter and cut the remaining vitreous. Similarly for the other side. And so this was a relatively large lens. I'm just putting a PMMA in the sulcus for this patient. And we can suture at the end of the surgery. This I'm just showing that there's some cortical matter
Dr.
which has
Rachana,
left behind.
please sum up.
Yeah. So the cortical material, even if it was behind, it came up by itself. Rest we can continue as the last surgery.
Thank you, Dr. Rachana.
Yes.
Okay.
Thank you, ma'am.
Yeah, thank you. So I request Dr. Rachana to stop sharing her presentation and Dr. Atul Kadane sir to give his expert comments.
Thank you, Dr. Rachana. The nice presentation.
Thank you.
With the permission of stalwarts like KK Mehta sir, Lane sir, Himanshu Mehta sir. I'd like to pinpoint few points in this presentation. The first case, I think the vitrectomy should have done from the side port. You should not use the main port for the vitrectomy because the chamber, whenever you do vitrectomy, if you have a stable chamber, it will always give you a good results. So there are no cutters now which can go through the side ports, or even if it is a big cutter, you can make slightly bigger the side port. From another port, you have an irrigation. And so that way the vitrectomy will be very nice. Second thing which I can point out, as she had pointed out in the second presentation, which is that whenever there is a vitreous or PC red, don't get panic. It is a part and parcel of the game. So having a vitreous loss, it doesn't mean you had done something more, any big mistake. Stay calm, keep your probe steady there. Don't suddenly try to remove it out. That is the first reaction that every novice surgeon will try to do that. So keep your probe stable on irrigation mode. And from the left hand, from the side port, inject visco. For that, in a routine case, start practicing injecting visco, even if there is no vitreous loss, so that in such type of situations, you don't have to do that activity for the first time. Because in that stress, you may not have that good control on your left hand while injecting a visco. So make it a routine practice that every time you eye or in FECO also, every time you come out, try to inject visco from your left hand so that it will become a routine part of. Third point is the whenever you do vitrectomy, maybe you can do it, but I always prefer for the new surgeons, you insert triamcinolone so that the things will become more clear for you. You will know where is exactly the vitreous is. And as you said, once the vitreous is clear, it depends on the stage also, which stage you had a vitreous loss. If it is like in the first case, you had a vitreous small red. In that case, I would have preferred to do a PCC also because that's very small red. So I don't want it to extend it while you put in an IOL inside. So maybe if it is a big red, you may not be able to do it, but in a small red, you can always do it, and it's very easy. Again, it's a mind block only that PCC doing is a big form. Only you need a side port with having a small, with these are small forces nowadays we have with us. The CC, the IOL and the sulcus always a three-piece IOL, and you can have now foldable three-piece lenses, so you don't have to extend. We keep a library of these three-piece lenses in your OC, and it's a very nowadays they are not also very big costing. Keeping that is a life saving for you because extending an incision. And again, whenever there is a vitreous loss, I always see whether even if I don't extend the incision, I always take suture because when you do a vitrectomy, some sort of hypotony. So you don't want another complication in the post-op because of the hypotony. So always better to have a single suture buried the knot. It's not a, you are doing a good for the patients. Rest all you have done it very nice. Maybe the experts, there are so many experts in this webinar now. They can point out some more points.
Yeah, thank you, Kadame sir. And I request Kike Mehta sir to give his expert comments as well.
I fully agree with Dr. Atul. You should inject in the viscoelastic from the side. Only little hint I would give is when you inject the lens, especially when you have open posterior capsule, always inject over an iris repositor. That way you can support the lens in case the tips tend to go elsewhere, which they sometimes tend to do. Otherwise, it was an excellent presentation. I quite enjoyed it.
Thank you, sir. Such useful tips. Thank you so much, sir. So with this, we will move on to our next speaker. Our next speaker is Dr. Megha Patil, and she is a consultant at HV Desai Eye Hospital. And the expert panelist for her is Padma Shri Dr. Lahane sir, who doesn't need any introduction. He's ex-director of medical education and research, Government of Maharashtra. So with this, I request Dr. Megha Patil to please share her screen. Dr. Megha? Dr. Megha, are you there?
What is the problem?
You're right, unable to share.
Dr. Megha, what is the problem? Can you unmute yourself and speak to us?
Yeah, she's messaging that she's not able to share her screen. I think we can go ahead with Dr. Imran Deshmukh because I can see him. Dr. Imran Deshmukh, he is a consultant phaco surgeon at Chhatrapati Sambhaji Nagar. So, Dr. Imran, can you please share your screen?
Okay, the reason why she's joined as an attendee. Dr. Megha, I've upgraded you to panelist. So after Dr. Imran finishes his presentation, please share your screen. You should be able to share your screen.
Yeah, I'll talk to her meanwhile.
Please unmute yourself, Dr. Deshmukh.
I am audible?
Dr. Megha, we moved on to the next one. So the next, after this one, you can present yours.
Okay, sure.
Dr. Imran Deshmukh, sir, please unmute yourself first.
Imran, you are muted. Please unmute yourself. Imran?
Hello, am I audible?
Yeah, you are audible. Please share your screen. Okay.
Hello? Hello?
Yes,
Yeah, doctor, you're audible. You can start, please.
Please share your screen, Imran. It was visible a while ago when you
Just
shared
a
it.
second. I'm again sharing.
Yeah.
Okay, can you see my screen now?
Yeah. It is visible.
Okay, thank you everyone for giving me the opportunity to speak in front of you. My topic today is my approach in phacoemulsification in phacomorphic glaucoma. So I'm starting the case. This is the routine steps, making side ports and making main wound. Important thing to remember is not to injure the entry capsule as the ACW is very low. Second step is to leave the dye for at least 30 seconds to 1 minute. So once you leave the dye, you get well stained. If this is one very important step in this surgery is making multiple star-shaped nicks. When you make multiple star-shaped nicks, the chances of extension is very less. I use a 27 gauge cannula here for aspirating all the fluid out. Once I have aspirated all the fluid out, the lens, the back compresses, and you can easily do your X's. So once this is done, aim for a smaller X's. Okay. Once you're doing a smaller X's, if you see, aim for smaller because the small X's can be enlarged anytime. And as the entry capsule is very fragile, so you have to be very careful and slow. As you can see, the size of the X's is very small. So what I'm doing here is I'm making spiral X's. So once the spiral rhexis is done, you can see the rhexis is still small. I will later enlarge it in my latest steps of surgery. So now the rhexis part is done. So there is no need to do any hydro in this part. Now this is routine phaco. I'm fast forwarding the routine phaco. So once the routine phaco is done, I'm doing trenching, and after trenching, I'm fast forwarding to 2x. This is stop and chop, and these nucleuses are very soft, mostly very soft. So emulsification part is very easy. So once this part is done, you can see all the quadrants are emulsified very easily. The emulsification is done very easily. And now going for IA, this is normal routine IA. Okay. Now this, as the cortex is very less, there's no need to do too much of IA. And once the IA part is done, you can inflate the bag. And here I'm increasing the size of the side ports. Now I'm implanting the IOL. The leading haptic goes inside the bag and the trailing haptic is in the sulcus. So now I rotate the IOL, and because of this, all the cortex which is left, it gets loosened out and can be taken out once the surgery is over. And now what I'm doing is I'm inflating the bag. And after inflating the bag, I'm using micro scissors to enlarge the rhexis. These are very important. These are very important instruments. You can enlarge the size of the rhexis, hold the rhexis at one part, and use centripetal force directed towards the center of the IOL, and then increase the rhexis. As you can see, this is slightly increased. So once this is done, I am using these micro forceps for manually constricting the pupil. What this, you have to be very slow and steady. Make sure that you're not using a lot of force. You don't want to cause error dialysis, and be very careful. Why I'm doing this? Because in post-op period, when you don't do this step, the pupils are mid dilated, and this causes a lot of photosensitivity. So here I'm manually constricting the pupil to bring down the size. You can either use microforceps, or uh, you can use the IA probe. So once this is done, once this is gone down, and now you can see the size has come down. And now taking the probe, I'm going inside. And all the visco is being removed, and now the case is closed. The side ports of wound is hydrated. And now using intracameral, and then this is hello.
Hi, Imran.
Hello.
Dr.
Yes,
Imran.
ma'am. Ma'am, was I audible?
Yeah, you were audible and your video was also visible.
Yes.
So I think
The last part I forgot to mention was that the important step in this was for manually constricting the pupil. What I have observed, if when you manually constrict the pupil, so in the post-op period, the pupil size comes down, so there is way less photosensitivity. And in routine cases of phacomorphic glaucoma, what I've noticed, if you don't manually constrict, the pupil is mid dilated in the post-op period, causing a lot of photosensitivity and irritation to the patient. So there were three steps important in this video. One was making the rixes. Secondly was enlarging the rixes by using microforceps. And thirdly was manually constricting the pupil.
yes, Dr. Imran. And with this, I request Lahane sir to give his expert comments.
Imran, you did an excellent surgery. Basically, in the intumescent cataract, as you know, the AC is shallow. And what you do, the rexis is smaller rexis, and then increasing the rexis is very good. You opened in the center multiple, this one. But normally, what happens in the center, sometimes the pressure of the fluid is more in the center. So I always advise to go in the mid periphery. If you go in the mid periphery, then the pressure there is less. Then the what surgery you did is very well. The second concept of yours, that is the just can say by, you can say forceps. You were doing the iris, you are making the pupil small. See, what we learned till today, you must treat the, you can say, the iris and cornea with very, very, very sensitivity. So touching the iris, you know, so that causes the trauma. What may be the cause? If you want to constrict, then pharmacologically you can constrict with the pilocarpine if you want to do it. Or otherwise it is dilated by the pharmacological drugs only. So automatically it will get constrict. So it will not require to constrict by some mechanism, this mechanical thing. So we should avoid such mechanical thing. Of course, post-operatively, small pupil helps, but such type of mechanical this pressing or pushing the iris is definitely, I think, we should avoid. And otherwise, okay, you may have a good result, but sometimes it may give the iridocyclitis or traumatic iris may be there. Whatever smooth way you go, this happens. So, but what surgery you did, concept I agree. The rexis is very difficult. Always there is a Argentinian flap, and that can be avoided by your technique or by mid periphery. Very true. First small rexis I agree, or you can increase the rexis. That also I agree. The pupil constriction also I agree, but the concept is mine as an old surgeon is go with the pharmacological constriction instead of mechanical. I think so.
Thank,
So
thank you,
you
sir.
can ask,
Thank
take
you.
it.
Thank you, sir. And I request Atul Kadane, sir, to give his comments as well.
Actually, I just like to add one point. In many times, as sir rightly pointed out, the pressure is made in the center. At the first nick, only you get an Argentine flag size. You don't get a time to do a small rexis or other rexis. We have one study I have presented in MOS also, one that 2 minutes magic, I said. You try it in the next intermittent cataract case. You put a trypan blue dye and keep it there by 2 minutes by clock. Even this 2 minutes is too big time. In all, we are doing this almost from 2021 and tell you that you get a time to develop the nucleus. See, as soon as you get the nick, you will never see that the bag will go from this end to that end. After giving a nick, you get a time to debulk the nucleus by aspirating the liquid fluidic cortex. And after that, making an CCC is a routine job because once the pressure is down, then there is the problem of Argentine will not. So maybe you can try Imran in the next intermission case.
Yes, sir.
Thank you, sir. I request Himanshu Mehta, sir, as well, to give his expert comments.
Yeah, very well managed case, no question about it. Dr. Lane said something very nice. Couple of things that I would just add on. A T-shaped incision. On a routine case also, we are used to doing either clockwise or anti-clockwise rexis. Practice in a routine case when your nerves are not very bad to do it the other way than what you're doing. Why am I saying this? As sir said, yes, go, but at the mid-periphery area, the pressure is least over there. Staining it for 2 minutes is the best idea because quite often when you want, this, the capsule is not stained. But T-shaped, the moment it tries to run off, if you start with the other side of the rexis, that has been the most saving grace of life. And or changing position to me, that has helped me to change my position of the hand and the wrist. Because the anterior capsule has a mind of its own in a white cataract. It just has a mind of its own. And it just wants to run off. So taking care there, you can't be overfilled, you can't be underfilled. You have to have pressure on the lower lip. And if you're doing a rexis.
Thank you. Thank you so much, sir. And now I request Dr. Kiki Mehta, sir, to give his expert comments.
I fully agree with whatever the previous speaker said. I would, however, like to add one thing more. One of the big advantages of keeping the stain for a longer period is it makes the capsule comparatively thicker. So the Argentine flag sign is much less. So stain it for a longer period of time. And the rest is all, of course, routinely as has been discussed.
Thank you, sir. Thank you so much, sir. So I think with this, we will move on to our next talk. And the next talk is by Dr. Megha Patil, and she'll be talking about phacoemulsification in a traumatic cataract. So the technical glitch has been solved, I hope. And Dr. Megha, I request you to share your presentation, please.
Am I audible?
Yeah, you are audible.
Okay. Good morning, everyone. I am presenting a traumatic cataract surgery today. In the same cataract surgery, a patient had a iridodialysis and zonular dialysis. So same thing I am finishing in one surgery. Thank you for the opportunity. I'll start with the video.
Dr. Megha, you can speak while and describe the steps that are being performed.
Dr. Megha?
Yeah.
Yeah. Please describe these tips. Yeah. Yeah.
Yeah, I'll fast forward the things. Okay, I will describe this and I first. I just finished the Rexis and I was able to complete the Rexis. Then afterward, I did a phaco emulsification first. And hydrodissection was done. Then little bit I dialing the nucleus. I don't want to dial the nucleus too much because I don't want to increase the cellular dialysis. And after the cataract is finished, I've cleared the cortex. And after clearing the cortex, I have put the CTR ring from the side port.
Please speak, tell us about the steps that you're doing.
Actually, I'm not able to minimize the volume of this video. After this, once I put the lens, I have repaired the iridodialysis with the help of Proline 50 suture, with the help of the flange technique. So in this flange technique, I used the Proline suture and I flanged with the manual cautery and I inserted into the conjunctiva. So that I will explain.
Please explain the procedure, Dr. Megha. Dr. Megha?
Yeah.
Yeah, please explain the procedure, whatever you are doing.
Once I cleared the lens portion, I decided to do the iridodialysis repair with the double arm flange technique. Usually we use the 10-0 Proline suture. So I use the 50 Proline suture to repair the ID, and I used the U technique so that I will insert the 26 number needle gauge through the sclera in the AC, and from the main port I inserted the Proline suture. I cut the Proline suture in a bevel manner, and I at the tip of the 26 number needle I have inserted the Proline and I took it out from the sclera. Both U shaped I have taken it out, and once I have taken it out, I have cauterized with the help of manual cautery. So U flange has been done, and the flange is then inserted in the conjunctiva, and conjunctiva is closed with the glue.
Okay.
So
So thank you
that,
so much. Yeah. Thank
no,
you
no,
so
that
much, Dr. Megha.
one last portion I would like to show.
Okay.
Okay. My audio was visible?
Yeah, you were visible and your audio, we could hear you also. So I request Dr. Ragini Parekh ma'am, but I don't see her. Ragini ma'am, are you there? Okay, so I think she's not there. So I request Lahane sir. Sir?
Yes.
Yeah.
Actually, I saw a total surgery.
Thank you, sir. Thank you, sir.
First time the surgery was planned very well.
Thank you, sir. Thank you so much.
The repair was done very good. I think
Thank you, sir.
The zonular dialysis you did the
Thank you.
good CTR, and
Thank you, sir.
the flange what you have made is a good. See, you have to just pull it towards the you have made in the conjunctiva in the sclera, and then you have done very well, and both repairs. It means the zonular repair and the dialysis repair you have done well, and I think the technique is also good. I really appreciate your surgery,
Thank you, sir.
and
Thank you.
I think really see Megha, you are
Thank
an
you, sir.
excellent surgeon and a very good surgery you did. I really
Thank you,
appreciate
sir.
because see two things together and very well done. Really appreciate and
Thank you, sir.
congratulate. Great
Thank
thing.
you, thank you. Thank you.
Ha.
Thank you, sir. Thank you so much. Dr. Karani sir, are you there?
Hello.
Sir. Yeah. Atul Karnani sir, are you there? Please unmute, sir.
माझा नेटचा इश्यू चालू आहे त्यामुळे थोडंसं.
So we can hear you.
Okay, so in the meanwhile, a question to all our expert panels who are routinely doing these sort of cases. Now, what we saw was a phacoemulsification being done, and there was, of course, zonular dialysis as well as irododialysis, presumably zonular dialysis. So, would you prefer to put in a CTR before initiating phacoemulsification, or would you like to complete phacoemulsification and then perhaps, just like in this case, before cortical removal or before implanting an IOL, then put in a capsular tension ring? Professor Mehta, Professor Lahane sir, Dr. Kadane.
Well, frankly, given an option, I would prefer to put the ring before. You just clear it up because you can be sure of your placement of the ring. Placing it subsequently, especially in this difficult case, is going to cause more problems. And I must congratulate Megha. It is an excellent case. Well done.
I too.
Piyush, what was saying? Acha, okay, Atul, go ahead.
नाही सर बोला ना सर तुम्ही प्लीज.
अतुल बोल तू मी पुन्हा बोलतो.
Sir, actually, I also agree with Mehta sir because the only problem that we say that putting an CTR before it is chances of entrapment of cortex, but that can be dealt by just changing the method of removal instead of an traditional teaching of putting an cortex radially. You can remove it by the tangential motion. So, but putting an CTR before cortex removal or putting an CTR will make your job very easy. It gives you a comfort. The chances of complications bit less. Yes, sir.
Thank you. Yes, sir. Next time I'll do.
see, what Atul and what Keki said, it is not necessary that you should put the CTR before surgery. See, if the zonules are not much damaged, you can do the surgery and you can remove the cortex. See, here the cortex and cataract will come easily, and when there is a CTR, that will intermingle in the removal of the cortex.
Yes,
In
sir.
some cases, it is better to go with the CTR after the surgery. But if
Yes, sir.
it is not supporting, it means the pressure, it is not tolerating the pressure when you are doing the PECO. That time you can put a CTR before, or you can use a capsular hook. But what Megha did was good, and that is also one of the technique, Megha. You were correct.
Yes. Thank you, sir.
But one more thing I just want to add. I tried, maybe I don't know, it is not available, but an ASI anchor, one of the implant that is to fix such cases with zonal dialysis. The beauty
Yes,
of
sir.
the implant is that you can put it before you remove your cataract once the
Cataract.
PCT is done, and it hooks on the anterior capsule. So it's nothing to do with the fornices. So the job becomes very much easy, and you can have an CTR also, as Lane sir said, after removal of cortex and after removal of nucleus, you can put a CTR also. Before that, you have a stabilized back with the help of ASI anchor. The problem is nowadays availability. I have done 6 cases of this ASI anchor and with excellent results.
I'll try next time, sir.
So since we have
That is
time, we'll just
yeah.
discuss a few
Okay,
more
thank you.
questions.
Go ahead.
Dr. Megha, any particular cutoff do you use when you are making a decision whether to use the anterior route or to refer to your retina colleague for a lensectomy? What is the cutoff that you would use in your practice in terms of iododialysis or zonular dialysis?
More than half of the zonular dialysis, or 5 to 6 hours zonular dialysis, then I'll prefer to have a VR backup. So all these cases which I have done this iododialysis repair and this, we have a great retina team with us. Dr. Rashmi is
So
there.
when you say you
VR backup.
like a retina backup, you mean to say
Yes.
that you will still go in from the anterior route, and in case if something
Yes, happens, then I hand over to her,
so
because I will
when is
inform
the cutoff? That is my exact question. When is the cutoff
more
that when you
than
need
half
to?
of the dialysis.
So
More
if
than
it
half
is
of the dialysis.
if it is
5 to 6
180
hour
degrees,
dialysis.
so if it is 180 degrees, that is the time that
Yes.
you don't enter anteriorly and
No,
you
no.
send it to your
No.
VR colleague.
VR colleague. Directly VR.
Still, we have like some time, so we can discuss Dr. Imran Deshmukh's case as well. Like he presented the lens-induced glaucoma case. So I request Dr. Kiki Mehta sir to give more comments about either the traumatic cataract or the lens-induced glaucoma cases.
No, I thought he did it quite well. I really have nothing much more to add. He
Thank
done
you,
a
sir.
good job. Done a really good job.
Thank you, sir.
Sometimes these cases can be very tricky. They look very simple in the beginning, and halfway through you get stuck badly. But he managed it comfortably. Congratulations.
Thank you, sir.
Uh, so I think we are like on time. So this was an excellent session with all the practical and clinical relevant discussions, and all the topics were extremely well covered, and they were highly useful for routine cataract surgeons as well. And so congratulations to all the speakers, and I thank the expert panelists and the MOS team for conducting such an enriching academic session. Sumit is there. Sumit, would you like to give some comments?
No comment, ma'am. Question, if I can ask, if there are 5 minutes, I can.
You have time,
So,
Yeah. We have.
question to KK sir, that in PCR cases nowadays, what do you prefer, doing an anterior vitrectomy with the pars plana approach, or going via side port? What is your take on the same?
If I was Abhay Basawada, I would go from behind. Because he believes and he always says you should go in from behind. The only big problem is that once your eye is open and the eye is soft, then to make a puncture point to put in a vitrector to go from behind is you literally squeeze the vitreous out. And that is the one big hassle. Of course, you can use the side port to do it. So unless I'm getting vitreous streaming out, I prefer to use the anterior approach. Far easier, far safer, far cleaner. And you use we use visco and you use steroid afterwards to make sure that you've got no vitreal traces left over.
So
So
just to
that
add
in
on that, Sumit,
yeah.
what I learned as well in these cases could be uveitic cases, could be cases with a lot of posterior synechias, smaller eyeballs, undilating pupils with a lot of positive pressure building from the back, especially these hyperopic eyes. What I learned from my senior colleague, Dr. Saumil Sheth, is that you anticipate it. So instead of, of course, you can give mannitol to the patients preoperatively, but in our busy practices, sometimes that is not the case and not possible. So in those situations, if you anticipate that kind of a situation, you can put in a single 23-25 gauge cannula, and if required, you can debulk a little bit of the anterior vitreous at any point of time that you see the positive pressure is causing prolapse of the anterior segment contents, or even viscoelastic for that matter. So if you reduce it and make it soft, you can go ahead and do the case with minimal complications. Just to add on to what your question was, would you like to go from behind, or would you like to? It's more of a matter of comfort. So we can't expect most anterior segment surgeons to do that. But in case one has experience with the anterior vitreous or the posterior vitreous, it becomes comparatively easy.
Just add one more thing on. A side port in this case is always very helpful. And Dr. Lahane has always mentioned it in his talks. A side port is what I call as a lifesaver. It maintains pressure, prevents excess. The movement of the face keeps the iris stable, enables you to handle it easier.
Thank you, sir. Thank you. We can start the cornea. They can have 4 extra minutes to discuss.
So thank you very much, Professor Archana. You've conducted the session beautifully. A big thank you to our esteemed expert panelists, Professor K.K. Mehta, Dr. Atul Kadane, Professor Lahane sir, and we've really missed Rakini madam over here as well. So thank you so much. Congratulations to all the speakers. And I request you to please continue. We have an exciting cornea session coming up next. So please stay tuned for that. We have Dr. Swapnil Bhalekar and Dr. Saurabh Mundra.
Thank you, Piyush.
Thank you very much, Sumit. Thank you, Dr. Vare. That was wonderful.
Thank you, sir. Thank
And
you.
of course, Dr. Lahane, nice to have you on board.
Thank you. Thank you, KK sir. And Archana conducted well. Thank you.
Thank you, sir. Thank you.
Thank you. Thank you.
So, Dr. Saurabh.
Yes. With your permission, can we start the session?
You can start if you have your speakers and expert panel already logged in. You can go ahead and start.
Thank you. With this, we come to our next interesting session on cornea in the midterm MOS 2026. And I would like to invite our chairperson, Dr. Nikhil Gokhale sir, to please join us. Also welcome moderator, Dr. Swapnil Bhalekar and myself. We have our expert panel, Dr. Swapnil, Dr. Prabhat Nanjia, Dr. Sapna Kini from Mumbai, Dr. Mitesh Jain from Mumbai, and Dr. Shadab Khan from Nagpur. So, and speakers are, we'll first start with Pratima. She is already there. So, Pratima is a cornea specialist, has done her education from LBPI, and she is practicing in Nagpur. Over to you, Pratima. You can share your screen.
So, good afternoon, everyone. Just a second, I'm just trying to share. So I suppose my slides are visible and I'm audible clearly.
Yes.
Okay. So good afternoon, everyone. My name is Dr. Pratima Vishwakarma, and today I will be discussing on why we shouldn't guess the germs and why every corneal ulcer needs a scraping. So this is what we need to understand, that scraping and sometimes even repeat scraping is required in almost all cases of microbial keratitis. So, if a patient like this, a 48-year-old gentleman, comes to you with a history of vegetative matter, with who is already on antifungals since 45 days, on treatment with natamycin and oral ketoconazole, and the prior smears clearly show that there were fungal filaments, there is growth of culture, fungal filaments on culture, and you know for sure that the infection was responding but has worsened, then what will you do seeing this kind of clinical picture? It has now almost involved the limbus, it is a large ulcer. So, would you like to continue the same medications and wait and watch because this is the first presentation with you? Then, would you like to augment the antifungals? Would you like to add on voriconazole? Or would you like to start antibiotics along with antifungals? Or since you know that this is a definitive worsening, would you like to go for a therapeutic penetrating keratoplasty or just do a repeat scraping? So luckily for me, this was the picture which I had seen. This was my patient. I knew that this was the first picture with which the patient had presented to me. I knew that this is a dematiaceous fungus, and all of you seeing this picture know that. And so I did a repeat means corneal scraping for this patient, and there were plenty of fungal filaments. There was no growth, but we all know that this is dematiaceous fungus. And so I started this patient on natamycin hourly, atropine 3 times per day. Ketoconazole was also started. Debridement was done, and this patient was doing quite well, as you can see in this clinical picture. And I was following this patient weekly. But at 4 weeks of follow-up, this was the clinical picture which I had shown earlier. So was there an issue with the compliance, or there was resistance, or was it a secondary infection? That was my thought process. So I did a repeat corneal scraping, and to my wonder, what I could see that there were no fungal filaments at all in any of the smear samples. I had sent separate samples to the microbiologist also, and she also could not find any of the any fungal filaments in any of the samples. So I started moxifloxacin, and within 1 day there was a growth of pseudomonas in the corneal culture sample, which was sensitive to almost all antibiotics. So I started this patient on tobramycin also for the sake that there was slight amount of melting at 4 days. I did a TABCL also. And as you can see, slowly this patient improved quite well. And at 1 month of follow-up, this was the clinical picture with a good amount of scarring, means and the infiltrate had completely resolved, and now we could see the anterior chamber structures also. And so this is pretty good compared to the clinical picture we had seen earlier. So had we gone for a therapeutic PK at this moment of time, we would have rushed into it actually. So what we need to do is that we need to scrape each and every patient. So coming to this, let's see a little bit of few more examples. So I'll just show the photographs of few more patients. In this patient was being on treatment with antifungals, and based on clinical judgment. And when this patient presented to me, I had some amount of doubt. So I did a repeat scraping for this patient, and I could see that there were nocardia filaments. And now this patient is on amikacin, and the infiltrate has completely resolved. Here in this picture, we can see that there is like a good amount of corneal edema, corneal sensations were less, and anyone would think that this is a viral keratitis. But since you can see there is some amount of dryness over here, so looking at the dry looking picture, I did a corneal scraping and could find fungal filaments. This is my own scraping, my own sampling, and I have only visualized this on my own microscope. So this is what I could see in my own clinic. So now this is another patient, which was a known case of pseudomonas, was on being treated with amikacin for pseudomonas endophthalmitis, and later on he developed this small ulcer. So he was still being treated with amikacin for the reasons that the ulcer had developed in a known case of Pseudomonas. And upon scraping, I could see that there were these small yeast with pseudohyphae. So now I have started this patient on amphotericin B, and she is doing quite well. So, with this, I can safely conclude that in all cases of microbial keratitis, we should not forget the simple protocol that scraping should be done in all cases. If you see that there is improvement, and now after some amount of time there is some worsening, then do a repeat scrape. If there is no visible fungi in the repeat scrape sample, then consider secondary infection and add antibiotics accordingly, and always avoid the urge to do a TPK whenever you see worsening, and look for the cause of it first. So, thank you. With this, I conclude my presentation.
Thank you, Pratima. Thank you very much for a wonderful presentation. I invite Dr. Swapnil Bhalikar sir and Dr. Nikhil Gokhale sir for their expert opinions, 2 minutes each.
That was
Swapnil, you go ahead because I just joined just now. So,
okay, sir.
But
Okay.
I thought it starts at 12, but maybe you just started dot time. Very good.
So, excellent presentation, Pratima. And the message is quite straight that every ophthalmologist who is seeing the corneal ulcer patient either should equip himself with some kind of, either he should be able to do gram KOH as a microbiology workup, or he should be able to, have the microbiology support maybe in-house or somewhere. Without that, I think treating any ulcer empirically has many problems. Like when we see patients who are treated initially, most of them present with toxica medicamentosa, they have severely congested eyes, even the corneal picture is very different. And once it starts worsening, it's very difficult to treat those patients. So the message is quite straight that every ulcer should be scraped and subjected to microbiology. Even if we are sure that this is fungus or this is bacterial, it's always better to scrape it to avoid further problems. And in case I feel if some ophthalmologist doesn't have the access to microbiology and still wants to start the treatment, if you start the treatment on third day in 48 to 72 hours, if you feel that the ulcer is worsening, please refer the patient where microbiology support is available. I think that's the crux of the talk. And thank you for the wonderful cases.
Thank you. So, yeah.
Yes, sir. Yes, sir. Please.
No, just wanted your opinion for the house. Most often than not, it comes out to be no growth. But what blankly should you start? You saw a pure white cornea. It's a contact lens patient. Most likely it could be whatever that you wish to think of. But would you put fortified gentamicin? What would you start with even before you get your culture report?
You mean to say if you see the ulcer for the first time, which appears clinically bacterial? So your question, let me frame it in a right way. Do you mean to say that what would be the choice of drug for empirical treatment of bacterial keratitis?
Yeah, in case two reasons. One, the patient has come late to you, and or he had been treated partly somewhere, and or places where there is no microbiology support available. Let's be practical. What is it that you would give? Would you give fortified gentamicin? What would you start with all the coverage that you have?
See, so gentamicin will come when you are thinking about the gram-negative infections, right? So initially, if I feel that if it's a clinically fungal ulcer, it makes sense clinically. If it makes, because fungal would be completely different clinically. So if it's fungal ulcer, then you have to start on 1 or 2 drug therapy, maybe natamycin or voriconazole. If you feel that it's a bacterial infection, even moxifloxacin or gatifloxacin makes sense. Further than that, if you in 48 to 72 hours, if you feel that the ulcer is worsening, then I think it's best to scrape the ulcer, get the etiology in hand, and then do the targeted therapy than going ahead with maybe fortified medications or gentamicin or whatever. Because more addition of drugs will increase the toxicity and the picture will become worse. Maybe Dr. Nikhil would be able to comment more on this.
Yeah, so Dr. Himanshu, I think we have to see some things, parameters. For example, what is the size of the ulcer? Is it a peripheral or central? So if it's a big ulcer, say an aggressive looking ulcer, and what is the progression rate? Like somebody, like you said, contact lens within 48 hours may become a total ulcer. So something which is very progressive, or it's a indolent or a slow grade progressing ulcer. So, and then what is the previous treatment? For example, the patient is already putting moxie drops given by a previous ophthalmologist and has come to you and is not getting better. Then basically we need to do a very broad judgment whether you're looking at possibly bacterial or fungal. If you're not sure, it's best to start at least the antibiotics. If they're already on fluoroquinolones, we know there is significant resistance. You could consider giving, say, a fortified combination of drops for gram positive and negative, and then watch them.
Nikhil.
So so cefazolin we don't get nowadays. So for gram positive, either we give cefuroxime or we give vancomycin, which will practically cover all types of gram positive organism. And for gram negative, you can give fortified tobramycin or fortified gentamicin, like this. So something like that. If it's an aggressive ulcer, if it's rapidly progressing ulcer, if it's a central ulcer and you suspect that it could be bacterial and it has not responded to moxie or toba or just normal drops, and then if the ulcer is still not improving on antibiotic, and then basically we need to rule out a fungus by at least doing some sort of scrape. I would say that a smear test is more reliable than a culture test, because, and of course, we need to have a microbiologist who has some interest in seeing those slides, because sometimes we send it to small places where some technician sees it casually and then it is very often reported negative. So in fact, I
Scanty
think what we
sample.
need to do, all of us together, is that try to send to a common center, at least in every suburb or every zone, so that that person gets at least few samples every month, so he's interested.
So we could do that one, Nikhil. And would you also tell, for the benefit of the crowd, you would preserve it in what? You would send the culture with what? Is it just a swab, dried swab? Would you want to put it in saline?
So
Yes.
no, if I need to do a culture in my clinic, I ask the patient to get all the plates from the microbiology lab, and then I scrape and directly plate it on the lab in the clinic, and on the way back home they give the plates back to the lab, because if we take a transport medium or a swab, it usually invariably will be negative. So we need to do direct plating in the clinic. Only thing, they have to go to and fro to the lab to collect the plates and send them back. If I have to do just the smear test, for example, which is very simple, which I do very often, just to distinguish the fungus or just to confirm the fungus because of medical legal reasons as well today. So in that case, I just have glass slides in my clinic, a box of glass slides. I put the material on the glass slide, put two slides
With
one over
KOH.
the other, and send it within half an hour to the lab, and they would do whatever it smears, grams, KOH, and that works very well actually.
That's right. So these were just practical tips. What can be done?
Yes.
We could
Right.
sit and earmark a couple of them and have a good rapport with a few pathologists, as you said, microbiologists.
Yeah.
We'll talk on that. And if we can earmark, it'll help them and our own fraternity. Thanks very much,
Sure.
Swapnil. Thank you.
Right. Thank you.
Thank you, everyone. I now welcome Dr. Prabhat Nanjia's expert panel and request Dr. Hita Bhagwat from Akola to please go ahead with her presentation on surgical induced necrotizing scleritis management case presentation. I request everyone to restrict to the time.
Is my PowerPoint visible?
Yes, madam. Please go ahead.
Okay. A very good afternoon to everyone. I hope I am audible and my PowerPoint presentation is visible to everyone. First of all, I would like to thank MOS for giving me this opportunity. And I'll be presenting few cases of surgically induced necrotizing scleritis. And due to time constraints, I'll be specifically mentioning only the relevant points here. Coming to case one, it was a patient in whom pterygium surgery was performed 5 weeks back, and MMC and cautery was used in this case. The primary operating surgeon did a regraft again 1 week back, and when the patient presented to me, he had severe scleral ischemia with remnant melting graft. The superior and inferior conjunctival donor areas were noted, and the inferior donor area from which regraft was taken, it was still healing and had an epi defect. I started with the medical management of oral and topical steroids along with doxy, and the patient was reviewed after 1 week, at which time, no, I didn't see much improvement, and I went ahead with surgical management. I did a tenoplasty for this patient and then did an EMT over it. VCL was placed and tarsorrhaphy was done. 4 weeks post-op, actually, I had to remove the tarsorrhaphy as it had loosened. And when I saw the patient was resolving well. Coming to case 2, again, there was a recurrent pterygium surgery which was done 4 weeks back along with MMC and cautery. And again, the primary surgeon had tried a regraft 1 week back. But when the patient presented to me, she had severe scleral ischemia with thinning and conjunctival fibrosis medially. Sorry, this pic is post-staining and not very clear. It's not showing the thinning properly. The superior and inferior conjunctival donor areas were also noted. And in this area, you can see slightly that thinning, which is, in the shadows. Again, I started with the medical management of oral and topical steroids along with doxy and reviewed her after 1 week, at which time I found that the thinning was slightly progressing. So I went ahead with a lamellar scleral patch graft for this patient and did a tenoplasty over her. But after doing tenoplasty, actually, I observed that the conjunctiva, which was looking a bit fibrosed at the beginning, I could actually free it a bit. And so I did an additional conjunctival covering over it and secured it with glue and sutures. Did a BCL and did a tarsorrhaphy also for this patient. And at 6 weeks post-op, the patient was resolving very well. Now, coming to the third case, again, this was a pterygium surgery which was done for a recurrent pterygium 5 weeks back. And in this case also, the primary surgeon had used MMC and cautery. And when she presented to me, there was a scleral melt with a focal thinning. Medical management was again given, but since she was going out of town for after a week or so, I reassessed her after 3 days and decided to go ahead with surgical management. Again, did a lamellar patch graft for her and conjunctival covering secured with glue and sutures. BCL was placed and tarsorrhaphy was done. But this gave different results. Patient was doing well at 1 week post-op, but 3 weeks post-op, the overlying scleral patch graft melted focally and surrounding area showed a lot of inflammation. So I pumped up IV methylpred 500 mg to her and increased the oral steroids and started topical steroids at a higher frequency and then reduced it. 6 weeks post-op, that focal area of thinning showed improvement and vascularization, and 7 weeks post-op, the epithelium was healed well, though the area is slightly thinned out still. So take-home message from these cases is that one should avoid excessive scleral bed cautery, especially in pterygium surgeries, and should use MMC with caution. Surgical management has to be customized as per each case instance, and optimal medical management should be given first to control the inflammation. And sometimes we need to accept that biology is not mathematics. My teacher always used to say this, as is evident from the next case, which is out for discussion. This patient is again of necrotizing scleritis post-pterygium surgery 4 weeks, presented to me with severe scleral ischemia and thinning. Cornea is also involved near the limbus. I started him on high-dose oral steroids, topical steroids, and the patient was lost to follow. He presented 1 month later to the primary operating surgeon with this clinical picture. So there is vascularization, healing definitely, but a small area of thinning is still present. At this stage, I had restarted him on 60 mg oral steroids and advised tapering properly along with topical steroids. So I would like the panelists and experts here to discuss, is this the right line of management or should I go ahead with anything more at this stage? Also, since this sclerosing necrotizing scleritis, this involves multiple types of management, I would also post few questions which can be discussed here as we are having expert panelists here. So my first questions, I'll be sharing all these here, that at the time of presentation, when the patient presents initially, does IV steroids and peribulbar steroids have any role? And how long is the optimal waiting period for medical management before intervening surgically? As for my third case, I intervened on day 3. So was it early, which led to that focal melt of the scleral patch graft? And if already the patient has undergone regraft, can we trust the newly healed superior conjunctiva to support a pedicle graft? I mean, the conjunctiva has already been harvested from superior area and inferior area. So can we try a pedicle graft in such cases? Also, the fourth one, which gives better results, a conjunctival pedicle graft or tenoplasty? I think we can discuss these questions as we have many experts in this field here with us today. Thank you so much.
Thank you, Dr. Heta. I thought panelists will ask you a question, but you have made panelists' life difficult anyway. Up to them. Dr. Prabhat, please start.
Very nice.
You can keep the last slide there if I thought you want.
Yeah,
Question
yes, sir,
slide.
yes.
Very
Yes,
nice,
yes.
difficult cases that Madam has showed. Though, one interesting point that I would like to add before we go to her questions is that the first case was a primary pterygium where mitomycin was used. So in a
Yes.
6-year-old, in a primary pterygium, mitomycin usage is not really indicated. If you have a recurrent pterygium, then definitely it is indicated. It is known to reduce further recurrences and reduce the fibrotic component. But in a primary pterygium in a middle-aged or elderly gentleman, it's not really indicated, particularly for nasal pterygiums. The second point, before we go to Madam's questions, is that once mitomycin is used in the low concentration of 0.02 or 0.04%, it must be washed with at least 50, maybe even 100 ml of normal saline, because the wash is really important. And regarding the excess cautery that also she has mentioned in a couple of cases, it is important to identify only the active bleeders on the scleral bed and cauterize only the active bleeders. So these are the points that may help prevent these particular scenarios. Now, regarding the questions that Madam has rightly put forth, IV steroid is certainly indicated as first-line pulse therapy for these patients to reduce the fibrotic, sclerotic, and necrotic components. Peribarbital steroids not very well mentioned in literature, but can consider on a case-to-case basis. One of the main problems is that it, particularly the use of a subtenon, can worsen the thinning. So there you have to be quite cautious. So if the patient's systemic status allows, prefer IV steroids over peribulbar. There is no particular optimum waiting period for medical management, but start with the medical management that she has rightly given: oral steroids, oral doxycycline, topical medication, and IV, as we just mentioned. If the thinning is very severe and uveal exposure is imminent or already present, then early patch grafting must be performed with additional procedures that we will discuss. In case 1 and 2, the regraft was already done using the inferior conjunctiva. So can we trust the newly healed superior conjunctiva to support a pedicle graft? One of the problems with where we have already harvested a graft is that some amount of fibrosis will set in there. So to redissect that and to move it into that, nasal sclera, that is a little bit difficult, and there may be some amount of cheese wiring, because even if we take the thinnest possible graft, some amount of scarring is induced in the donor site area. And we will have to cover a much larger distance from the superior to the nasal quadrant. In addition, the pedicle graft does not provide as much vascularization as the tenons from the same nasal site. So if the tenons can be easily harvested as a flap, the tenons is preferable, and it also brings in more vascularization. Otherwise, some cases with mild to moderate scleral ischemia and defect, you can consider the healed superior conjunctiva to support a pedicle graft, provided that the conjunctiva is mobile so that it allows easy dissection. So for that, you can just use a bud and move the superior conjunctiva like that. If it is moving, then you can consider that pedicle graft. And between conjunctival pedicle graft and tenonplasty works very well for moderate to even large areas of ischemia. It is important to understand that while the primary surgeon had done the inferior conjunctiva, used it as a regraft, if the scleral bed is ischemic and does not have vessels, the regraft is not going to work. So the most important goal of surgery at this point is first to achieve vascularization, reduce the ischemic component. And for severe cases, the tenonplasty is arguably the best thing. For mild to moderate cases, whichever suits the surgeon preference out of these two can be performed.
Thank you, Dr. Prabhat. Nikhil sir, you want to add anything? We switch to.
Yeah, so when we get a melt like this after pterygium surgery, we need to consider three possible etiologies. One is possible ischemia, which is the most common, I think, where there is excessive cautery which has been done, or you have left a bare area. The second could be there could be maybe mitomycin C. Third could be there is possibility of infection, which needs to be ruled out in all the cases. And the fourth could be an immune mediated inflammation. I think the sort of cases that we are seeing here are more related to ischemia and the graft maybe not surviving there. So I wouldn't label these cases directly as surgically induced necrotizing scleritis, because that's a very different entity which is seen when there is very often 70 to 80% of these patients will have a systemic collagen vascular disease. It will come after, if it can come after pterygium surgery. I have reported one case in journal, and if there the scleritis will involve the other quadrants beyond the pterygium area as well. So if it's a SINS, it's a generalized scleritis where you might get nodular scleritis, scleral thinning, which will be there in all the quadrants or other quadrants as well. So that can help us to know whether it is a SINS or it is basically a local pathology either due to ischemia or infection or whatever. Before we give oral steroid, be 100% sure that there is no fungus or no other pseudomonas on the scleral bed, because if there is an infection and we give steroid, then that's the end of the eye. So these are some important points to keep in mind. So I would basically label these cases more as possibly maybe ischemic sort of pathologies, or maybe the related to maybe mitomycin, as she said, in some cases, and wouldn't typically label them as SINS, because SINS will need systemic immunosuppression. They will also need a systemic workup for collagen vascular disease, which needs to be done to be able to identify if there is a systemic cause. So they are little different and they behave a little differently. They can come after any surgery, and they can come from a few days to up to 20 to 40 years after a surgery as well. So it's a little different entity, which I would possibly reserve my label for certain different difficult cases. Thank you.
Thank you, sir. Thank you, everyone. I now invite expert panel Dr. Sapna Kini to this session. And I invite Dr. Neha Rathi from Nagpur for her clinical presentation on managing OSSL. Dr. Neha?
Yes, sir. Am I audible, sir?
Yes.
Yeah. Okay. Just a minute.
Share your presentation. We request everyone to keep discussion time to 3 minutes.
Is my screen visible?
Multi-panel is visible.
Is it visible now?
Yes, yes. You can enlarge it in.
Just a minute.
I also request Dr. Pooja to be ready with the presentation.
Okay. So it's visible, sir, right? Yeah. So at the good afternoon, everyone. At the outset, I would like to thank Dr. Saurabh sir for giving me this opportunity to speak on this case, especially not only just for the cornea surgeons, but more for the non-cornea surgeons who can very effectively manage OSSN cases if they follow particular guidelines. So a 64-year-old male came with complaint of burning sensation in left eye since 5 days. The visual acuity in the right eye was 660, not improving, and in the left eye was 636, improving to 624. The slit lamp examination showed normal conjunctiva in the right eye, and the left eye showed temporal papillomatous lesion of around 4 by 4 mm size involving 2 clock hours of the limbus from 2 o'clock to 4 o'clock. The cornea was clear in the right eye. The left eye cornea showed lesion encroaching towards the temporal area. Rest of the anterior segment was normal. Patient was operated for cataract, having PCL in both eyes. Patient posterior segment showed lasered PDR, dull FR, pale disc, and ERM, which explains the vision. This was a slit lamp photo. So morphologically itself, with the dirty white lesion, sentinel vessels, leukoplakic component, papillomatous lesion, we can diagnose many cases on slit lamp itself, but there are many cases also which cannot be diagnosed on slit lamp. Coming to more in-depth for the diagnosis, vital dyes like lissamine green stain, rose bengal stain gives a very good negative predictive value. So it can actually show you the difference in the neoplastic and non-neoplastic cells, showing the extent of the lesion which is not even visible to the naked eye, which helps more during the excision, during the surgery. Another modality, that is ASOCT, has been very popular now because it gives excellent depth of the tumor. It shows if there is any stromal or corneal invasion, the differentiation of the normal to abnormal tissue, and helps a lot for proceeding for the surgery. Having said that, histopathologically is still the definitive and the gold standard for the diagnosis. This was the ASOCT of the patient. As you can see, mostly it was restricted to the epithelial part of the conjunctiva, had no scleral or corneal invasion as such. This is the closer look of the ASOCT. So the patient was then proceeded for excision biopsy of no-touch technique, which is the gold standard, and a conjunctival autograft in the primary sitting itself, and prophylaxis to prevent any recurrence. Topical chemotherapy cycles was started post-operatively. So I don't have the video of the same patient. This is the similar case. After localizing the tumor, first start marking around 3 to 4 mm size from the tumor all around. Then holding only the conjunctival frill. Do not touch the tumor at all because that will cause the seeding. Start excising the tumor along the sides. Mind you, it will bleed a lot, and it's better than wise to keep a cautery as in all aspects. The original case was bleeding so much that I was hardly able to see the tumor during the excision. So cautery would help you a lot. After excising the whole of the margins, then you can proceed for the base of the tumor. For the corneal part, again measure around 4 mm from the lesion to the cornea. Absolute alcohol works amazingly well. You can put that absolute alcohol on the cornea for around 45 seconds to 1 minute, allow it, and then start scraping with the crescent blade. You can even use mitomycin C, but absolute alcohol works brilliantly well. It has guarantee that all those neoplastic cells are removed. Start scraping from the center to the towards the lesion, and then just wash it off. For the base of the tumor, if you feel that there is any scleral or any corneal involvement, better to go ahead for a superficial sclerectomy or a superficial keratectomy as well. After the excision of the lesion, place it on a filter paper exactly on the location where it is on the eye, and you can then send it for the histopathology. Or in the same patient, I have done the primary conjunctival autograft. Now, why more so? Because it gives brilliantly amazing cosmetic result. Earlier, what it used to be done was that we used to first excise and wait for 3 months, and then if there is no recurrence, then do a conjunctival autograft. But now in the primary sitting itself, you can do a conjunctival autograft. Having said that, for this lesion itself, if it is a very huge lesion, amniotic membrane graft would be a better choice, no doubt in it. And then the procedure remains the same. You just put a fibrin glue and the graft is placed as you do for a pterygium surgery. Coming to the chemotherapy, this is the main idea why I'm precising more on this is mitomycin C, 5-fluorouracil have worked brilliantly well for decades now. Mitomycin C has a little bit more of this side effects like topical hyperemia, punctal stenosis. 5-fluorouracil has a little bit less of it. Mitomycin C 0.02 or 0.04%, both will work 4 times in a day, 4 weeks, 2 weeks off, and 4 cycles can be given, which is the Santosh Honavar's protocol. 5-fluorouracil you can give for 1 week, then keep it for 3 weeks off. Both are equally comparable. Both have multiple studies being done. They are equally comparable. Now, after the introduction of interferon alpha 2b, the prophylaxis for chemotherapy has become more acceptable for the patient. This drug works brilliantly well. Patient has hardly any side effects. In such large cases, you can even do interferon alpha pre-operatively, perilesional first with topical to reduce it to the resection size, then go intraoperatively. You can even apply perilesional there also, and then post-operatively prophylaxis can be given of interferon alpha. This beautiful drug is generally what I have seen every time it was available for me. 3 million international unit, 0.5 ml. You have to actually prepare it to 1 million international unit per ml. Just add 5.5.
Dr.
Yes, sir.
Neha,
Just
you've already,
summarize.
Dr. Neha,
yeah,
please
yes.
summarize. You've
Yeah,
already
yeah,
shown
just
that.
a minute. I am just finishing, sir. To just add 5.5 ml of the lubricant, you will get that, and just give it for 4 times in a day, 4 to 6 cycles, depending upon the lesion. It is extremely safe. Even cost comparatively, interferon alpha, much acceptable, 900 rupees. It will be acceptable even for the post-cataract patient gives for that much money. So patient has never declined for the cost aspect. This was the histopath report, had moderate dysplasia, and this was the post-op 6 months. Patient did very well. Thank you.
I invite Dr. Sapna to please share her expert opinion. Dr. Sapna, your mic is not on.
Sorry. Good afternoon, everyone. Thank you, Moscon, for this opportunity, and thank you, Dr. Neha, for a wonderful presentation. So, as the OSSN is one of the most common benign tumors that we see on the ocular surface, so it was a good presentation. And basically, the important points that we want to know is basically nowadays, as we all know, that histopathology was the gold standard, and for the treatment and diagnosis, excision biopsy was the gold standard. But nowadays, with ASOCT coming in, we also have scope for chemotherapy directly if we have our staining and OCT and clinical suspicion together.
Definitely.
We can even go for directly chemotherapy. And as you have wonderfully explained all the three agents, amongst that, considering the availability, cost, and balancing the toxicity in our setup, we find 5-fluorouracil very much useful. Would like to know others' opinions as well. And for the bleeding part in your surgery, what we do is we use brimonidine pre-operatively, 1 drop.
Yeah.
That also helps in reducing the bleeding.
Yeah. But generally, it bleeds so much, ma'am. Even if given a brimonidine, it will bleed. You will not suspect it before, but while doing surgery, you will feel that, oh, this is now out of going a little, and you have to have that cautery with you.
Yeah.
So,
and one more point which you mentioned, that while sending for excision biopsy, you have to place it on the Whatman paper and mark the sites, so that you know that you have a tumor-free margin, and post-operatively whether you need to give chemotherapeutic agents if the margins are still not tumor-free. So these are the basic points, I think. If anybody wants to add anything else.
I think double freeze. Double freeze through cryotherapy should always be done. We have significant data to prove that that reduces the recurrence rate after surgery. And technically, this chemotherapy is indicated if the base is positive or if the margins of excised lesion are positive. So otherwise, you may or may not give. But cryotherapy is essential. I think we must add it to our surgical regimen if we want to treat them surgically. Otherwise, localized cases where there is no deeper involvement of episclera or sclera, I think just giving 5-fluorouracil alone might work extremely well. It is about 1,000 times cheaper than surgical treatment and does not risk that you will spread the tumor, because sometimes when you're doing surgery, you might, by irrigation, by oozing the tissue, the cells might disperse into the tissues around the eye. So I've had patients who had to eventually undergo exentration because they had multiple surgeries done by somebody and the tumor had spread entirely into the orbit. So I wouldn't recommend general ophthalmologists doing surgical excision. You can try medical treatment. Otherwise, if surgery is required, send them to a specialist who can possibly do it the right way. Thank you.
Sir, just a question. Have you ever tried, sir, only in these cases, only topical chemotherapy in the beginning, primary treatment?
Yeah, so I think now I haven't done surgery for a pretty long time. I only use topical chemotherapy, and of course, patients who have very aggressive tumor, I don't do exentration or those type of things, scleral plaque therapy. If they require those type of treatments, I would have to refer them to a tertiary care center where it's available, because I don't have access to plaque and other things. But otherwise, medical therapy alone works excellent. One problem with interferon alpha 2b is that it's no more available freely. It requires refrigeration, and the cost of treatment is about 800 rupees per injection. It works slowly, so it will take 3 months, 6 months of treatment, which is very expensive. One. Number two is that after 3 months, if you realize the patient is not responding to interferon alpha 2b, the tumor may have progressed. So we need to use it with a little bit of this caveat in mind, although I know that most surgeons in most institutes prefer IFN alpha 2V because it's very non-toxic and very friendly to the ocular surface. But again, availability, cost, and refrigeration are things that, especially in a rural setup, we need to keep in mind, because that's one of the problems. Otherwise, excellent case and nice presentation. Thank you.
So to my surprise, yes, sir, thank you. So to my surprise, interferon alpha was available every time when I prepared for the cycle. Like within an half an hour, I was able to get the injection. That was a acceptable point. That never I was unable to.
Yeah, so you can do a survey among ophthalmologists in
Yeah.
Maharashtra, how much
Yeah.
difficulty they've faced in getting this
Yeah.
medicine,
Maybe
and
that.
maybe then take a call, because sometimes your local of maybe
Yeah.
pharmacist is getting it from somewhere, but most brands are no more available. It's very difficult to get it. Even near
But
Tata Hospital in Bombay, you don't get it. So
okay.
that's the gravity of situation even in Mumbai for us.
Okay. Because I didn't say
Thank you,
anything.
everyone. Because of
Yeah.
time constraint,
Yeah.
we need to switch to some other presentation.
Sir, can I
I
have
now
one
invite
quick
Dr.
question?
Pooja Andhare to please present on carbide blast, more than just a burn. And I request everyone to restrict their talk and
Yes.
discussion vote to within 10 minutes. So 3 minutes each, 3 to 5 minutes each. Dr. Pooja, please share your presentation.
Yes. Yes. Is it visible, sir?
Not yet.
Hello.
Not yet.
Just a minute.
Yes, now it's visible. You can start. You can go on glass mode or full view.
Okay. Is it visible?
Yes, please start.
Okay. Yes, I'm Dr. Pooja Andhare, working as cornea consultant in HV Desai Eye Hospital. Good afternoon, everyone. I'll be discussing about carbide blast, more than just a burn. Last year, we all know it was a social media rage, Instagram challenges, YouTube challenges, from YouTube videos showing how to make these guns at home, which was very dangerous. How does it work? So you put calcium carbide pieces and few water droplets from back valve. It produces calcium hydroxide and acetylene gas. When you press the igniter at the back, it produces a loud noise blast from the front barrel. After few uses, calcium hydroxide particles get accumulated in the front barrel and gun stops working. So many curious people tend to peer through the front barrel and try to ignite the button, which causes very severe ocular injuries. So we have three cases today with us, which we treated in last November, Diwali, October, November. This is case one, 16-year-old boy presented within 24 hours. Irrigation was done outside, so we posted him directly for amniotic membrane grafting. He had near total epithelial defect with corneal burn. Fornices were clear, there were no residual chemical inside the eye. He responded very well after 1 month, and at 5 month post-op recently, he is doing great with BCVA 6.9. He has superior LSCD, but the visual axis is relatively clear. So as of now, I'm not planning any further treatment for him, just observation. This is case 2, which was a 17-year-old boy, very extensive injury. He had necrotic charred tissue along with the calcium hydroxide particles stuck in the cornices, total corneal burn and conjunctival burns. He underwent total debridement of this necrotic tissue with manual removal of calcium particles along with total amniotic membrane grafting, and we kept conformer for 2 weeks after that. It healed very well at 1 month, but there was some superior scleral thinning noted, for which he underwent repeat amniotic membrane grafting at 1 month. At 5 months, he is doing very well. Surface is stable. There is total LSCD, stain negative. Cornices are absolutely clear. For this case, I'll be planning a slit in auto slit in next 1 or 2 months. This is case 3, which was even more severe. He presented at 3 days after injury, 17-year-old boy again. He had total charred necrotic cornices. For him also, I planned similar surgery, AMG debridement, and for him, he had a entropion, cicatricial and early entropion. So, fornix forming suture was also taken. Even he developed superior scleral thinning and early melt in at 1 month post-op. Inferior fornix and limbus was healing very well. He also had non-healing ED. So he again planned tenoplasty along with AMG. At 2 months, he was doing very well, recovering very well. This is 5 month post-op. Inferior fornix absolutely clear. He has superonasal symblepharon with dense pannus, and rest of the fornix is clear. For him, the next step will be symblepharon release with autoslit, and maybe he might require OPK in future. All three cases were started on prednisolone acetate 1% post-op with antibiotic, AGM, plenty of lubricants, and doxycycline. Case 2 and 3 were maintained on steroids, soft steroids, and tacrolimus and lubricants for a longer period. So carbide blast is actually a triple threat. You cannot just look at it as a chemical injury. During your surgery, we have to do the globe exploration to rule out any scleral or corneal tear, foreign body, and if it is embedded, pre-op scan will always help. Ultimately, recognizing this in time and treating accordingly and aggressively is the key point. And patience is another very important point to follow in these treatments. We have to counsel the patient's relatives. These are young boys with thankfully one eye affected. So counseling was very important throughout the treatment of this patient. Thank you.
I now invite Dr. Mitesh Jain from Mumbai for his expert opinion.
Yeah. Hi, Saurabh. It's a good presentation. Can you hear me?
Yes, loud and clear.
Yeah. So, Pooja, nice cases. Just couple of things. Immediately, any post-chemical injury, first, as you said, continuous irrigation was done nicely. Second thing is to start topical prednisolone immediately post irrigation. Lot of times we are the second or the third source where the patient comes for a checkup. So the primary person needs to start topical steroid. In your second case, where you have shown that vision is improved to 624 and there is pannus, one more treatment modality can be tried is the scleral lenses. They can also help improving the vision of the patient, and maybe the surgery can be delayed for a little time.
The trial was given, but because of the financial restraint, and it is not possible.
Yes. One more, the third case where you have shown that the patient has developed a simpliferon with a total LSCD. It is better to have two-stage procedure. One separate simpliferon surgery, get the phonetics form, and then on a second stage, I think doing a slit would be better than doing combining both at the same time. Otherwise, nice, yeah, nice presentations, and you can see that they're all carbide injuries are all grade 4 to 6 and require immediate surgical intervention in the form of amniotic membrane graft, removing all the injury, whatever calcium carbide particles in the from the phonics. Very important to remove all of them.
Yes, sir.
Yeah. Yeah.
Quick comment,
Anything else?
Yeah, Mitesh.
Yeah.
Mitesh,
Swapnil,
go ahead.
anything you want to? No, Swapnil, you want to add anything?
Yeah, so yes, carbide injury, as Mitesh also mentioned, that they are very severe injuries. 2 points I would like to add on that. In these cases, whatever you plan, you do AMG, tenonplasty, or whatever you do, please don't forget to do tarsorrhaphy in this patient, because tarsorrhaphy is like the most important thing which you can do for the surface to heal, because these are extremely severe injuries. And second, what happens is very often in these patients, we are more focused on the surface all the time, surface healing, limbal stem cell deficiency, simpliferon, but we never, check the pressure digitally at least. Because these patients very typically, what my experience in last 15 years, I've seen many of such patients treated, they land up with very advanced glaucoma. So right from beginning, you have to keep watch on the pressure, because after 1 to 2 months, usually the pressure starts increasing. Plus, we keep on giving steroids. So usually we sometimes save the surface, but we have already lost the optic nerve. So it's always better to keep watch on the surface, keep on taking the digital pressure, and at any moment, if you feel that the pressure is high and it is not responding to the topical medications, it's best to go for tubes in these patients even before the surface intervention. And tube can be done even if you have slight visibility. That's not the problem.
I just need to add one thing, my personal experience. Like what these are the cases who generally have I will say long, they need a very long follow-ups, multiple stage treatments, and obviously money matters will be coming here. So what happens is many times these patients are lost to follow for even a private corneal surgeon, forget a general ophthalmologist. So request take home message to all the ophthalmologists in private is have a good rapport with somebody working in institute, because these are the cases who generally need multiple stage treatments, and because of economic and financial matters they may be lost to follow up if we are not providing them that. And obviously money will the surgery will take a charge in private, so if we refer them to some institute for some scheme or something like that, we will at least save the patient's eye. So
only one question. Should tenoplasty be planned in the initial stage itself along with AMG in such very grade 4 cases?
Inflammation will be there, so you can plan in second stage. What Swapnil has already said, like tarsorrhaphy is more important to heal it. It is much cheaper and it will allow time to heal.
No, again, if you see any area of sclera which is ischemic and it's already showing melting, then you can consider doing tenoplasty at the first row.
Yes.
Okay.
Thank you.
Yeah.
Okay, thank you very much. I now invite Dr. Vishwajit Deshmukh and will request Dr. Swapnil Bhalekar and Dr. To take over as expert panel for his case. So Vishwajit, please go ahead with your case on VKC. Is visible, but your audio is not there.
Yeah, are my slides visible and is my voice clearly audible?
Yes, voice can be little more audible if you are near mic.
So good afternoon, everyone. First of all, I would like to thank Mos and Dr. Swapnil Bhalekar for giving me the opportunity to present in this platform. Today, I'll be presenting an interesting and a challenging case which I had overcome during my fellowship in LVPI. So this case highlights how seemingly routine VKC when persistent and uncontrolled can progressively lead to keratoconus and eventually can cause corneal blindness too. So these are the abbreviations used in my presentation. So this was a 6-year-old male from Sambalpur, Odisha, who presented to us in January 2018 with complaints of both eyes intermittent redness and irritation since past 2 months. On examination, his visual acuity was 20/25 in his both the eyes. He had diffuse papillary reaction in upper tarsal conjunctiva with limbal thickening and Horner-Trantas dots, which was suggestive of VKC. His rest all anterior and posterior segment findings were unremarkable. So he was treated with topical olopatadine, low-dose steroids, and topical tacrolimus eye ointment, and was counseled to avoid eye rubbing and to do cool compresses. 6 months later, his cycloplegic refraction was done, and which revealed significant astigmatism in his both eyes. He then again presented to us in September 2019 with similar complaints, where he was advised supratarsal steroid injections, but the parents were unwilling. And now the child was lost to follow up for next 3 years. He presented to us in June 2022 with complaints of sudden diminution of vision in his right eye since past 3 days. His visual acuity in the right eye was finger counting at 1 meter, and on examination there was a cloudy appearance of cornea suggestive of acute corneal hair drops. Examination of the left eye revealed muddy conjunctiva with limbal papillae and Vogt striae. Op scan of the left eye showed advanced keratoconus with thinnest pachymetry of 422 microns and Kmax of 66 diopters. So with this, we arrived to a provisional diagnosis of both eyes VKC, both eyes advanced keratoconus, and right eye corneal hair drops. So here he underwent right eye desmontopexy with C3F8, and in left eye he underwent collagen cross-linking after the control of allergy. So 3 months after right eye hair drops and post left eye collagen cross-linking, his vision in right eye was 2200 and in left eye it was 2060. At this visit, there was exacerbation of VKC in both his eyes, and he was started on topical high potency steroids, tacrolimus eye ointment, and on oral steroids. Again, 3 months later, there was another relapse of VKC, and he was continued on topical steroids, tacrolimus, and oral steroids here. So here, tomography was done in his left eye, which revealed there was progression of keratoconus post-collagen cross-linking. Here, the thinnest pachy was 250 microns, and his Kmax was 85 diopters. He was then again lost to follow-up for a year, and then he presented to us with relapse of VKC in both his eyes. He had limbal hyperplasia with perilimbar Horner-Trantas dots, and here again he was started on topical steroids, oral steroids, and tacrolimus eye ointment. Here the limbal disease resolved with lipid deposition and formation of pseudogerontoxin in both his eyes. So 2 months later, he then presented with acute corneal hair drops in his left eye. And here his parents were not willing for any surgical intervention. So he was started on topical steroids and hypertonic eye drops. So a year later, the density of corneal scar in his both eyes had reduced. His vision improved to 20/40 in the right eye with rigid gas permeable lens, and in left eye 20/25 with Boston scleral sight lenses. And here his eyes were relatively quiet, and he was continued on topical tacrolimus and olopatadine eye drops. So this is the timeline of our patient. He presented to us in 2018 with active VKC. And then in 2022, he developed right eye hair drops for which desmontopexy was done, and in left eye collagen cross-linking was done. In 2023, his keratoconus post-collagen cross-linking had progressed, and he was treated for active VKC in multiple visits. And in 2024, he developed left eye hair drops, which was managed conservatively, and he was continued on anti-allergic medications. So our patient had refractory VKC as there was persistent or worsening of disease activity, and it was not responding to highest possible concentration of available immunosuppressant agents for more than 3 months, and also it was unresponsive to repeated courses of pulse oral steroids. So in VKC we usually follow a stepwise treatment depending on the severity of the disease. Initially, we start with antihistaminics and lubricants, followed by topical steroids and topical immunomodulators in more severe disease. And in the refractory disease, we require pulse oral steroids along with systemic immunomodulators such as oral tacrolimus or oral cyclosporine. So looking back at our case, initiation of oral cyclosporine or tacrolimus would have been helped here to achieve better control of the disease and to prevent further corneal complications. So also in refractory VKC, with the help of allergy specialist, we can even consider biologics after doing serum IgE levels, and we can start subcutaneous omalizumab therapy. I'll skip this slide. So the take-home message from this case is that in recalcitrant or refractory VKC, we need to aggressively control with the help of systemic immunosuppressions. And in pediatric keratoconus, there is very rapid progression, so we need to do timely collagen cross-linking, and even after collagen cross-linking, we need long-term aggressive control of VKC to prevent further corneal complications. With this, I end my presentation and open the case for further discussion. Thank you, everyone.
Thank you, Vishwajit. I invite Dr. Swapnil to give his expert opinion, and followed by that, Nikhil sir to summarize or expert summary. Dr. Swapnil, are you there? Nikhil sir, you want to add something?
No, I think very good case, very good message from this. Basically, we need to understand that one, VKC needs to be adequately managed, which is what you have shown here, and it has progressed. Second is that even if you do cross-linking and the child continues to continue to have inflammation, then it's going to still progress. So doing cross-linking, sometimes we feel everything is over. That's not the situation. And I think counseling is so very important here. And again, compliance to treatment is very important here, and which can only come if we are able to counsel the patient adequately. Otherwise, these patients keep going clinic to clinic, hopping, because no one has explained them that we are just trying to control the disease, and we are not going to cure it, and they will need long-term management. So I think counseling on the first time the patient comes to you is so very important to maintain the compliance, so that they know the realistic expectation, and not that you will do some magic and they will become all right. So I think very good case, very nice presentation. And the only interesting thing, I don't know if has been noted, is like, was there any difference in the way the hydrops behaved in a cross-linked eye? Because normally we have hydrops most often in patients where cross-linking has not been done. So because the stroma may be a little more compact, did it behave differently or look differently, in case you noted something like that?
It looked similar what we usually see, but what literature says that in children there is a very rapid collagen turnover. Even after collagen cross-linking, the collagen will be replaced with the diseased one. So that again there are, like, it is a similar risk of hair drops in children. Basically.
Thank
you. Thank you, everyone.
Yeah, can I just put a point one?
Yeah,
Ishwajit? Yeah, so Ishwajit rightly mentioned the end, systemic immunotherapy and systemic biologics. Subcutaneous omalizumab, systemic cyclosporine at an early stage would have maybe prevented this hydrops in one or both the eyes. So we need to keep this in mind, that even VKC is one of the indication for a systemic immunotherapy.
Yes, sir. There was another issue with this child. He was coming from around 12 hours to our main center in Bhubaneswar. So there were issues with follow-up in this child. So we were not able to manage him adequately there too.
I think you should prefer for long distance patient supratarsal depometrol.
Yes.
Obviously, pressure needs to be checked and kept maintained, but relying total, these are the typical cases where local doctors won't give steroid where it is needed, and they will give other supplements, but steroids do the main role here.
So another point, like recently I had seen a case here in Pandharpur. He was having a recalcitrant VKC, a 13-year-old child. So when I was going to start oral cyclosporin, I just checked his HIV status and all like systemic infection status. So surprisingly, I got HIV positive in that child. So this is another interesting case which I'll see how we can manage collectively with the intensivist.
Nikhil, sir, just one question for you.
Yeah.
What is your expert opinion for removal of the supratarsal raised lesions, complete surgical excision?
So basically, I think doctors from Shankar Nethralaya have published that you can do cobblestone excision if they are extremely refractory and you have recurrent shield ulcers, but you need to combine it with a mucous membrane graft, oral MMG, or an inferior conjunctival graft, because otherwise they tend to have high recurrence rate. If we just give supratarsal, or we do cryotherapy, or we do excision with mitomycin C, these are the other options. There is a high recurrence rate which has been reported in these processes. So you should do an oral MMG with excision. That will work possibly better, because the oral mucosa does not react like the ocular mucosa reacts to allergic agents.
Thank you. Thank you. Just last 1 minute for summary. I just need to ask one more question related to one of the case presentations where they have shown series of scleral melts. So just needed to ask whether all these melts, what was the status of the graft, the primary conjunctival graft taken for pterygium? Was it there or was it not there?
So in the, am I audible, sir?
Yes,
Dr.
yes.
Hita here. Yes, sir. In the first case, sir, the graft was there. It was the regraft, which was done by the primary operating surgeon. That was still there, but it was almost melted. I mean, 50% of the graft was there. So when I was doing the surgery, I had to remove the graft. It was completely avascular and more than 50% had melted off, sir.
And remaining cases?
So remaining cases, remaining second case also, the regraft was done, but there was no graft seen on the bed, sir.
Yeah, because what I've observed is many people have now switched from glue or suture to the glueless blood, like with blood. So if the second day, if they open the eye, third day, second day, whatever, and if they see the graft is hanging or not in position, I will suggest better to immediately stitch it. Because once the graft is gone, the bare sclera itself invites lot of troubles.
So I had discussed this with the primary operating surgeon. So he has said that he had used glue in both the cases, sir. In the primary surgery also, the glue was done. It was not like autologous serum. That blood was not used. He had used glue, it seems. And in the second case also, and in the regraft also, glue was used. So I'm not sure why.
One more thing, Dr. Majesh. MMG's two concentrations are available. One is 2 milligram vial and one is 10 milligram vial. So if we don't look at if you need to check with the primary surgeon, if he's using the standard dilution for a 2 milligram vial in for a 10 milligram, then he would be obviously having 5 times the more concentration and that much more risk.
I think for pterygium, if we are doing with a conjunctival autograft, there is no need of mitomycin at all. Anyway, let's summarize this. Thank you everyone for excellent opinions and presentations. And I now hand over mic to the next session. I invite moderators for the next session to take over. Thank you, Piyush,
very well
for this.
conducted. We missed Swapnil being there because he was thank you, Swapnil. Even though he was there in another CME, he's also joined. All the speakers made relevant points. The panelists and the chairperson added on, contributed so much very good points. The only problem was that you had 4 minutes extra and then 2 minutes of delay. So it's a 6-minute delay. So with that, we move on to the next session, the retina session. We have Dr. Manish Bapai, who's joined us. He's the moderator, and the chairperson, Dr. Paritosh Kamdar. A very warm welcome to you both. Handing it over to you, Dr. Manish.
Yes, good afternoon, everybody. Thank you, Dr. Piyush, for the opportunity to arrange this session. I welcome all the speakers and all the experts. Without any delay, we'll start with first case by Dr. Kshitish Tamboli. He is from Nagar, and he will be presenting a case of intraoperative surprise. And he will be moderated by Dr. Mandar Zogolekar. Dr. Kshitish, please take over.
Yes. So is my screen visible?
Kshitish, your screen is visible, but it's not very clear. Perhaps you can switch off your video because your bandwidth is low.
Okay.
All right, sir. Dr. Kshitish, can you stop share for a minute if you don't mind?
Yeah.
Just click on the share button once. Don't go sharing. Just click on the share button once. You will have something called optimize for videos option on the right hand side. Just uncheck that.
Yeah. Okay.
Now you should be able to share.
Okay.
Much better, sir. If you can just also start your videos just to see that it's balancing. Perfect, sir. Thank you.
At the outset, good afternoon, everyone. Thank you, Dr. Manish Bape, sir, Dr. Piyush Bansal, sir, and Paritosh Kamdar, sir. I'm Dr. Kshitish Tamboli. I'm presenting a case where I surgically managed the unexpected surprise in a patient who had done cataract surgery elsewhere. So this was a 60-year-old male who came as walk-in patient to me. He had done cataract surgery 8 days ago elsewhere. And he came because he had pain in the left eye, in the operated eye, since last night, and there was a diminution of vision. However, he complained that there was very low vision since the cataract surgery was done also. So in the affected eye, the vision was hand movements. There was corneal haze. The AC was completely shallow. Only the IOL reflex seemed to be visible. There was no view of retina. Only the faint glow was seen. I avoided B scan due to the shallow AC and fresh cataract wound. The other eye was fairly normal with cataract in the eye and retina seemed to be normal. So patient is not referred to me. It's a walk-in patient, so I don't know what was there in the surgery. What is the point to be noted is AC was completely shallow. So anything that had to be done in the OT. Patient had to be counseled accordingly. And so the decision was taken to go in OT, and patient was given complete idea of guarded visual prognosis. So my reason of presenting this case is nothing is known before going to OT, neither the anterior segment nor posterior segment. Why is AC shallow? Because maybe the phaco wound was converted into a larger wound, and post-cataract surgery, the AC became flat. Patient has pain maybe because of that same reason, but there were no signs of infection or inflammation. So I was not thinking on terms of endophthalmitis. But what could be the complication that I would manage in the OT? Was it a nucleus drop? What is it? Oil drop? Was it a vitreous hemorrhage? Was retina on? We didn't know anything. So I had to be ready for everything before going into OT. And patient was also told all the same things.
This patient is post-cataract surgery, 8 days operated elsewhere, came with completely AC shallow and severe pain in the eye. after forming the AC, saw with indirect ophthalmoscope that there was some cortical drop and nuclear fragments. To my surprise, there was also foldable IOL, and iris claw was also tucked. The challenge here was how to remove the foldable IOL with iris claw being intact. First tried with MacPherson, but forceps being horizontal could not get a proper grip or hold on the lens. Then tried hooking with the dialer from one side and taking out with forceps from other side, but since the forceps is horizontal, still could not hold it. Then I thought of something which could go vertically downwards in the space between the superior part of iris claw. Then I took Daljit forceps or iris claw forceps which goes vertically downwards. It held the IOL firmly and hence was successfully removed.
Thank you so much.
Dr. Mandar, can you please discuss the case?
Am I audible?
Yes.
Very well managed case, Dr. Kshitij, but I just wanted to add some few things that you mentioned that B scan cannot be done this case, but I think that you should do it on a gentle basis by yourself. Then you should be able to pick up a lot of these differentials that you have mentioned, the suprachoroidal and all can be definitely picked up with this, and even the top nucleus could have been picked up.
Actually,
IOP
I
you
don't
didn't
have
take
it,
by
so I
Goldman.
didn't refer it to someone because that gentleness is required.
Okay, that's true. And IOP needs to be taken by Goldman, so that gives another clue for what could be the causation factor. And you took a good decision to take him immediately and managed it well. In these such cases, always, even if it is a referred case and which the surgeon has told you something has happened, be ready for anything, because there is a tendency from the surgeon's point that to state what has happened in a lesser manner. So always be
Yeah.
ready to have a 10x of what they have
Yes.
you are anticipating, and be ready for your instrumentations. Very
Definitely.
well managed. Yes.
Thank you so much, sir.
Well managed, Kshitij. Paritosh sir, would you choose to tackle this in any other way?
No, I think he's done a good job. The only other thing would be whether one would use a, I missed a little bit of his video, whether he used a phaco fragmenter or whether he chewed it up with the vitrectomy cutter itself. Yeah, so that would have been one variation. One more thing which I would do is that I would also at least try to make sure that most of the vitreous at the posterior pole is chewed up before I start tackling the dropped IOL, and I would cushion the macula with PFCL. Although this was a foldable lens, foldable IOL, so not so dangerous, but still I would cushion that. And the other important thing is that these eyes need to be watched lifelong. I've had the instance of a senior gynecologist who presented with a detachment almost, I think, 7-8 years after the corrective surgery and good vision recovery. So we need to watch these eyes on a long-term basis. But very nicely done.
Right. So,
Thank you so
we
much.
missed that part where you were trying to lift the IOL and then extract it. So did you place it over the IOL? Because we missed that part. There was a lag over this. So did you bring it up and then you placed it over the
No,
iris?
sir. Actually, the thing was, I wanted to keep the iris claw intact because I didn't have the IOL power also. So there was no point of thinking of SFIL and retaking the iris claw. So I found some superior space between the iris claw and iris. So in that space, I put the Daljit forceps, which was going vertically downwards because it wasn't coming up with the McPherson. So I put the Daljit forceps, which was vertically downwards.
Very nice.
Did you
And
put the
another way,
6 mm
another
wound
thing that
or
what you can do in such a situation is, of course, it's just another alternative way. Is in the anterior vitreous itself, if you have a good grip of the IOL, you can use a micro scissor and try to maybe cut the IOL there itself so that the space required to extract it is comparatively less. And I agree with Dr. Paritosh sir when he mentions that you have to induce PED essentially before you're trying to extract the IOL. You don't want any inadvertent traction and then falling into the loop of a retinal detachment happening later on. And of course, if required, using PFCA. So, Dr. Manish, can we move on to the next case?
Yes, please. Let's move on to next case by Dr. Abhindya Purve. Dr. Abhindya is from Chhatrapati Sambhajinagar, and she will be presenting the case of ROP, and Dr. Preetam Samant will be discussing the case. Dr. Abhindya, please take over. Dr. Abhindya, can you hear us? Are you there? Okay,
Yes,
looks
I'm
like
trying to share my screen.
yeah.
Just a sec. Sir, I would request for another speaker. I need to leave the webinar to change the settings.
No
Okay.
problem. You get it
Is Dr.
sorted. We
Is
also have
Dr. Nene here? Is he Dr. Nene here? I can't see his name.
Yes, I'm
Yeah, yeah. Dr. Nene, can you please present your case? Dr. Nene is from Kalyan, and he will be presenting a case of atypical endophthalmitis. And Dr. Jagdish Loya will be discussing the case. Dr. Amit, please take over.
So at the foremost, I would like to thank Mos for giving me this opportunity, and specifically thank you to Dr. Manish sir for giving me this opportunity to present in such esteemed speakers. So I will just jump onto my cases. So these are cases of atypical endophthalmitis. They usually present with a delayed onset, with infections occurring after weeks or months, and with usually mild or absent symptoms. They lack pain, redness, and hypopion also, as seen in acute cases. The most common causes being slow-growing, low-virulence bacteria like Propionibacterium acnes. It can also result as a sustained-release drug implant like dexamethasone implantation. So I'm going to present two cases. Both these cases gave me nightmares. So this was a case of Ozurdex. The patient had come after a week and he was doing perfectly fine. But then after a month, he presented with a quiet eye, but what was there inside just shocked us all. Uh, so in the start, we did a AC wash for the hypopyon present, and the inside, as you can see, had dense exudates present with the Ozurdex implant floating over there. So we started with our vitrectomy, trying to be safe, not to injure that Ozurdex. PVD was induced gradually, and vitrectomy was then completed. So you can see all around the vasculitis which this Ozurdex injection had caused. I made a sclerotomy from the same port, and with the help of forceps got hold of that Ozurdex implant and explanted it outside. So it came out as a single piece, it didn't get fragmented. So note the extensive vasculitis and all the sclerosed blood vessels. So I just crossed my fingers, did a fluidic exchange, gave Vanco, Septa, Dexa, and injected silicone oil. So this is how it looked post-op. We had sent it for gram culture also, KOH mount also, but everything came out to be negative. Now this is the silicone oil removal being done after 2 months. And you can see that most of the sclerosed blood vessels, they have again, means not you can say come back to normal, but they are very well perfused. And the picture looks much better. So this patient did well. The second case was really interesting. So SFIL was done around a year back. And then this came propped up. And the patient came with diminished vision of hand movement. So we took up the patient for surgery. Peritomy was done, and then I flanged that haptic which had exposed. Then again, the 3 ports were made. I cleared off the AC of the hypopyon which was there. The IOL looked stable at the other end. So again, in this case, the blood vessels were all sclerosed. The retina was ischemic. So it was a vitrectomized eye. So I directly did a fluid exchange. I injected again Vancomycin Dexa and filled up the globe with silicone oil. So here, covering that exposed haptic was very important. I dissected the conjunctiva a bit. It was all fibrosed, and then I sutured it up. This patient also did well. So this is a post 2 weeks follow-up, and the vision improved to CF 3 meters. Thank you.
Dr. Jagdish, would you like to
Good
discuss?
afternoon, everyone. Good afternoon. Amit, very well managed cases, both of them. In first case, you didn't get any organism, but what happened in second case? Did you do gram stain for that also?
No, second case we didn't do it.
Yeah, you got away with without doing it. Very well managed cases. I just want to make 1 or 2 points here. In these patients, usually low virulence is there and low grade inflammation is there. For general ophthalmologists, what they do, if patient comes after 1 month after tapering of steroids, they feel that it's a steroid withdrawal and again keep giving steroids 2-3 months, and then patient land up to your table to the VR surgeon with frank end off or low grade end off. So we need to see in these patients, unless and until proven, we should treat it as a infective only in these cases. And in your first case, usually these sclerosed vessels, they usually have bacillus, low-grade bacillus infection. So in those patients, because of your Ozurdex implant, probably didn't show inflammation aggravated. I was quiet because inflammation was not there, but inside in the retina, it had created a much damage compared to outside, wherein you are seeing a quiet eye. That's all very well managed. Anything else, Manish, you can add? Paritosh, sir,
Yeah, Dr.
if you want
Paritosh,
to.
sir, would you like to add something in this end of cases?
Not really, because I was busy trying to contact Dr. Bhavan and Dr. Kelkar. But
Okay. Dr. Kelkar
I
has joined,
only,
is
only,
joining.
uh, only one thing is that I agree with Dr. Loya that antenna for suspicion of end-off should be very high, and it's better to it's better to err on the side of over investigation,
Treating.
over treatment, than to miss it and end up in a mess later on. Because
I know
every time
there
that
are
you delay things, more endotoxins and exotoxins are released into the eye, which temporarily may get controlled if it's a low-grade infection, low virulence infection with steroids. But you're eventually causing more and more damage to the retinal vessels and the retinal cells.
So could you get any microbiological reports in either of the cases? Did you get some
With the
support
first
from
case,
that?
I had sent the sample. It came out to be negative. In the second case, I hadn't sent any.
Okay. This is precisely the reason the risk of exposure of haptic leading to endophthalmitis is something that keeps me, away from doing Yamane technique way frequently. I mean, unless
So
otherwise.
this
I have
was
shifted totally to CMT flex for that reason only.
so this also was done a year back, and it was done by one of our fellows, and they had done a suture, glueless SFIL. They had made a flap and they had tucked that haptic in the scleral pocket, and they didn't flange it. It wasn't a Yamane technique, and I don't know how it came out from beneath that scleral flap.
Oh,
Um, can I request admin support to please help Dr. Aditya Kelkar to join? He is unable to join from the link given.
Manish, can I make a comment here?
Yeah, please go ahead.
Yeah. So I think fantastic cases shown by Dr. Amit. In all these, I mean, these methods, the Yamane's method, blue diols and all are very well established, and they have fantastic results, no doubt. But, like how Dr. Paritosh mentioned earlier for the early days, that even after dealing with dislocated IOL, a lifelong follow-up is required. I think the same goes to say for these cases also, because sometimes these cases could have exposure of the haptic, or even for that matter, sutured SFIL could sometimes cause exposure of a tetropoline. And then those cases have to be followed up very closely, because these kind of exposures can result into infection, endophthalmitis. So the chapter doesn't close, once you do, I mean, a good technique, and once you achieve the desired visual outcome, I think the chapter doesn't close there. Close follow-up in these cases is extremely important. Probably, if you have an exposed proline suture, I would probably want to keep the patient on long-term antibiotic prophylaxis, in these cases, so as to prevent any untoward event later on. So
no,
just keep pins. Thank
without
you.
having any symptoms or without having any signs, do you like to give antibiotics?
It's just an afterthought, Jagdish. Maybe you can, if you're
Okay,
able to observe closely, maybe they may not even require antibiotic prophylaxis.
okay. Manish, I just want to make one more comment. Can I?
Sure.
Yeah.
Yeah.
See, there are many incidences where a patient with low grade endophthalmitis, people label it as a TAS. Even after 3 days, 4 days, 5 days, if patient comes after 7 days also, they say that it's TAS. That is also we need to look into always. and treat it, ask referring surgeon that it is not TAS, it is endophthalmitis. Right.
I think we'll run short of time for eventual cases. Dr. Abhinde, are you on? Can
Yes,
you
sir.
connect?
Yes, I'll just connect, share my screen. So my PPT is visible?
Yes, doctor, please start.
Yes. So at the onset, I would thank Maharashtra Ophthalmology Society and Organizing Committee to give me the opportunity to present. And I would be presenting a case of ROP. A 32-week-old gestational age preterm female infant had presented at 35-week gestational age for sorry. Um, hmm, for general ROP checkup with a birth weight of 1560 gram and NICU stay of 21 days. The baby had had a respiratory distress syndrome and ventilative support was required for 5 days and oxygen therapy for 8 days. There was no other significant NICU history regarding to infection or transfusion. Coming to maternal history, the baby had mother had a type 1 gestational diabetes mellitus and hypothyroidism. No other history was significant. This was the presentation at 35 week, that is 3 weeks after the birth, where we can see that there were multiple dilated veins, there was arterial or tortuosity, and only zone 1 vascularization was present with multiple vascular loop. This was the right eye, and this is the left eye showing similar kind of presentation with multiple hemorrhages also. So diagnosis of bilateral zone 1 aggressive ROP with plus disease with multiple vascular loop was made. The baby was advised injection anti-VEGF. However, they were lost to follow up, and after multiple calls they presented again after 2 weeks. When they presented, this was at 37.1 week corrected gestational age. There were multiple anterior segment neovascularization, and this was the picture 2 weeks before. When they presented again, this was stage 4 AROP, where there was a TRD in the central extending into the macular area with multiple vascularization. This was the left eye, where we can see that there was zone 1 vascularization with multiple vascular loops, and also there was stage in few areas, almost 6 to 8 clock hours, suggesting a hybrid form of the disease. So the diagnosis at again presentation was zone 1 aggressive ROP, both eye with plus disease, with right eye stage 4A ROP and left eye stage 1 to 2 in 6 to 8 clock hours. This patient was advised injection in the left eye and right eye surgery for the same, and left eye injection was given. Right eye, before starting the surgery, we did a laser 360-degree, and this is the video of the same, where 3 standard 25 gauge ports were made. The infusion was connected and IOP was maintained at a lower side. Also, while making the trocar, this silicon band were used to significantly decrease the trocar length. As the size are small and the lens is larger, we have to manipulate our instrument accordingly. Also, the ports are made such that it allows for simultaneous visualization and manipulation. Now coming to the surgery, what we usually do is significant traction surrounding is removed. Now here you can visualize, while removing the anterior posterior traction, there was pull on the membrane and there is bleeding because of the high vascularization. What we did is we just increased the IOP momentarily to 25-30, and that was enough, and again it was lowered to the lower side. Vitrectomy was continued, and a significant vitrectomy anterior posterior and tangentially along the membrane was done, so that surrounding membrane all the vitreous traction is completely removed. Now one of the method how you analyze the traction is completely removed, when you are doing the vitrectomy, the membrane moves along with if there is a traction present. So that is one of the sign how much of the vitrectomy surrounding should be done. I apologize for the brightness of the video. Coming to further, after this is done, there is simultaneously instrument exchange required because we don't want a lens touch in these cases. The lens is larger in size as comparatively, and hence the instrument has changed the cutter from the other side to do the nasal inferior vitrectomy is being done. You can observe the oozing of the bleed is present from the vascularized area. However, still we did not do any diathermy over here. Complete peripheral vitrectomy was done, and at the end of the surgery, because of the oozing, we used diathermy. Fast forward. So this is the diathermy done over the retina area was not diathermy, only the membranes which were present significantly anterior, which was bleeding, was diathermized, and at the end FX was done, and intravitreal anti-VEGF injection was given at the end of the surgery. Ports were removed, and that is the end. Coming to the post-op, this is the post-op this is at treatment, this is post-op surgery 1 week and after 1 month, where the membranes had significantly regressed, and at 1 month no membranes were absolutely seen. This is in the left eye, where the zone 1 regression was observed and the vascularization has improved, and this baby has recently also received laser treatment and is on follow-up. Thank you for the opportunity. So should I stop sharing?
Yeah, great case, Dr. Abindya. Dr. Preetham, you have extensive experience in treating ROP babies with surgical management. Could you please give your comments?
Yeah. I'll just take 20 seconds first to commend Dr. Piyush Bansal on the fantastic online meeting that is organized. I mean, I'm sitting in the comfort of my home, about to have lunch, and I'm enjoying this thoroughly. I don't know, I can't imagine how we used to go to conferences, every week and every month in the past, spend so much energy and resources. So really commendable, Piyush and Manish, for this session. Now, firstly, Abhidnya, you need not apologize for the quality of the video. It's really tough to get videos in ROP surgeries, and your quality of video is fantastic, commendable, in fact. Hats off to you for such a quality of video. I think if you ask me, you've done everything right. I can't imagine of anything which I would have done differently in this case. I mean, it's a lens sparing vitrectomy is the way to go for these cases which have posterior disease, where the disease is entering stage 4 and you have traction on the retina. So along with reducing the vascularity of the disease, you have to reduce the traction. So that is the only way to save the retina from going into a stage 5 retinal detachment, which you don't want. I think you've done a fantastic job here. Yeah, how I would like to ask how many millimeters from the limbus for your sclerotomy is placed?
So usually we place 1.5 to 2 mm from the limbus.
Yeah. Because they here in absolute neonates, 3 weeks and 4 weeks, you have to go as close to the limbus as possible. And there is always a chance that you might injure the zonules, but that is something, is a risk benefit ratio you have to weigh, where you don't mind going close to the zonules in these cases, because you have those instruments that 25 gauge, so they won't really damage the lens and the zonule so much. And the trajectory of the instruments has to be absolutely vertical so that you don't touch the lens. These are some of the things you have to take care when you're doing a lens pairing vitrectomy. But I think you've done a good job. The primary aim is to reduce the anteroposterior traction. You can't really do a total vitrectomy like you do in adults. Here there will be a lot of vitreous cortex still remaining behind in the eye. But once you've reduced the anteroposterior traction, uh, your main objective is achieved. The second objective is to reduce the bleeding, to achieve as much hemostasis as possible. I think also which you did quite nicely. Because what happens is sometimes in these lens pairing vitrectomy, especially when when there is a lot of vascularity, you feel that okay, you've done a good hemostasis, but then post operatively it bleeds. And that blood, when it gets enmeshed with the vitreous cortex, it can itself induce again traction, which is very, very severe. And then, you might have to then again do a resurgery, and then the results are not so good. So achieving hemostasis in such vascular cases where doing a lens sparing vitrectomy is also of cardinal importance. Any other comments I would like to invite from seniors like Dr. Kamdar sir, if he's there, or Dr. Bavankole sir, if he's there.
No, Vikram, I think you covered it up very well. Thank you very much. Only one comment was that this would not be a type 1 gestational diabetes of the mother. The mother was type 1 diabetic, but that's just not exceedingly well managed case. Very well done.
Yeah. Thank you.
I would ask one question. When would we consider, because this was high vascularity present, I considered using injection at the end of the surgery in spite of the membranes being there along with the vascularization. When will you not consider injection, or when we'll consider injection as a supplement, adjunctive, along with surgery?
So shall I take that question?
Yes, please.
Yeah. So I think here, once you know that there is traction on the retina, probably you would not want to inject before, doing a surgery, because then you're worried about the crunch effect. If you're injecting and then there is a considerable interval between the injection and the surgery, you would probably have worsening traction on the posterior pole. So I think your timing was correct. You did a surgery, and at the end of the surgery, to reduce the vascularity later on, you've given an anti-VEGF. Because again, during, let's say if you say, I wouldn't give the anti-VEGF at the time of the surgery, then you're risking that time where, you're relying on your laser to cause to have the vascularity to come down. Now, in that intervening period, if it bleeds again, then it's very difficult to assess also what's going on inside. So I would do the same thing. I would do a lens sparing vitrectomy, do the fluid air exchange, and under air, leave back a little anti-VEGF inside. So both your anti-VEGF and your laser is doing the job of, sort of rectifying the vasculature.
Thank you, sir.
So in interest of time, let's move on to next case. Next, we have Dr. Rahul Tiwari, who is from Nagpur, and he will be presenting his case. Dr. Rahul, please take over.
Yes, sir. Thank you, sir. Is it visible, sir?
No.
Doctor.
Do you have any technical issues? We'll take the next case first.
Dr. Rahul, just click on the share button bottom 6 o'clock and select the entire screen. Just click on the share button bottom.
Yeah.
And just select the entire screen and then go share. Yes. Perfect. Yeah, just select the presentation, sir. Allow and just select the presentation. Perfect, doctor. Thank you. Yes, perfect.
Yeah, thank you. So good afternoon and thank you for having here. I'll be talking about a surgical rematch. So this is a 36-year-old male patient who was having a pathological myopia, and he presented with a total retinal detachment of about 200 degrees with a superior giant retinal tear extending from 7 o'clock to about 2:30 o'clock with foldable retinal flap, and there was a bare choroid, and the pars plana vitrectomy with the help of PFCL was performed. The patient improved to 6/60 at about 1 month, but then presented with the redetachment at about 2 months. And you can see that there is an inferior retinal detachment with the PVR in the lower left diagram. And there was this OCT picture, which shows a thick ectopic inner foveal layer covering the whole of the foveal area with the disrupted retinal layers. And this patient was having almost a myopia of about -17 or -80. So we took the patient to the OT, did the silicone oil removal, and just opened. Then we can see that there is an extensive PVR with the inferior retinal shortening and a stretch hole, and the superior GRT was well settled with secondary ERM on the macula. So brilliant blue was used for the negative staining and double filling in a single block. The adhesion of the ERM to the surface of ILM is a lot stronger in PVR cases. This causes retinal folds. So ILM filling was initiated with pinch and fill technique to raise the flap, and then the ILM you can see that it was coming in the pieces because of the fibrosis over there, and one can see the dense fibrotic nature of this ERM with the poor tissue planes in this case. So at this stage, the excessive traction during the peeling can very easily result in the iatrogenic breaks. And this is the pathological myopia case which lacks the normal elasticity and the structural strength of the macula. So the peeling was performed within a controlled manner and by segment, avoiding a vectoral traction across the foveal area with the gentle circumferential peeling of the ERM was removed first from the foveal area and then gradually peeled circumferentially in the larger surrounding area, and the ILM peeling was then advanced as far as possible. And this doing a large ILM peeling also helps in preventing the recurrence of the epiretinal membrane in these patients. Then peeling was done gently by pulling the band inferiorly, anteriorly to avoid the iatrogenic retinal tear at the posterior edge of this previously laser scars. VR pick was used to gently peel off the membrane and to unfold the retina. But this was very thick and it was very difficult to unfold the retina from there. So a decision to perform a relaxing retinectomy was made, as there was still contracted and shortened residual retinal folds. Intraocular diathermy was applied to the margins of the entire area to be incised to avoid cutting the major blood vessels. This relaxing retinotomy incision were placed with the vitreous cutter with a careful attention to maintain the homeostasis by raising the intraoperative IOP, and it is imperative to perform a liberal retinectomy to the entire fibrous and non-functioning retina to prevent the neovascularization secondary to the ischemia, and to minimize the recurrence of retinal detachment secondary to the reproliferation. A fluidar exchange was then performed, taking care not to damage the choroid. This was followed by endolaser air silicone oil exchange. And this was the post-operative picture at 3 months with much better anatomical outcome. And the patient improved to about 6/36 in this case. Thank you for attention.
Very nice case, Dr. Rahul. Indeed, very challenging. Dr. Aditya is joined. So, Dr. Aditya, could you please discuss, share your experience and your thoughts on this case?
Yeah, it's a very challenging case, very well managed, Dr. Tiwari. You're right in suggesting that the ILM peeling is extremely challenging. Would you consider using PFCL for the counter traction in these cases?
Sir, this can be actually used, but in my hand, I prefer not using it because somehow I feel it is more easier for me to do it without PFCL. But yes, PFCL has advantage because it keeps the retina posteriorly, and it in a way prevents the iatrogenic pulling of the retinal layers leading to the iatrogenic hole. So yes, one can use it.
Dr. Mudit also advocates using glue, or maybe Dr. Naresh Babu has advocated using amniotic membrane graft for these kind of retinotomies. Have you got any experience with this technique?
No, sir.
So whenever you have a large retinotomy like you had near the posterior pole and you want to bridge the gap, you can use an amniotic membrane patch graft there, or a tissue glue also, so that the chances of proliferation again can be reduced. Very well done once again. Thank you. Also, another point is to reach the retina when you have a myopic eye. You may not go usually how you enter with a sclerotomy tangentially and then inside the eye. You can directly introduce the trocar and cannulas. Also, you may shift behind using the light pipe from 4 millimeters to 6 or 7 millimeters also in such myopic eyes, so that you can have easy access to the posterior pole.
Yeah, yes, sir.
You can remove the cannulas and directly go inside.
Yep.
Or put the cannulas little posterior also.
Absolutely. But very well done, Dr. Tiwari.
Thank you, sir.
Dr. Paritosh, you have anything to say? Would you
Yeah,
like to?
no, extremely well managed and very nice comments by all of you. Basically, you can use indirect illumination to find out the ora serrata in these cases, and then you know how much more posterior you can go. And I prefer to use 23 gauge instrumentation in these cases as compared to 25. Just one more variation was I would have used the membrane pick more than what Dr. Tiwari did, and I would try to save as much of the retina as possible. Now, if I have to, if I was compelled to do the retinectomy, I would have probably joined both the breaks together, because in any case, they were, because doing too much of laser very close by probably also is a stimulant for more PVR. One more thing is that in this case, I would have considered putting a drop of triamcinolone at the end. That would help to stabilize the PVR process, because these eyes are prone to recurrent PVR, and that would be a very useful adjunct. One more thing would be to consider use of methotrexate also. If one finds that those fine flimsy membranes are already forming post-op after this surgery also, then it's better to intervene early with methotrexate than later.
Right. So let's move on to our last case. Last speaker is Dr. Harshal Gondale. He is from Nashik, and Dr. Harshal will be presenting his case on malignant glaucoma. Dr. Harshal, please. It's very nice that next session is glaucoma, so probably we can have some inputs from our colleagues from glaucoma also. So Harshal, please take over.
Hello. Can you hear me? Hello.
Yeah.
Yes, sir, you can start.
Yes, Harshal.
Yeah. So I'm presenting a case of a query malignant glaucoma post 2-year surgery. She was a 35-year-old female.
Harshal, go into the full screen mode.
Harshal, go to full screen mode, please.
I already clicked on the full screen mode, sir. Actually.
Doctor, it's not full screen. Can you just stop share for a minute?
Sure. Yeah.
Yeah, just stop share for a minute, please.
Go to stop share.
Yeah. Yes, sir.
Just click on the share button once and select the entire screen and then go sharing. Just click on the share button once.
Yeah.
And select entire screen and then share. Now just go to the PPT and make it in a slideshow mode. Perfect, sir.
Yeah. Yes, sir. So she was a 35-year-old female who presented with main complaints of a decrease in vision in her right eye since last 10 days, mainly complaints of floaters. She was a known diabetic since last 15 years. So her best corrected visual acuity in the right eye was 6/9 and in the left eye it was 6/6. On fundus examination, she was noted to have high risk PDR along in the right eye, and in the left eye it was SNPDR. We had planned for right eye 3 sittings of planned retinal photocoagulation, and in the both eyes we wanted to do the FFA just to look at the status of the other eye. So this was her OCT picture and fundus photo and FFA, which showed a large subhilar hemorrhage in the surrounding the disc. Left eye, she didn't have any NVEs, and her baseline investigations, uncontrolled diabetes with an HbA1c of 10.8. So she was advised right eye 3 sittings of pan-retinal photocoagulation, and left eye she was just observed. She was asked to review after 2 months. After reviewing her after 2 months, her best corrected visual acuity in the right eye had decreased to 6/18. However, her blood parameters were still, sugar was still not well controlled. She was asked to undergo additional PRP in the right eye in view of unstable lasered PDR. She was lost to follow up, and she came to the clinic maybe after 6 months when the vision in the right eye had still gone down by to 5/60, and she had developed a right eye tractional retinal detachment along with a full thickness macular hole. In the left eye, she had developed a proliferative diabetic retinopathy. Physician fitness was taken, and she was advised right eye anti-VEGF injection followed by VR surgery. In the left eye, in view of PDR, she was advised 3 sittings of PRP. This was the OCT picture when she presented after 6 months. So she underwent a 23 gauge pars plana vitrectomy with membrane peeling, ILM peeling, along with an endolaser and silicone oil. The procedure was uneventful. On post-op day 1, after a week and after a month, she was doing well with a best corrected visual acuity of 6/36 in the right eye, and in the left eye she was maintaining 6/6. So she underwent right eye silicone oil removal 3 months post primary surgery. The first day was uneventful. However, she presented to the clinic on the third day with severe pain. The right eye, she had severe corneal edema along with a shallow AC with a pressure of 52 millimeters of mercury, and ultrasound she didn't have any RD or CD. So she was given the primary line of treatment with tablet Iopar SR, IV mannitol, and topical AGMs. The glaucoma opinion was sought for, and she was noted to have right eye malignant glaucoma, for which they had started atropine, and she was advised pars plana lensectomy with anterior hyalurectomy with inferior peripheral iridectomy. She underwent the same. The first day post-op, the pressure had come down to 20 millimeters of mercury, along with significant decrease in the corneal edema. On 7th day, the pressure still was around 30, in view of which she was started on Misoft eye drop. And on 14th day, the best corrected visual acuity had improved to 6/60, along with a normal intraocular pressure. After the literature search, this is the ASOCT picture post anterior hyaloidotomy and inferior PI. So there are few similar cases reported. However, few queries that I wanted to ask you all. Any other differential diagnosis that we can think about? Any similar experience? Why didn't malignant glaucoma occur after the primary surgery, like the VR surgery? And can an SFIL be planned in the right eye after few days? And what are the precautions to be taken for the other eye or when she undergoes a cataract or a retina surgery?
Okay.
Hello.
So yeah, I have had some few patients like this, and rather
Yes, sir.
than it's probably because of iris Bombay that happens with 360-degree posterior synechia that it led to
Okay, sir.
this kind of picture. Uh,
Yes.
Whether it was just malignant glaucoma, I think we have a lot of glaucoma specialists here. They will be able to throw
Sure.
light about it. But probably I would have done phacoemulsification and put in the IOL in first city. I mean, in this case, rather than doing lensectomy, because that
Okay.
forms a barrier for neovascular glaucoma in future. Uh,
Yes, sir.
However, we have our MOS secretary, Dr. Preeti Kamdar, who's a senior glaucoma specialist. And with permission from our chairman, Dr. Paritosh, I'll ask Madam's opinion as to how would you.
Yes, my best.
So please ask Madam's permission to take the argument,
Yes,
sir.
yes, please go ahead.
Dr. Manish, you seem to be not having a good time and trying to create trouble here at home by asking us each other's permission. So no matter, I'll let that go. But yeah, on a serious note, if there is peripheral anterior synechia, which is causing the angle closure, the lens iris diaphragm will not move ahead. When you do a UBM, the lens will remain posteriorly if it is because of PAS. So the hallmark of this aqueous misdirection is the entire iris lens diaphragm moves forward along with a closed angle, high intraocular pressure, and which does not respond and responds to atropine. So in this case, because of the response of atropine, I do think it was aqueous misdirection. Now, why it didn't occur in the first place is not, we can't really say, but what predisposes is a short what do you say, a short length of the eyeball. Second is if there has been sudden hypotony, that also can predispose. In eyes which are already predisposed, it can occur. Now, once it has occurred, every time you operate the patient for any other surgery, you have to tell them that this can recur. Even the other eye, when you're doing a cataract surgery, make sure that the lens does, I mean, the aqueous, the intraocular pressure is maintained at a constant, the AC does not collapse, and plus keep a close watch. And one more thing, don't be in a hurry to stop atropine. The atropine should continue so many times indefinitely. And if you want, you can taper, but when you're tapering, again call the patient, keep a very close follow-up because they tend to relapse. So these are my thoughts on that. Anything else?
Regarding lensectomy versus phacoemulsification with IOL implantation in view of future risk of NVG, would you, what would your this thing be?
We can do a we can do a phacoemulsification. There's no problem, but there has to be a communication between the two chambers. Make it a one common chamber. So either you do through the zonules, you can do a hyaloidectomy, and thus make it one common chamber between the aqueous posterior chamber and the posterior segment. So that way, take care, and you can do a phacoemulsification also. There's no problem.
I
Here,
think we
I
have,
think
yes. Yes, Dr. Paritosh,
we
sir.
are also dealing with a situation of ocular ischemia. So, probably the patient developed low-grade fibrinoid syndrome, and that is what led to the genesis of this entire aqueous misdirection. Because the anterior hyaloid would have gotten, partially fibrin and fibrosed and led to all these things. Now, so the important thing is to do a carotid and ophthalmic artery Doppler in these cases as well. If you looked at the FFA of the other eye also, it was not a good, clean situation. So, carotid and ophthalmic artery Doppler would be my other suggestion for this week.
I think we have come to the end of our session. We have managed to finish it well in time. Dr. Paritosh, would you have any last words before we wrap?
Yes, thank you to all the presenters and all the mentors, and a big thank you to Manish for having conducted the session so well, and a very big thank you to Piyush for such a wonderful feast that he's dished out to all of us as scientific committee chairman. Thank you, all of you, and good.
Thank you. Thanks to all the participants for presenting great cases, having a wonderful discussion. And with this, I think we hand over to the next session to the group. Thank you all. Thank you for joining.
Thank you.
Thank you, Dr. Manish, Piyush, and Dr. Kamdar, sir. Thank you.
Thank you so much.
So next is the glaucoma guys and girls. So here, can we start now, Dr. Piyush, with your permission? He's not here, so let me start. Good afternoon, everyone. I'm Dr. Preeti Kamdar, and I'm the Secretary of Maharashtra Ophthalmic Society, and it's a pleasure to be here on this afternoon with all of you. And I thank the chairperson, Dr. Piyush Bansal, for this wonderful webinar and the unique concept, just case-based, and that's what all of us enjoy. And of course, the coordinator, Dr. Sumit Lahane, and the scientific committee of Maharashtra Ophthalmic Society. So for this glaucoma session, we will have 5 cases, and each will be of 5 minutes each. And I'll be joined by the chairperson, Dr. Manisha, who's a glaucoma specialist from Mumbai. And our first case is by Dr. Sneha Shinde Bandurge, who's a glaucoma specialist from Kolhapur. And the panelists for this case are Dr. Ashish Thul, who's an experienced glaucoma surgeon from Nagpur, and Dr. Archana Kota, who's also a glaucoma surgeon from Sangli. So if you can just start sharing your screen, Dr. Sneha. Are you there, Dr. Sneha? Yeah, I can see her. Yeah. Hi.
Hi. Can you
5 minutes, please. Yes, we are able to see us.
Yes. Can you see my screen now?
Yes, we are able to see your screen.
Okay. Yeah. Good afternoon, one and
Make
all.
it full screen. Make it full screen.
Yeah. Is it visible now?
It's not full screen as yet.
Is it visible now?
Now it
Yes,
is.
visible.
Yes.
Okay. Can I start?
Please.
Yeah. Good afternoon, one and all. Thank you so much for giving me this opportunity. So my case is a 50-year-old female came with a onset severe headaches in 7 days, nausea, vomiting 7 days, colored halo 7 days, and blurring of vision 7 days, and eye pains in 7 days. So history of present illness, she came with sudden onset of severe headache, more
We are not able to hear you.
So near right bro, photophobia.
Your voice is getting cut.
Nausea, vomiting since 7 days. Can you hear me now?
Yes. But it's fractured. Your voice is
in
fractured.
the right eye and what? Okay, there's no history.
Dr.
No
Preeti, I believe
history
there is
of
an
similar
internet.
complaints in the past. Any recent medication? No recent medicines intake prior to the attack. Ocular trauma. No prior red eye episodes. No previous lasers or use of steroid drops. No previous diagnosis.
How can we help her?
Ma'am, can we take the next case then?
Yeah, let's do
I
that.
don't know. There's some internet.
Let's do that. Okay. So is Dr. I think stop sharing. You sort out that issue and let us just go to the next presenter, Dr. Sheetal Naik.
Okay.
Is Dr. Sheetal here? Please stop sharing, please.
Okay. Okay.
Right? Dr. Sheetal, are you there? All right. Dr. Kunal, are you there then? Yeah, he's there. Dr. Kunal, if you can share your
Yes,
screen.
ma'am, I'm there.
Please do that. I will take your case first.
Yes.
So Dr. Kunal Nikale, he's a very experienced glaucoma surgeon from Nashik. He's going to be our presenter. And the panelists for this case are going to be Dr. Siddharth Kamble, who's a glaucoma surgeon from Jalna, and Dr. Mandar Paranjpe, who's a glaucoma surgeon from Pune. So please, Dr. Kunal, start your case, please.
Ma'am, are slides visible?
Yes, they are. Go into the full screen mode, no?
Is it full
Thank you.
screen now, ma'am?
Yes, it is.
So, good afternoon, everyone. At the outset, I would like to thank Mos for the opportunity. Mine is a very simple case pertaining to a general ophthalmologist. So, all high IPs are not glaucoma. So, a 38-year-old male IT professional came to glaucoma opinion in our OPD. He had complaints of eye strain, ocular heaviness, and discomfort in both eyes. He was on and off anti-glaucoma medication since a year, and presently he was on combination of brimonidine and timolol drops. Previous records checked elsewhere mentioned IOP on NCT ranging from 32 to 34 millimeters of mercury. He had a strong family history of glaucoma in his mother and grandmother. Mother was on treatment with 2 anti-glaucoma medication with advanced glaucoma in one eye. Patient was anxious and was referred as IOP didn't reduce enough on topical medications. Coming to negative history, he had no history of any steroid intake or recurrent uveitis or ocular trauma and no systemic illness per se. On slit lamp evaluation, the cornea was much clear. We could see a very thick corneal slit beam on the slit lamp, and he had normal iris pattern, normal anterior chamber depth, and rest of examination was within normal limits. On examination, he was myopic in both eyes with 6.6 and 6 in both eyes with -2 sphere in right eye and 1.5 sphere in the left eye. Goldman's applanation tonometer without any anti-glaucoma medication measured right eye was 28 millimeters of mercury and left eye was 27. Diurnal IP measured at different time intervals measured fluctuation less than 5 millimeters of mercury. So investigations, we could note very thick corneas in his case, which was 614 in right eye and 612 in left eye. Gonioscopy done saw grade 3 open angles in all the quadrants with minimal or very less TM pigmentation in all the 4 quadrants. Fundoscopy done had a very healthy disc with 0.4 and 0.45 CDR with healthy neuroretinal rim and no RNFLD or no notching seen. Perimetry 24-2 done was absolutely within normal limits, reliable, and OCT again we could see a healthy RNFL thickness in all both the eyes.
We've lost you, Dr. Kunal. Dr. Kunal, we've lost you.
Treat all of them or treat none, or who should be treated? So these were the questions pertaining to me and again all the general ophthalmologists who have seen him before. So by definition, everyone knows ocular hypertension is when the IOP is more than 21, no evidence of ONS damage or visual fields, open angles, and no systemic or ocular cause for raised IOP. So to answer our question, there was ocular hypertension study where the role of topical IOP lowering agents in preventing the onset of glaucoma was seen. Here, the 5-year glaucoma risk was very less, 4.4% in treated eyes versus 9.5% in the untreated eyes. So, considering the small risk, is it practical to start treatment in all the ocular hypertension? The answer was the risk factors. So, the prospective proven risk factors, out of them, the main risk factors were the thin corneas and elevated eye pressures. So in the ocular hypertension studies, when the corneas were thinner, that is less than 550 microns, and when the IOP1 presentation was more than 25, that there was 36% chance of getting glaucoma, as compared to 6% when the corneas were on the thicker side, that is more than 588. So whom to treat? There are high risk cases where the IOP is more than 30 with thick corneas, or the IOP is 26 with thin corneas. Vertical curve disc ratio more than 0.4. So plan of treatment should be, in these cases, the target IOP reduction should be again 20 to 30% of the baseline. Anti-glaucoma, single monotherapy or SLT can do. Our case, like moderate risk he had. IOP was between 24 to 29 with thick corneas. He had family history of glaucoma, high myopia. So we could plan and discuss with the patient. If the risk is more, we can start treatment. Low risk, we can always observe. There are again special considerations like a one-eyed patient, a young patient, one with reliable or unreliable fields or optic disc assessment. Again, the patient who has already started treatment with some other physician and is tolerating the medication well, or the patient who desires treatment.
Dr. Kunal, 5
Yes, ma'am.
minutes are up.
Last slide. So in our case was a young anxious patient who was non-compliant. Again, he had an apprehensive mother who was desiring treatment in her boy. He had thick corneas with moderate risk. Counseling was done. Again, the target in his mind was in 15 on 14. So we counseled him, it should be lower 20s, and we gave him option of AGM or SLT, and he went ahead with SLT, and he was happy to follow. So take home pulse is like NCT is again a screening tool and should not be used for treatment. Complete evaluation, risk benefit of glaucoma therapy is important. Apprehension has to be taken care of with reassurance and counseling. Thank you. Thank you for the opportunity.
So, Dr. Kunal, that was a nice case, even though you said it's a simple case. This is the kind of cases which we see day in and day out, and
Yes,
which are
ma'am. Yes, ma'am.
misdiagnosed or overtreated. So, it's the right case for this panel. So, I would say, I would now ask Dr. Mandar Paranjpe for his views. And I don't see him here, but then.
Yeah, I'm here.
You're here? Okay.
Yeah.
You can just switch on here.
Yeah, my
Oh,
camera is
okay.
on.
In a different way. Fair enough. So what would you treat or would you not?
Yeah, so it's a calculated decision which we need to take. It's not an individual decision. It is with consultation, or rather discussing the scenario with the patient and the relatives. Now, obviously, there is a risk factor, family history of glaucoma. Mother and grandmother both have glaucoma. So genetically, this particular individual is prone to, or I would say slightly higher chance of developing glaucoma in future. So we need to keep that in mind. The initial pressures, although were high, the corneas were quite thick. So if you look at the CCT adjusted IOPs, they were probably in the mid-20s. And there are two things which I would do. One is I would do a diurnal in this patient just to see what's the range, even though the initial IOP is still high. Sometimes you may get an initial IOP of early 20s, and then the diurnals may have one reading which is off the charts. So obviously that tilts you more in favor of treatment. That is one thing. And second important aspect which I would consider is the compliance, which has to be considered. So like you say, the risk is X percentage of this person developing glaucoma over the 5-year period. But then, practically speaking, if you tell this, suppose this is a patient without any family history, and if you tell this to a patient, probably he'll forget about it. And then maybe a few years down the line, he comes back to you with very advanced disease. So this is something which you need to hammer in the head, and which is, you just can't, you don't have any control over this. So in this particular case, I think what Dr. Kunal did was right. He did talk to the patient. Another important aspect is the psychological state of the patient. He mentioned that the patient was anxious. Now, that itself says a lot about the personality and the way patient approaches this particular problem, or any problem for that matter. So, obviously, we know that if the patient is a type A personality or that kind of a personality, then because of
So you would do exactly what Dr. Kunal has
yes,
done.
I agree with
Counsel.
what he has done.
Yeah.
But most important is one reading is not enough, NCT is not enough, and you need to do a thorough workup, and oftentimes you need to follow up with that workup consequently.
So counsel.
Just to
Counsel
interrupt,
is like communication. Yeah.
yes, diurnal was done, and diurnal was less than 5 millimeters of mercury, as I've already mentioned in the slide.
Yeah. And what was the highest? You said it was around 27, 28.
27, 28, yes.
Fair enough. So, Dr. Rita, you have raised your hand. You can unmute yourself, please.
Yeah, thank you. Very nice case presented by you, Kunal. But the only thing I thought Mandar would bring this point up is you don't look at the central corneal thickness as a management tool at all, and there is no factor like corrected IOP. That is one message that has to go to the general ophthalmologist very, very clearly, because there are many softwares which now give you this corrected IOP phenomenon, and there is no such a thing as corrected IOP. If the IOP is recorded at what it is, doesn't matter what the corneal thickness is, that is the IOP. The only thing that actually you worry about is if it is a thinner cornea, then there is a higher chance for progression, and you can do nothing else with that IOP otherwise. So otherwise, absolutely well managed. I think discussing with the patient was very important. Absolutely. Because between 27 or 28 and above, you would normally want to discuss the case with the patient and let him know what are the chances of his getting to glaucoma, and then start treatment.
So, Dr. Sagarika, you had raised your hand. You wanted to say something?
Yeah, it's a beautiful case. I won't go into that. But one thing that I would definitely like to add to whatever has been said, which is all absolutely fine, is that when you have such a strong family history of glaucoma, in that case, in today's world, it is very important also for us to tell the patient that, look, we have another modality by which we will be able to give you a better idea whether you'll be developing glaucoma or not by doing genetic studies. That's my only take on this. But otherwise, beautifully managed case, and all of us do that. It's very difficult to do genetic tests, but this is one little take that I think in today's world we should think of. Thank you.
So I would say the take home for this case is, one is that counsel, you establish the risk. This was a moderate risk because of family history, plus the person was a myope themselves. And that's why a moderate risk, but again, thick corneas, few in favor of glaucoma. So this is exactly the case which confuses people, and you managed it so well. So don't jump to treatment. Establish the range at which the IOP is. And most importantly, even if you decide you're not going to treat, hammer that follow-up is necessary. So don't say, okay, go away, kuch nahi hai, unnecessarily you don't have damage, because you don't know, after 5 years, the person may have elevated IOP and come back with damage. So what you did was absolutely right. And let's go on to our next case. And Dr. Sneha, hello. Dr. Sneha, are you able to now join?
Yes, ma'am.
Yeah, so just please start your screen sharing. So as I said, the discussants are Dr. Ashish Thul from Nagpur and Dr. Archana Kota from Sangli. Can you share your screen, please?
Yes, ma'am.
Yeah, you can start from here where you left off. And the timer, if you can just put it for about, say, 3.5 minutes.
Okay, ma'am.
Yeah.
There was no history of similar complaints in the past or any recent medicine intake prior to the attack, no history of ocular trauma, no history of redness of the eyes or previous laser or any surgery be done or steroid drops used, no history of previous history of any glaucoma, no history of using any she gives history of using plus number glasses in her childhood, no history of any ocular surgery done in the past history. Hello.
Yeah, we can hear you. Go ahead.
Okay, ma'am. Yeah, I thought there's
No, go ahead.
No history of similar complaints in the past. No
Sneha, it's still fractured. Sneha, it's still fractured. Your voice is not clear. You're go into a better zone if you can. I think. Sneha, can you hear us? Sunilji, what can we do? Sneha, can you stop sharing, please? Okay. Just go ahead with your slides, please. We'll read the slides.
Screen
Dr.
sharing is stopped, I think.
Yeah. Dr. Kanchan?
Yes, ma'am.
Can you share your screen?
Yeah. Yes, ma'am.
Please. So Dr. Kanchan, she is a glaucoma specialist from Latur. And the discussants will be Dr. Ajit Hazare, who is a glaucoma specialist from Chhatrapati Sambhajinagar. And of course, Dr. Videsh Kulkarni, who's a glaucoma surgeon from Sangli. So Dr. Kanchan, if you can just share your screen, please.
Yes, ma'am.
Yeah.
Okay. Good afternoon. First of all, thank you for the opportunity. And today I am presenting this case of neovascular glaucoma and why it's a race against blindness. We'll see with this case. So I had one case of 56 years old female patient which presented with the loss of vision in her right eye for 1 month. There was history of right eye cataract surgery done 5 months back elsewhere, and patient was diagnosed with neovascular glaucoma in right eye 3 months after cataract surgery. She was started on anti-glaucoma medications, brimonidine and travoprost, but IOP was not under control. No surgical intervention was done, and patient lost her vision in the right eye. Now she has come for second opinion to me. She was known case of diabetes for last 20 years. On examination, she already lost right eye vision. Left eye was 6 by 60. IOP was 40 in right eye. Left eye was 11. Anterior segment shows right eye PCIL. Left eye, she had advanced cataract. Fundus right eye total cupping with neovascularization. Left eye was little hazy view due to cataract, but disc and macula was grossly okay. So, as the patient had no pain in right eye, we had not done any intervention for right eye, but we planned left eye cataract surgery. She because of advanced cataract, the blood sugar level was okay at the time of surgery. 1 month post-op, patient was doing extremely well. She was 6'9", IOP was 13 without any medications, and fundus we checked at 1 month after cataract surgery. There was moderate NPDR. Now we asked patient for close follow-up, but patient didn't come, and after 3 months she turned up with left eye similar complaints. So she had florid NVI, she had ectropion UV, and raised IOP of 36 in left eye. Her right eye pressure even increased more to the 54. So this was the anterior segment picture and the fundus picture. So fundus, if you are able to see in that red rings, there were neovascular fronts were developed, and but anterior segment have more neovascularization as compared to the retinal changes. So I had doubt. I did all systemic investigations. I did 2D code, Doppler, everything, but everything was okay. So luckily her disc was okay, but NVs were there. So we planned quick surgery of left eye because she already has lost right eye. When she presented, she had pain and vomiting, so given mannitol, immediately started all oral and the topical medications. I have planned PRP1 sitting on same day because left eye cornea was relatively clear, and anti-VEGF injection given on the same day. So I have planned trabeculectomy 2 days later, and also did the DLCP in the right eye for the pain management. Now patient is doing well after TRAB. 1 week post-op, her pressure was good in left eye, it was 8. Unfortunately, I don't have video or the photos of that TRAB surgery. But 1 month post-op, her pressure was again 22, CDR was zero point 0.4, but patient was non-compliant, one-eyed, so I don't know whether she will come for follow-up or not. So I have started one AGM combination drop, and when she came for the last follow-up, her pressure was good. So I just want to say the neovascular glaucoma need quick intervention because many a times patient lost vision because these are refractory glaucoma. They are not responding to medical management. So most of the time the diabetic retinopathy and the CRVO is the main uh, cause for the neovascular glaucoma. So retinal ischemia is the main reason. These are the other different causes. So CRVO, in ischemic CRVO, almost 45% cases develop neovascular glaucoma. In diabetic retinopathy, PDR, almost 45 to 65% patients develop neovascular glaucoma. And one important thing I want to highlight here is ocular surgery increases the diabetic retinopathy progression. And what are the causes? Because this is the important point we have noticed in our case also. So post-operative inflammation always increases the progression of that retinopathy. So we need to see the patients carefully after cataract surgery whether there is increase in that severity of the diabetic retinopathy, and the close follow-up is also important. So diabetes patients already have retinal blood-brain barrier is weakened, and surgery further disrupt this permeability. Increased oxygen demand and metabolic stress is there, and because of any surgical intervention, it further increases the stress, and sometimes pre-existing hidden retinopathy becomes visible. So this is also one of the important cause. So presentation we have already seen. What are the different stages of neovascular glaucoma? Initially, there is only rubeosis iridis. Because in this case, if IOP is normal, then we have to pick up early.
Your
Yes.
time is up. 5 minutes
Yes.
are over.
Yes.
I
Yes.
think you
Ma'am.
have
Just.
presented the case
Yes.
very beautifully.
Yes.
So we can cover the rest in this.
Okay.
Okay.
Just
Yeah.
I want to go to one final
Sure.
slide, take home
Sure. Sure.
message.
Sure.
This is one treatment plan. So in any neovascular glaucoma, if no PL is there, if pain is not there, medical management is important, or go for cyclodestructive procedure. In seeing eyes, if media is clear, go for directly trabeculectomy or the shunt surgery. If poor media, intracameral Avastin injection is important. It also increases the trap surgery results. And if vitreous hemorrhage is there, vitrectomy with endolaser followed by surgical intervention can be done. So take home messages: early detection of NVI is very important. Undilated slit lamp examination and gonioscopic evaluation is very important in all PDR and the CRVO cases. And Avastin has role
I think
anti-VEGF.
we'll take
Yes,
it in discussion.
yes, yes,
All
yes,
right.
yes.
So thank you, Dr.
Thank you,
Khantin.
thank you.
That was a very nicely presented and nicely managed case. And again, we are not looking for cases which are out of the world or very rare. We are looking for cases which everyone sees. All comprehensive ophthalmologists, glaucoma specialists, retina specialists, these are the cases that they kind of see. So let's go to the discussion. If you can please stop sharing your screen.
Yes.
Yeah, so Dr. Ajit, yeah, there you are.
Yeah.
So, at what stage will you start the laser? Like you have somebody who has neovascularization, PDR, but no elevated IOP. Would you do the PRP? Would you advise, would you refer to the retina surgeon?
So I think retina surgeon is an essential part of the team. And as soon as I see that the patient has PDR or even very severe NPDR, I would take a retina opinion. If needed, we would do a FFA even now and do PRP. If there is no glaucoma, we would do PRP, especially when the other eye already has a history of NVG. And if the patient has already started developing raised IOP, then we need to look at the angle to see if there's any angle closure. And if the PDR is not, if it is just flat NV all over and just at the disc with no fibrovascular proliferation, then it makes sense to give an anti-VEGF injection also. But that's a call that's taken by the retina surgeon because we need to look at the potential effect of the anti-VEGF injection on the PDR as well as for the glaucoma. So it'll be a combined effort.
So PRP remains the, at whatever stage it is, if it's a neovascularization because of PDR or any other reason, you need to get in the retinal surgeon and do a PRP. Correct? Depending upon how clear, here as she said that it was a very clear media, so she did the PRP on the same day she initiated. That was wonderful. Right? So Dr. Ashish and Dr. Manish is also here. Thank you, Manish, for joining. Were you there for the whole thing? Then maybe you can put your
Yeah,
thoughts.
I was there. I was there for the whole.
Yeah, so your thoughts on anything else you want to add to this? What you
So
would have
it's
done
yeah.
different?
Only thing I would like to add is that when a patient has lost one eye to NVG and you operate the cataract, so as she has pointed out, Gauri has pointed out that the cataract removal removes that barrier. So I would say that the follow-up or the observation has to be a little more aggressive because we are going to anticipate that she might develop the neovascularization in the fundus or maybe some fronds in the angle. So I think moment the cataract is removed, maybe I would put on a very short, maybe quick follow-up for retinal exam and gonioscopy to see if anything can be picked up early. That is one extra point which I would like to make. Be more aggressive in watching what is happening. And also the same patient, sometimes we operate, that time we check all the sugar and everything. Once the patient is operated, we never get the sugar rechecked. So in these patients, their glycemic control also has to be monitored in the post-operative period with the aim to keep diabetes well controlled so that there's lesser chance of these things happening then. So these are two extra points I would like to add.
Well taken points, very well, that yes, post-op glycemic control is equally important because otherwise patients also, all right, surgery is over, now let me have a merry way, like let me eat, all is good. Pooja, you had raised your hand, you wanted to say something? You're muted, unmute yourself, please.
So I had a case yesterday of ocular ischemia actually. But the pressures were normal. She had NVI, pressures were normal. So how does everyone plan in this case? Should we, anticipate like later on the patient will develop glaucoma or something? Because the fluoride NVI, ocular ischemia, like we did carotid Doppler and we did find, occlusion there. So how we should go ahead? Should we plan like anticipate like glaucoma will develop in future or something like that?
How much was the occlusion on the carotid?
It is significant enough to cause ocular ischemia, florid NVI, and on FFA, everything was, I don't remember exactly how much
So that
the carotid
those
ocular.
the neurosurgeons, vascular surgeons, they will not operate till it is 90%, 85 to 90%, because otherwise the risk is very high. So that's why I'm asking how much was the occlusion. They will not operate unless you have 85% occlusion of the internal carotid artery. And yes, I think whenever their blood vascular supply gets normal, they get a terrific rise of intraocular pressure. So,
That's
Doctor,
what. So
yeah,
eventually she might develop glaucoma, no?
Dr. Ashish, you want to answer that
Yeah,
question?
yeah, very high risk for the patient to develop glaucoma. You will need a very close follow-up, little
Follow-up,
less.
yeah, close
Yeah,
follow-up, yeah.
yeah.
True. So
Yeah, that's right.
coming back to this case. So, which of you, Dr. Rajul, you are here. So, would you prefer a trab or would you do AGV or an implant? What would you do?
General guideline, if depending upon the synechia and the amount of neovascularization. So, if the neovascularization is well controlled, and if the superior angle at least if is open, then the trap has a good success rate. But if you ask me, my personal opinion, I would prefer tubes over the traps in general.
So, you can
Ma'am,
do a
the
trab. Let's, yeah.
yeah, ma'am, the actually the as we have read it, it is florid NVI with such an aggressive disease. Since in 3 to 4 months, she totally lost the vision from 6/9. So I think trab instead of trab, you could go to a valve like
Yeah, so that's
RD
why I
or.
said if the
Yeah. So,
neovascularization is well
what I'm
controlled,
going
then
to
tube
say,
traps. Otherwise, the tube is definitely a better choice.
I think we'll
I,
end the
I'm not, I
discussion.
didn't talk about this
Yeah.
patient. I said in general the guidelines.
Yeah, because we'll have shortage of time. So to the viewers, I want to say, in the meanwhile, if you can just, Sneha, if you're back again, or Dr. Sheetal, if you're here, you share your screen, please? Sheetal. In the
Yes,
meanwhile, the
ma'am.
takeaway
Yes,
from this case could be, one is PRP is the hallmark. Keep a very close follow-up. There was a question which said,
पहले
can we
माझं
do
का होत
a...
नाहीये शेअर
नाही होत. नाही होत आहे share. Okay, so Dr. Rita, are you ready with your case? We can take your case first.
यस मैम हो गया
हो गया? All right. हो गया? All right.
just a second. Just a second.
Yeah, sure. So there was a question which said, should you have done a gonio before the cataract surgery? And I do agree that when one eye has neovascular glaucoma, the other eye gonio should be done, right? So I think Sheetal, you have had some problem with sharing the screen. Let me
Can you
take
see the
Dr. Rita.
screen? Can you see
Yes,
the?
yes, we can. Yes, we can.
I think, Preeti, you should
Ma'am, why
say
did you
very
stop
clearly
sharing?
that every diabetic patient should have gonioscopy.
Absolutely, yes.
Why did you stop sharing?
If you're not able to screen, we'll take Dr. Rita's case. We're losing time that way. So, Dr. Rita, why don't you share your screen, please? Dr. Sheetal will take your case later. Dr.
Yes,
Rita can
ma'am.
start sharing her screen, please. जमतंय का? You're able to? You're muted.
Should I try again?
Okay.
Ma'am, should I share?
होता है? मत कर.
By mistake.
Do it. Yeah, do it.
By mistake.
And do it. If you are able to, yeah. This is Dr. Sheetal Nayak. She's a glaucoma surgeon from Nanded. Yeah. Is this? Yeah, right.
Yeah.
So
Can you
please go
see,
ahead.
ma'am?
Yes, please go ahead.
So, good afternoon, everyone. Um, I would like to thank the organizers and Preeti ma'am specially for letting me be part of this session. I'm presenting this case with respect to clinical findings mainly and diagnosis just so that early stages of malignant glaucoma in these cases is not missed. So this patient is a 65-year-old female who was referred to me for recent onset blurring of vision since a month. She underwent uneventful phacoemulsification around 6 months back and she was doing well till now. There was no other significant history. On examination, vision was 660 and 36, and slit lamp revealed shallow anterior chamber, iris Bombay, pseudophakia, and a IOP of 40 millimeters of mercury. So a diagnosis of secondary angle closure glaucoma was made and multiple YAG PI were done along with capsulotomy and halorotomy. No pre-IOL membrane was noted during YAG PI. So she was given post-operatively steroids along with homatropine eye drops and topical anti-glaucoma medication. After 1 week, vision improved and AC also became deeper, but it was slightly on shallower side. PI was patent. IOP came down to 20 millimeters of mercury. Gonioscopy revealed few peripheral anterior synapse with irregular pigmentation. Other eye revealed shallow anterior chamber along with cataract under normal pressure. So YAG-PI was done for the other eye, and this affected eye steroids were tapered while homatropine and anti-glaucoma treatment was continued. After 1 month, her vision, anterior chamber was well maintained, IOP was well maintained, fundus was seen in this visit, which also revealed normal disc with no glaucoma changes as such, and other eye also was normal. So, home atropine was reduced to bedtime, and she was asked to continue the anti-glaucoma treatment. A follow-up after 3 months revealed that everything was under control. So, she was asked to stop homide and review after a month. Another same case, a 60-year-old female operated for cataract surgery 10 years back and came with recent decrease of vision since 2 months. This case was seen around 16 years back by me. Um, for this case, the vision was improving to 6.6 and 6 with -2 diopter of myopic correction. IOP was 30 millimeters of mercury. There was definite difference in the anterior chamber in both eyes, right eye being shallower than left eye. The previous record of this patient didn't reveal any myopic correction after surgery. So this patient was treated with atropine eye drops after the laser treatment. Then in follow-up, we tried to stop atropine, but IOP raised again. So she was continuously given home atropine eye drops along with only topical beta blocker in the right eye. Another case of 70-year-old female, one-eyed patient was seen 12 years back. She had a history of SSCS surgery at government hospital and was referred to us after 4 months of surgery for IOP control. The vision was counting finger on presentation with irregular pupils with peripheral anterior synechia and shallow anterior chamber. IOP was 40 millimeters of mercury. Yeah, peripheral iridotomy, hyalotomy was done with maximum medical treatment was given to her along with atropine, but IOP couldn't be controlled. So these patients underwent pars plana vitrectomy with laser ablation of ciliary processes in 2 hours by VR surgeon. Vision was maintained after the surgery to 624 and 12, but by this time disc was damaged and there was advanced disc damage, but since last 11 years, she is maintaining this vision and IOP is under control. So basically, in any pseudophakic patient, we should suspect glaucoma if there is sudden increase in myopia, there is shallower anterior chamber, slowly rising IOP, there is forward shift of iris diaphragm, and vision worsening despite clear media. The causes can be zonular weakness, intact anterior haloid, post-YAG caps, or post-operative inflammation. Basically, ciliary body, vitreous, IOL, anatomical interactions, they get changed. These can be due to progressive anatomical changes which continue with aging, or delayed triggers like sudden IOP fluctuations, inflammations, medications, or there are some eyes which are anatomically predisposed. These cases typically would respond if detected early to cycloplegics and posterior hyalorotomy. Rest of the treatment depends upon the stage and the time of presentation and severity. So this concludes my presentation. I now respectfully invite the experts for their thoughts and discussion. Thank you.
Thank you. It was a very nice collection of cases. So let me ask Dr. Ashish Badgujar, who's the panelist for this section, and your thoughts on what is the first thing, how do you suspect aqueous misdirection or malignant glaucoma?
Yeah, ma'am. Good afternoon, everyone. Ma'am, mostly malignant glaucoma is a retrospective diagnosis because first thing comes. Hello, am I audible now?
Yeah. Go ahead.
Yeah, first thing comes in my mind is pupillary block. We have to rule that out first by patent iridotomy and whether the central AC is shallow or deep. Okay, so sometimes the patency cannot be checked because of the hazy media, hazy cornea. So, but after starting on the anti-glaucoma treatment, hyperosmotics, then once the IOP is little bit under the normal range, we can check the patency. If iridotomy is not done, we will go ahead with the iridotomy first. And even after iridotomy, if it is not improving, then that malignant glaucoma will come into my mind. But classically, malignant glaucoma is described in angle closure disease post-incisional surgery, but it can happen in pseudophakia and aphakia as well. So we have to keep that in mind as well. So that's what that madam has summarized, like the differential diagnosis that initially they treated as pupillary block. Then in second case, that myopic shift in pseudophakic patient is noteworthy.
So she's given all the pointers which tell you, okay, this may be aqueous misdirection. It is a diagnosis of exclusion. Dr. Sagarika, what would you do? Or Dr. Pooja, if you're here, what would you do? Now you've diagnosed aqueous, what is the first line of treatment?
Basically to establish the connection between the anterior chamber and the posterior chamber. If the connection between the anterior chamber, like iridectomy, hyalodectomy, and posterior vitrectomy is done, then we make the whole eye as a single chamber that prevents further progression and probably stops the disease there. So very commonly I have seen malignant glaucoma immediately after the surgery. It's very rare. I have rarely seen so late as she has presented. So yes, late presentation is also seen, but then we have to rule out all the other causes like pupillary block glaucoma and aim to manage the malignant aspect of it. So
what would be your medical line? So homide or atropine? That's what I'm asking.
Homide atropine. I would like to give atropine. Then I would like to give steroids also, like strong steroids, oral as well as topical, and observe how the patient is responding to treatment, and then maybe vitrectomy if it is not responding to the medical management.
And Manish, how long would you continue the atropine? That will be the last question for this case. Then we go to the next case.
Atropine sometimes need to be continued for very, very long periods of time. And definitely, if it has responded to atropine, I would keep under observation for at least a month or two. And if the things are remaining good on atropine, then after some time you can withdraw, may from 2 times, make it 1 time and see. Then if you stop it completely, very short follow-up, because there is a very high chance that on stopping atropine, there may be a relapse. So atropine definitely, and there are some patients who, if they are doing well, I have had a patient many years ago, now that patient has passed away also, who we kept on atropine for 5 years.
So long term, that is what I wanted to bring upon. Long-term atropine. And of course, in the previous session, retina session, we made it clear that if you're operating the other eye or doing any other procedure in this eye, the likelihood of aqueous misdirection is very high. Dr. Rita,
I would like to just add one small point.
Yeah, sure. Till Rita, start sharing your screen, please. because
when
we
you
are
are
short of time.
diagnosing aqueous misdirection and you see all the signs, a shallow AC with a little myopic shift, and you see that, that it's one point that you have to see very carefully, especially in pseudofakes, is how much space is there between the edge of the pupil and the IOL. If there is a good amount of space, then it is not malignant glaucoma, but it is peripheral anterior synechia, which is pulling the iris away from there. And if you sit and do vitrectomy and all that is not going to work, you will need to do a trabeculectomy in that case. So this is, and sometimes if you want to verify, if you do a UBM
Start
also,
sharing, no?
you are able to see the difference that the IOL is behind and the iris is in front. If you see that, then it is not malignant glaucoma.
Exactly. Within malignant glaucoma, the whole iris lens diaphragm shifts as one unit. So the IOL is not left behind. So that is one way of differentiating between the two. So not able to share, Rita? It's difficult. Okay. Then is Sneha ready, or are you in a better zone? Otherwise, we'll just have discussion of both of them are not able to share the screen. Sheetal, are you there? I think she.
Yes, ma'am, I'm there.
Yeah, okay. No, not
I'm
she.
there.
Sorry, Sneha. I'm so sorry, Sneha. I think she was in a bad zone. All right, so then let's have a discussion. Let's not waste time. So then, what is, if Rajul, if that also does not work, atropine does not work, your medications don't work, what is the next thing that you would do for aqueous misdirection?
Ask VR surgeon for the vitrectomy. And when they do vitrectomy, it is very, we have to make sure to tell them, of course they will do it, but to have clear, the anterior hyaloid face has to be removed completely. So that is a very important thing. Otherwise, the aqueous misdirection will continue.
All right. So vitrectomy, if it's a phakic patient, would you also advise a cataract surgery along with it?
I think that would be a better way of managing patient. Only thing is he's too young. In that case, it's little dicey. But if the patient is old, then yes, doing cataract surgery and vitrectomy would be a better choice.
So, Dr. Sagarika, what would you do? You would also advise lens extraction along with the vitrectomy, or just a vitrectomy and then at a later date, lens
I think
extraction?
that's a very difficult question because most of us do not get malignant glaucoma at that time. But there are instances where you can get malignant glaucoma in young patients, even like, for example, after an iridotomy, you can get it. Yes. But then if you have to, then I would go what Dr. Raju just said, that you have to do it, then you go ahead and do it. So that's one thing. And when one should not, one thing which has not been talked about is the investigative tool of UBM. So I think UBM sometimes, we had a one-eyed patient, and that patient had having malignant glaucoma. And once you do a trab and cataract surgery done along with the trab, and now you have a shallow AC and all features pointing towards malignant glaucoma with then you were wondering, why is this that the AC is shallowing, but the pressure is still low? So you have that pressure should be high and the AC should be shallow, but sometimes the two of them don't go together. So at that time, you take the use of you use a UBM and you see the anteriorly directed ciliary processes, and then you can come to one conclusion, which then goes in favor of you. We did hyalodectomy by the help of, as Rajul said, by the help of the retina surgeon, and the case still today, now it is maybe 5-6 years down the line, absolutely all right. Another point I would like to make, which I didn't, that is Professor Sood, he used to say, continue atropine indefinitely. It may not even be just 5 years, it may be for the lifetime of the patient, unless the patient develops some kind of toxicity or something like that, because that cycloplegia should not stop. They have never said, no book or no article has said, stop at this particular time. That's
right. Even after vitrectomy, you would continue atropine? You've done a vitrectomy. Yes.
That's a solid point that you have come up with, Preeti. I can't answer that because I don't know. Yes, perhaps You would have tried to, if you maybe you could stop it and then again restart in case the pressures were rising. Because mind you, sometimes even after vitrectomy, patient might have raised pressure. My own mother had it, so I know it is a little dicey situation.
So, though that's a beautiful way of answering. Any other questions from the audience?
What I would like to again go into
Yeah,
a little more detail is that vitrectomy is not only a vitrectomy. It is vitrectomy with iridozonule, connection. So that whoever is doing the vitrectomy has to make sure that a connection is patent from the anterior chamber through the iris, through the zonules into the vitreous cavity. So sometimes if the vitreous, the retina surgeons, I have seen them pushing the vitrectomy probe from behind through the iris into the anterior chamber and then taking it back inside. And I have seen anterior section surgeons doing it through the iridotomy or iridectomy hole, going through with the vitrectomy probe. So both these things can be done, but it's important that it is a continuous connection between all the chambers.
If the patient is pseudophakic, we can do it.
Yeah, so I'm talking of pseudophakic only. In phakic, so you are removing the lens.
Then we don't have to refer to VR surgeon. We can manage.
And you are removing, if it is a phakic patient, you are removing the lens. You can still do it.
So that's how it is. Stepwise, first is diagnose aqueous misdirection. It's a diagnosis of exclusion. Second is atropine along with aqueous suppressants in some way. If it still does not work, if it's pseudophakic, then maybe you can just go through the zonules. And the last stage is a complete vitrectomy, making sure that you cut the anterior hyaloid, you make the whole eye into one common chamber. Those are the steps of treating aqueous misdirection.
There's one more thing. There's
Yes,
one
yes,
more
yes.
thing.
And
Sorry.
atropine, yeah.
You can also, no, atropine is all right. You can also use the YAG laser. So before you do the surgery, you can use it.
True, yes, you can. In a pseudophakic patient. Yeah, in a pseudophakic patient, we can use that. And now we come to, let us discuss a little bit about angle closure.
Can I just discuss my case, because my thing is not opening on Zoom, but it's a very interesting case, and I would, if the permission of the chair.
Okay. Without pictures, will we be able to understand? Because I discussed the case with you. Without pictures, will we be able to?
So, you have to just imagine that there is that cyst between 5 and 7 o'clock.
Okay. So, in 2-3 minutes, please discuss.
Yeah.
Start your video, please. At least we can see you there.
You want to see me?
Yeah.
There's nothing worth seeing in me here. Forget it. I'll just talk.
All right. Go ahead.
So this was a patient who came to us post cataract surgery with done elsewhere about 2 or 3 years ago with a raise in pressure, and all that we noted, but there was a iris cyst between 5 and 7 o'clock, which was transparent. There was nothing else that we saw. So we decided, I can tell you what we needed to do. We needed to do a UBM, which showed us that it was an empty cyst. There was no solid cyst there. So that we had ruled out a melanoma. And so the diagnosis we made at that point in time was that probably it was a post-traumatic, as in post-cataract, small cyst which grew up and blocked the angle, gave a little rise to the intraocular pressure, and that's how the patient presented to us, with a little diminished vision and a little pain. The pressure at the time of presentation was only 22 millimeters of mercury. So, taking this into consideration, we decided that we'll just knock off the cyst, and we put in a vitrector and we cut the cyst. Then we joined the iris back again in place and had a nice round pupil. This patient went back with a little high pressure on the first post-op day, but came back to us within 5 days, having done the necessary, because we gave her anti-glaucoma medications for that time for a week, and her pressures went down and she was absolutely fine. She continued to remain fine for a few days, but she came back to us 1 month later with florid uveitis and with pressures of 45. Now, this was something that we had not seen, so I had to do a lot of literature search. The uveitis was absolutely florid, so there were cells, there was flare, we could hardly see the posterior chamber, whereas initially the fundus had seemed to be absolutely normal. But this time, through, we could not have a good look at her fundus. So what we did was that we decided to treat her as a case of uveitis. So we just started normal uveitis treatment. Her pressures went down. She came up to us about a month later, again with very high pressures. So at this point in time, we had just done the routine investigations for uveitis. So we had not really done, any deeper investigations to look for secondary causes of uveitis. But when she came back the next time, I had to do a paracentesis to bring her pressure down. And then we got all her battery of investigations for autoimmune diseases, which came positive. Her ANA was 2 plus. She was MAN2 just about positive. So I decided that it was not my cup of tea for present. So I sent this patient off to a rheumatologist. The rheumatologist had a look. I had explained to him that this case is MAN2 positive, just 1 plus. I had not done a quantifor on gold or a chest X-ray at that point in time. But the patient was subjected to methotrexate with Folvite, and she seemed to do better with that. A month later, she came back again.
Dr. Rita, if you can just sum up, then we'll have some time for discussion.
Yeah,
Otherwise,
okay.
we won't have time.
And then, this went on and she started losing vision very rapidly. And my question was, where did we go wrong? Did we not? Is it right to expect uveitis? Is it correct to continue with the anti-metabolite treatment and a monoclonal antibody, which the rheumatologist thought was right at that point, but later on said it has nothing to do with the uveitis. Let the ophthalmologist manage the pressure. We will manage only the anti-inflammatory part of it. And the patient has now lost all vision.
Oh,
with high
so
all suggestions are welcome.
So to sum up, it was a case of an iris cyst for which you did vitrectomy, following which you had, I think, pigment release or uveitis and elevated intraocular pressure, not responding to any medications. Is that right? Let's sum up, right? And with some positive features suggestive of uveitis, like positive ANA and a Montus positive. So anybody, it's an open field, and we have about 3 minutes for this discussion. So Dr. Ashish, anything different that you would do?
I would want to know the status of the other eye.
The other eye is absolutely fine.
Yeah, if we are thinking in terms of a systemic cause causing it, I would expect at least some changes in the other eye. Plus, ma'am, the pressures at presentation you said was 22. That was without medication, is it?
That was without medication.
And with that cyst, iris inclusion cyst is what we are looking at between 5 to 7 o'clock hours.
Yes.
Otherwise, the angle is absolutely open.
Absolutely.
I would rather think in terms of just following up this patient rather than intervening to see whether the pressure goes up further, because 22 pressures I expect the disc was normal, right?
The disc was okay.
Yeah, so maybe just follow up instead of intervening at that point of time would have been a better.
The patient's vision was coming down, and he had pain in the eye.
Okay.
Yeah. Mandar, you have raised your hand. You want to say something?
Yeah, I think one of the differentials for a cyst is a parasite. And given the history of the subsequent uveitis, although you may not have seen the parasite, but I think it is worth a try giving a antiparasitic drug like albendazole. Probably it might help initially. Of course, now it's too late.
Yeah.
But I have seen one patient in whom at first I thought it was a iris cyst, but the patient had a parasite, and it was not detected initially because we missed it. And once we detected it, obviously it was removed, and we gave albendazole. The patient had a similar picture, although the IOP never went up, but had severe reaction. And they resolved with a long-term treatment of albendazole and oral steroids.
That's
that
something. That's also something different.
that is something different, and
I wanted
in
to
our
say one
country we
thing
should
about
definitely keep it in mind. Last point from Dr. Manish, then we'll conclude the session.
so when Rita, you have done a paracentesis, you could have sent that material for
We sent that cyst that we had cut.
no, not that. You did paracentesis for a raised pressure at one point.
Yeah. That was at the later point. But what we had done
When there was
we had
uveitis.
done
When there was uveitis, yeah.
Okay, that did not strike me at that point in time. But when we had done the cyst excision, we had sent that cyst for histopathology, and that did not reveal anything.
All right, fine. So, Dr. Sagarika, okay.
Yes, I definitely want to just put in one question actually. I mean, you all are thought of tuberculosis.
Yeah, and still they started.
I think that is something that I would have definitely gone in for, because they've done everything. But I think tuberculosis being so much in our country, you never know. That is why I think you will have managed the case, because sometimes you lose eyes. You've done your best. But I would have thought, yes, why not also tuberculosis?
Correct. And because of that, I kept, reminding the physician, please look at the patient because he's MAN2 positive and you are starting a monoclonal antibody, which, they don't go hand in hand at all.
Yes, they don't go hand in hand.
So there are some cases where you never know the why and what, but it only makes us little wiser on intervening. These are patients who teach us what sometime maybe I should not have done that. That is something which we think, but that is retrospective. So with that note, I thank all the panelists and the speakers.
Hindsight is always 2020.
I agree. Hindsight is 2020. Maybe I should not have done that. That's what you start thinking.
Yes.
So I thank all the speakers, all the panelists, and I'm very sorry about the glitches. But sometimes they do happen. But all in all, we had a wonderful session. And of course, it's been beautifully curated by the Chairman Scientific Committee, Dr. Piyush Bansal, and Dr. Sumit Lahane for a wonderful coordination. And of course, to the IT team. So thank you all viewers. And the glaucoma group signs off. Now over to the next session, please.
Thank you very much.
Thank you, everybody.
Thank you. Thank you.
Thank you, Dr. Kamdar. Just a correction, we didn't really curate the glaucoma session. It was curated by Dr. Kamdar herself. So please, all due credit to you all, to the glaucoma group and to you. So thank you to all the experts for such valuable inputs. They go a long way in helping budding glaucoma surgeons with the direction to think and manage their cases adequately. Thank you very much.
Bye, Piyush. Bye,
Thank
Preeti.
you.
Thank you all.
Thank you, Piyush.
So thank you for finishing in time, though, even though we gave it to you 2 minutes late. So you've given us a 3-minute profit. And I just hand it over to Professor Archana Vare for our second session on cataract. Madam, could you just invite the chairman and the expert panel, and then we'll begin.
Yeah. So thank you, Dr. Piyush. And so this is second session on cataract, dilemmas in cataract. And the chairman for this session is Dr. Suhas Hardipurkar sir. And he doesn't need any introduction. And we have the expert panelists like Dr. Shirish Thorat sir, Dr. Santosh Bide sir, Dr. Saurabh Patwardhan, and Dr. Pankaj Lande. So good afternoon, sir.
Good afternoon. Good afternoon.
So we will start with the first presentation. And the first presenter is Dr. Dhananjay Prajapati, and he'll be talking on subluxated cataract. So over to you, Dr. Prajapati.
Yes. Good afternoon, everyone.
So I request Dr. Prajapati to please share his screen and start presenting.
Yeah.
His video is off.
Dr. Dhananjay, there is a physical cover on your laptop's camera. If you can just open that, the video shall be.
No, it's open. It's open.
You try to share your screen, Dr. Dhananjay. Yeah, now it's open. Yeah.
Is it visible now?
Yeah, it is visible. I mean, if the cover is not visible, so I mean, we cannot see you. Can you start sharing your screen?
Yeah. Yes.
Dr. Dhananjay?
Yes, just a minute. Yeah. Is it visible now?
Yeah. Please make it full screen. Yeah.
Good afternoon, everyone. So I'll be talking on subluxated cataract. So patient adult male visited to OPD with complaint of diminution of vision in his left eye. On examination, we saw there was cataract in right eye NS grade 1 and NS3 in left eye, but also there was subluxation of the lens from 7 to 10 o'clock position. We examined him, the posterior segment was normal and phacoemulsification surgery was planned with monofocal toric IOL. So once the main incision was fashioned, viscoelastic was injected to flatten the capsule, deepen the AC, and also to tamponade the zonular site so as to prevent the vitreous prolapse. A continuous capsular axis was initiated. Care was taken that it should not extend. While doing the capsular axis, one should keep in mind it should be centered at the crystalline lens and not at the pupil. It should always be initiated from the site away from the dialysis. It is always better to use Strifen dye as it reduces the elasticity. And if you have options of femtosecond laser available, better to go for that. Sorry.
Please make it full screen.
Yeah.
No, it's not full screen. Please make it full screen.
Yeah.
Yeah.
So femtosecond laser options, if available, better go for femtorexis as it reduces the stress on the back. But you should keep in mind your pupil should be well dilated and zonular dilatation should not be gross. Yes, CTR was inserted into the bag. For CTR to be inserted, your axis should be continuous, your PC should be intact, and the ZD should not be gross or extensive. So hydrodissection was being done. A good and thorough hydrodissection with good nucleus rotation can ease the steps of phacoemulsification. Phacoemulsification with low phaco settings was started. Trenching was done. While trenching, I noticed the back complex, the nucleus back complex was weak and it was being pulled towards the phaco probe. That time we realized it was much less stable as what we expected during slit lamp examination preoperatively. So we supported the back with iris hooks. Trenching was done and the nucleus was cracked in multiple small pieces so that it can easily be pulled into the AC and emulsified. While doing phaco, one should remember it should not exert any excess pressure on the bags. When when it's difficult to insert the CTR before axis, one can use the nucleus as a scaffold. When you're dealing with the last piece, you should lower down your parameters, because there are chances that along with the last piece, the bag can get aspirated into the phaco tip. So to prevent that, you should lower down the phaco parameter too. During cortex aspiration, the cortex first at the site where zonules are intact should be cleared first. The site at the ZB, circumferential stripping of the cortex is much safer technique. The type of phacoemulsive, the degree of the lens, and the extent of the ZD will warrant what type of phacoemulsification techniques to be used. Direct chop techniques are more safer in case of ZDs. IL was inserted into the bag. It was a toric IL. It was aligned at the axis.
Yeah. Excellent surgery, Dr. Prajapati. So I would like to invite Dr. Shirish Thorat, sir. I don't know, I can't see him. Okay. Dr. Santosh Bide, sir, to give his expert comments.
Very good surgery, Dr. Dhananjay. A few tips.
Thank you very much.
Yeah, few tips. The insertion of CTR has to be proper. While inserting CTR, you should take care that the insertion of CTR should be such that during insertion itself, sometimes you cause more zonular damage. So you should avoid that.
Yes.
So that is one tip which I would like to give you. And second tip which I would like to give is that you can use capsule hooks instead of iris hooks. You can use capsule hooks at the edge of the capsular axis, because capsule hooks are very soft. And iris hooks sometimes you can tear the capsular axis edge because of stiffness of the iris hooks.
Actually, we did not have that option. We did not expected the bag to be this weak. On slit lamp examination, the bag looked quite stable, so we were not prepared for that. So at that time, iris hooks were available, so we used that.
Okay. And for long-term stability of the back, any plans from your side? Or may I ask Adipurkar sir regarding long-term stability of bag in such cases of zonular weakness? Adipurkar sir,
ring segment could have been used, but we are following up the patient. The patient is doing quite well since more than a year. Yeah, definitely a ring segment could have been used to stabilize the back for long-term stability.
And you have used a toric lens for this particular patient. So
yes,
with such a subluxated lens, what's your opinion about the toric, implanting a toric eye?
It is better to fix the bag when you're planning for the toric IOL.
Yeah, so sir can give us some guidelines about fixing the bag.
Okay, thank you, Santosh. Good attempt. There are a few things which probably, I would have done a little differently. First and foremost, your site of incision cannot be exactly in front of where the zonular damage was. So you could have shifted your axis. I mean, you have to be at 90 degrees. Here you were bang opposite. So every time you do phaco, you are trying to, giving a lot of stress on that. Number two, when you say that when you examined on the slit lamp, you did not think that the bag would be so floppy. See, if you see a subluxation of such a big extent, I think you should expect the bag to be kind of wobbly. So you'll have to fix it. Number three, well, like Santosh said, these capsular hooks are definitely more atraumatic, and they fix the bag better. And you hurried with the endocapsular ring. See, once you put, see, the principle is put endocapsular ring as late as you can. But then before you do that, you have to have a very generous hydrodissection so that peripheral cortex is all separated from the back. And second thing, if you had, after your rexis was complete, if you had done one attempt of hydro and then used your iris hooks to fix the back and then repeated the hydro, and after that, you know what? You should inject viscoelastic into the periphery so that the visco stays there and creates a kind of a path for your endocapsular ring to go in. What it does is subsequently your cortex removal becomes easy. And in such cases, when you have extensive zonular damage, freer the nucleus, better is the phaco. Because here, hydrodissection was complete. So the nucleus was not rotating well. So at that time, doing phaco or nucleus, disassembly becomes more stressful for the zonules. So that has to be remembered. And second thing, uh, if when you do slit lamp examination, if you see a donesis, phacodonesis, or when you completed the case, if you have slight inkling that probably endocapsular ring is not enough to keep the bag in place, you should always think of putting a segment. Now, like you say, your judgment was right that you found with the endocapsular ring, the bag was pretty stable. And even today, after 1 year, it is stable. But most of these patients will not give you problem after 1 year, they'll give you problem 4 or 5 years. So if it requires and if the damage is extensive, it is always better to fix it. Otherwise, you did it well. And of course, it was a bold attempt to put an toric lens in that, especially when you're putting a toric lens, you certainly want the back to be, properly
Stable.
Good, well done. Very well done. All the best.
But sir, what is your experience of toric IOLs in case of subluxated cataracts? Hadi Professor?
Yes.
What is your experience of implantation of toric IOLs in cases of subluxated cataracts?
See, it's like any other, no? The toric lenses, what you want is the lens has to stay at the place where you keep it. And normally, most of the lenses do stay where they are if the bag is pretty stretched out evenly. So here, if I have to have a toric lens, I would be all the more careful to fix it with a segment or Gupta segment, Ahmed segment, one of these, and then put the lens and properly rotate it in axis, and it stays and it works. And if it's a very small toric, probably I would not.
Thank you, sir. So with that, can we move to this next case, sir?
Yeah.
So the next speaker is Dr. Nikhil Kandurwar, and he'll be speaking about phacoemulsification in small pupil.
So good afternoon, everyone. I hope my video presentation is visible.
It is visible, just make it full screen.
At the outset, I would like to thank Scientific Committee MOS for this opportunity and giving an opportunity to present in front of God of phacoemulsification, whom we have seen during our infancy days of learning phaco. So presenting on small pupil cataract, just what I have learned during my post-graduation, just wanted to enlighten few statements from my mentor. He always asked me to value each surgery as a lesson and embrace humility in the OR. And patient safety should always be a priority, like we were just discussing in the previous case. So whatever possible things which should be available should be used in every case, keeping our all things at home, and patient safety should always be a priority. So managing small pupil, on these headings, I am discussing this. So risk of small pupil by definition less than 4.5 mm. There will be poor visualization of the peripheral capsule and equator, elevated risk of rexis tears, direct intraoperative iris damage or iris trauma, elevated risk of PCR in small pupil cases, and higher incidence of written nuclear fragments, which may come as a surprise on day one post-op. So basically, there are pharmacological factors, ocular pathology or systemic, which we all know. Patients on prostate disease on tamsulosin, ocular pathologies like pseudoexfoliation, chronic uveitis, and systemic factors like diabetes, advanced age, and previous traumas can lead to small pupil. So there are two types of small pupil, basically a rigid small pupil and a non-rigid or elastic small pupil. So rigid small pupil, it is scarred, atrophic, fibrotic because in PXF cases or uveitis cases, they hardly stretch with viscoelastic, resistant to pharmacological agents, and more prone to tear than expansion. And in these cases, all management by pupil expansion rings is always better. Non-rigid cases like highly flexible and elastic pupil in IFIS syndrome patients on tamsulosin, this sometimes may worsen. The floppy iris might worsen if you stretch this kind of pupil, but OVDs using highly cohesive viscoelastics and using rings can be severe in these cases. So pharmacological agents, intracameral epinephrine
Nikhil,
or
do we
these.
have a sorry to interrupt. Nikhil, do we have a case video or anything?
Yes.
So
Just
we'll
next
move on
slide.
there because the time is very less. This can be covered in the discussion. If you can just move on to the case here.
Okay. So blindly performing rexis, there can be high chances of rexis runaway and capturing pupil. Uh, we might have, almost all of us have encountered this blindly performing rexis, or in cases of hypermature cataract, rexis runaway, and there is just no way to get it back than just pulling it off. Sometimes pupil, when there is small or floppy, it is captured easily in the phacoprobe and causes pupillary trauma. So the key of performing blind rexis is to always look at the fold configuration and keep a fixed angle of around 20 degrees at the pupillary margin while you pulling, and frequent grasp and regrasp technique should be ideal in these cases. So if you are grasping it say 4 times, definitely grasp it 10 times while performing a rexis in small cases. Patients with a small pupil with conditions like head nodding, always better to fixate the globe with tooth forceps like limbs or something, or any globe fixation forceps. So another similar case, this kind of pupil will never dilate, and again maintaining the fold configuration at this angle of around 20 degrees with the pupil will help prevent, and always make it in a centripetal direction so that it won't run away. If there is a pupillary membrane, it is required to release the pupillary membrane, and once the membrane is released and removed, there will be a substantial dilatation of the pupil automatically because those contraction forces are already relieved, and then we can go ahead with the rexis. So you can see once the rexis is completed and membrane is also removed, that the membrane and rexis is removed together, it is dilated. Perfect hydrodissection, of course, always required, but small pupil cases, unless the nucleus is rotated freely, it might trouble you while removing the pieces individually. So, but if you can do a vertical chop, that is best thing in these kind of cases because there is a small central area and you are not going to blindly
We need to wind
split.
up. You already overshot the time, so let's have a
Okay.
discussion on all the videos that you have shown.
Oh, just one last minute, sir.
No, I'm sorry, Nikhil.
Okay.
You've already shot up by, you already
Okay.
crossed.
Okay, sir.
You'll have to unmute yourself. Yeah.
Yeah, thank you, Dr. Nikhil, for the wonderful videos. I request Dr. Santosh Bidya to give his expert comments.
Yeah, at the outset, I would like to thank Chairman Scientific Committee, Dr. Piyush, Sumit, even and everybody, Team MOS, for the wonderful midterm conference. Excellent videos, Nikhil. But I would like to remind you of your first slide. You have shown your skill of doing capsular access in spite of a very small pupil, but everybody may not be able to do that. The risk of doing blind capsular access is that you don't know what size the capsular access is, and usually you tend to do it very small capsular access. And in such cases, nucleotomy is often difficult. Number one. Number two is that there is always a chance of catching iris during phaco, and it does cause iris chafing and it progressively causes more meiosis of the pupil. So it's always better, there should be no ego, you can use a pupil expansion device in the beginning itself. The management of small pupil starts from preoperative examination itself. In the OPD itself, you know that what sort of pupil and how that pupil is going to behave. And with history taking also, if the person is taking some tamsulosin or any antihypertensive like prazosin or any drugs, antipsychotic drugs or finasteride, such patients are high risk for developing floppy iris. And in case of floppy iris, you should have a very low threshold for using pupil expansion devices because if you have started the surgery and then pupil comes down and then you want to introduce the pupil expansion devices, the chances of complication while introducing any sort of pupil expansion device, let it be BHEX, let it be iris hooks or any Malugian ring, anything. So it's always better to be ready and you have to anticipate that this pupil is, how that pupil is going to behave during the surgery and act accordingly. So my funda is that if you suspect that this pupil is going to go down during surgery, it's always better to use pupil expansion devices. Now regarding choice of pupil expansion devices, there are various pupil expansion devices. BX is an excellent, and whichever pupil expansion devices you are comfortable with, without any ego, you should use it. But in challenging situations where there is a shallow AC, where there is a positive thrust from the vitreous, the intraocular pressure is high, AC is really shallow, in such cases to introduce pupil expansion devices like any ring is very difficult, and in such cases iris hooks, it's pretty easy, though you have to take multiple openings, like 5 openings you have to take, but still it is pretty easy and it's very easy to do the safe surgery. We can have additional opinion from Hardipurkar sir. Over to you, Hardipurkar sir.
You have covered most of it, dear Santosh. But I would like to say something. See, there used to be a time before the rings came on the horizon when we took a great, pride in showing that, through a small pupil also we could do rexes or we could do cataract. But now it's an understood thing that all the complications in cataract surgery come because of poor visibility. And small pupil is one of the ways in which one of the hindrance factors for better visibility. And today we have all kinds of expanders. There's no excuse that, well, I'm a beginner or I don't know how to use ring. If you don't know how to use ring, you can always use hooks because hooks are as good, except that you have to put multiple punches. But now, as Indians, at least we should be so proud that imagine Malugan's ring used to be so commonly used, and today practically everyone has switched over to BX and BX, Octa, B Octa. They're such lovely rings and so easy to use. I think this would be my appeal to all the surgeons, younger ones who don't use. If you're not using yet, get used to using it. And in fact, where the small people has got a proper regime. Like if you suspect a small people, probably you would start with atropine from 3 days before. You may use intracameral epitrade to expand. If it doesn't, then you use dispersive scholastic to open it up. Maybe you use Y hooks, a stretch pupilloplasty. Very often with stretch pupilloplasty also, a rigid pupil may open up and along with dispersive scholastic. So dispersive scholastic keeps it nicely stretched up. If these things don't work and you think it's a non-rigid pupil, then of course you have to use ring. There's no excuse. And with ring, your surgery becomes so much better. So because today in cataracts, there's no point in taking stress in the surgery. Surgery should be like drawing a painting, where you are absolutely stressless, and all that you need to do become stressless. And one of the things in a small pupil is to use a nice ring, expand it, finish your surgery, and get out. Like in this case, required a toric lens. With a small pupil, you can't even see where exactly the axis, steep axis is. So I think it's better to use. But anyway, it's a good attempt. Meaning your control on your cystodome is probably much better than what control I have. I'm so much used to using a forceps to do it. Now, another thing is, rhexis can be done in such cases, and especially white cataract, more comfortably and more securely with a forceps than with the cystodome. But you manage your cystodome handling very well. Congratulations.
Thank you, Professor and Videsa. So just like Nikhil is a fantastic surgeon, we have another surgeon who's in our expert panel, Dr. Pankaj Lande. Are you there?
Yeah, in fact,
Yes,
Nikhil
sir, I am
had
here.
some videos of pupil expansion devices also, but because of paucity of time, he couldn't show them.
Yeah. I feel
Act-
pupil expansion devices are definitely a boon for every surgeon and must be utilized depending on its own competency. Everybody should decide according to the case.
So Piyush sir, I was just wanted to conclude in the next session. Sorry, I couldn't follow the time. But how I shifted now from not using device to completely using device in every case, that was the gist of the presentation. As Aldipurkar sir said, now nobody wants stress, even if there is smallest hint, or of course for toric cases, you just can't do it. So even I have shifted totally to BX devices
Okay.
over time.
Thank you. So, Professor Vere, can we move on to the next case?
Yeah. We can move to the next case. The next case is on pediatric cataract by Dr. Yogesh Jayabhai. So, Dr. Yogesh, please start sharing your presentation.
Okay, good afternoon, everyone. Today I'm presenting a case of a pediatric cataract management. He's actually 10-month-old child having the zonular cataract, which is visually significant. So we decided for the cataract
Screen is
extraction
not
with
visible. Dr.
yeah,
Yogesh.
I'm sharing my screen now. Is it visible now?
Yes, it is visible.
So we decided for the cataract extraction with IOL and antibioticectomy under general anesthesia. So now we done the 2 side ports, made 2 side ports. Dye is injected under the air bubble. Capsule is stent. The dye washed out. Viscoelastic is injected inside the chamber. Now we made 2.8 carat of main entry. Nick is taken on the entry capsule by using the cystitol. Now switched on the microdose. 4.5 to 5 mm Rexis is achieved by using the balanced shearing and tearing forces. As we found, this nucleus is a little bit softer, so we don't use the phaco probe for the nucleus emulsification and nucleus management. The Rexis is achieved. Hydrodissection and hydrodelineation is done. Nucleus management done by using the bimanual IF probe. So, because of the softness of the nucleus, it is easy to nucleus management by using the bimanual IF probe. And is switched. Through the nucleus management, I found that I have a little bit difficulty to see the anterocapsular margin and posterior capsule. So I decided to reinsert the dye again to stain the capsule again. So here under the air bubble I again stain the capsule, and when we wash the dye, the capsule margins are very much visible. Now viscoelastic is injected, and then again nick is taken on the posterior capsule by using the forceps. 3 mm or 2 to 3 mm Rexis, posterior capsular Rexis is made. It is relatively easier to do the posterior capsule compared to the anterior capsule in these pediatric cases. A limited anterior vitrectomy done. Visco is injected and single piece hydrophobic IOL is inserted. Leading haptic is first inserted into the bag, followed by the gently we dial the trailing haptic in the bag. Visco wash done. The air bubble is injected and the sutures are taken in the main port and two side ports, 10-0 Y grade. Sutures are well buried, and that's the end of the case. Thank you.
Yeah, wonderful surgery, Dr. Yogesh. Will you please stop sharing the screen?
Yes. Okay, just a minute.
Yeah. Now I request Dr. Bhide sir to give his expert comment.
cataract? Yeah, excellent surgery, Yogesh.
Thank
Very
you, sir.
easily shown the posterior capsulorhexis also, but you did not do vitrectomy through the.
Yes, sir, I did the vitrectomy.
So
There is a little part of vitrectomy, but I did.
part of the vitrectomy was done. Okay. No, excellent surgery. There is perfect surgery, I would say.
Thank you, sir.
Nothing to add actually.
Dr. Lande, are you there?
Yeah, Adipurka sir is there. He will tell something.
Yeah.
Yes, ma'am, I'm here.
Okay. Your comments, please.
Ma'am, first thing about the rexes, everybody should start with smaller rexes. That's what I would say. And forming the anterior chamber in the last, it was like slightly more, you say, not very rigid. And I personally like to use three-piece IOLs in cases of pediatric cataracts because they are more stable, hold the bag nicely. Using a CTR is also very important in cases of pediatric cataracts. And personally, I feel if we have a refractive surprises by the age increase, the three-piece lenses optic can be exchanged with another three-piece lens in the sulcus. That is one technique which we can use, and that way pediatric cataracts can get a better result with age increasing for the child. So I would definitely recommend a three-piece IOL use.
Thank you, Dr. Lande. Now I request Dr. Hardeep Professor to give his expert comments.
Yeah. One thing I must tell, the surgery is done extremely well. You have a good surgical hand.
Thank you, sir.
But in pediatric cataract surgery, the cataract surgical part is only 20%. The 80% is the management, pre and post. So what is the other eye status?
Sir, actually, it is a cataract. So I posted him for the another cataract surgery after 7 days.
You mean he's a bilateral cataract?
Yes, sir.
So in pediatric cataract, for the benefit of the viewers, you can tell us how did you decide the IOL power? What formula did you use?
Sir, actually, by 7 minus age of the patient at presentation, we usually use. So we kept as a +6 as a residual for this patient, as he is a 10 to 12 months old child. So we considering his age as a 1 year. So we take as a +6 as a after post-refractive surgery. It should be the residual refractive error should be there.
Okay. And when you said limited anterior vitrectomy, please define that.
Sir, we do only, if there is a no vitreous, we only do the anterior vitrectomy, 1/3 of the anterior vitrectomy. We don't do the core vitrectomy. Just any strand which are the prolapsing from the capsule, posterior capsule, we just trimmed out it only.
And what has been your experience like in the past when you have done such pediatric cataracts? When the children grow up, how often have you seen myopization or your need to either change a lens or put a piggyback? What is it? What has been your experience so far? What do you have?
Sir, actually, I'm doing this cataract surgery since 6 or 8 months. I just finished my fellowship recently. But previously, I've seen that there are little bit refractive surgeries. There is a chances of the myopia progression always there in these patients.
So between single piece and three piece, is single piece your preference?
Actually, sir, three-piece is a preferred, but there is a little bit chances of the iritis and the reaction is more there. So pigmentation on the IOL is sometimes I found in the three-piece IOL. So we shifted into three-piece single-piece IOL, which can be implanted in the back.
Yeah.
Because of the
Yeah.
haptics are.
No, but one thing is certain that these patients eventually, if they need, refractive changes, refractive corrections, today, of course, second IOLs and piggybacks have also come down.
Yes, sir.
Refractive surgery itself has become so very good. But I think you did the right thing. You really done it well. Good. You have a good surgical hand. Congratulations.
Thank you, sir.
Comment on staining the capsule again.
Actually, sir, I found there is a little bit difficulty to found out the anterior and the posterior capsule. Usually, when we place the IOL, should be a difference of at least 2 mm between the anterior and the posterior capsular rhexis. Then we can place the IOL. If there is a larger the posterior capsular rhexis margin compared to the anterior capsule, the IOL is not will not be uh, placed in the bag. So.
No, I think, in fact, this staining it again also improves your visibility. So I think
Yes, sir.
you're justified in doing, and you did it well. Very nice. A lot of learning points.
Yes.
Doctors?
Thank you, everybody. So with that, we will move to our next phase, and next phase is phacoemulsification in hard cataract, and this will be presented by Dr. Priyanka Sathe. So I request Dr. Priyanka Sathe to share her screen and start presenting. Dr. Priyanka?
Yes, ma'am. Just give me a minute. I'm just sharing my screen. Is my screen visible?
It is not.
Once.
Yeah, now it is visible.
Can you see my presentation, ma'am?
Yeah. We can see your presentation. Just make it full screen.
Yes, I will do that. All right. Good evening, everyone. I'm Dr. Priyanka Sathe. I am a consultant in cataract and refractive services in Dr. Agarwal's Eye Hospital, Vasai. I will be presenting a talk on nuclear warfare, in which we will be discussing strategies to manage hard cataracts. So first of all, it's essential to know what kind of case of cataract we are dealing with. So hard cataract, by definition, is an advanced, dense clouding of nucleus, which often leads to brown to black discoloration. And the challenges that we are posed with is that the lens is much larger in diameter than in routine cases. It is having increased thickness and usually stone-like density. And sometimes it can also present as a leathery kind of cataract, which becomes difficult to separate at the time of surgery. There is a requirement of higher phaco power usually, and it can cause zonular stress. At the time of surgery, it may be noticed that the zonules suddenly become weak, and there can be a frank dialysis as well. Rhexis may run off, and there can be corneal endothelial damage. So how do we strategize the management in these cataracts? A thorough preoperative evaluation is imperative in these cases, and slit lamp examination will not only reveal the grade of cataract, but it also tells us a lot about the health of the corneal endothelium, whether there are any guttae present, how the anterior chamber is, whether it's deep or shallow, what kind of a pupillary dilatation we are dealing with, if it's a poor pupillary dilatation or it's adequate for the cataract extraction, and of course the grade of cataract and the status of the zonules, if there's any phacodonosis. Specular microscopy and ultrasound B scan are very essential in determining the outcomes. We need to know the status of the vitreous and retina because we do not have any view in such cataracts of the posterior segment. Counseling has to be done properly and transparently with the patient because we need to explain to the patient the nature of the cataract and what we are dealing with, what the potential complications are, so that there are no surprises post-operatively on part of the patient and the surgeon.
Priyanka, please hold on. Please hold on. Do you have a video because you've already completed 2 minutes? You've got just 3 minutes remaining.
Yes, I'll just skip to the video then. So.
Yes, so we'll just see how to manage the direct chops in case of hard cataract and how to exactly separate the nucleus. So after staining with trypan blue, the capsular rhexis is performed here using a rhexis forceps. Rhexis can run off, so it has to be done under a lot of use of viscoelastic liberally and in a controlled manner. Sometimes we may have to do spiral rhexis as well, in which we start off smaller, but then as we proceed, we can gradually increase the diameter of the rhexis. So after hydrodissection, the lens is freed a little from the capsule. And then with the phaco probe, it is essential to know your settings in these cataracts. We need to have adequate power to be able to hold the cataract and impale the nucleus well with the phaco tip. So here you can see that the second instrument, again, this construction of the side port becomes important. It has to be 60 to 80 degrees from the main port for optimization of the position of the chopper. Preferably a sharp chopper should be used in these cases to separate the nucleus well. So here you can see that the phaco tip has impaled well at an adequate depth, and the second instrument is used to separate the nucleus all the way until the posterior plate. And in these cataracts, it may be wiser to make more pieces, more fragments of the nucleus instead of just 4, so that we can easily emulsify, bring them out of the bag and then emulsify, because the nuclei tend to be very, very large in these cases. So over here, about 7 to 8 fragments are separated, or created rather, and then they're all brought out. During quadrant removal mode, we have to ensure that the vacuum is adequate. In higher end machines, like in this one, Centurion, we can use up to 700 plus vacuums to bring out these fragments in at the pupillary plane and then emulsify one by one. And phaco power should be applied only when the piece is at the tip, not before, because otherwise it just gets transmitted to the surrounding structures. This is the second case. I just wanted to highlight the use of femtosecond laser in cataract surgeries, wherein flax. So we can use femtosecond laser here to create a precise rhexis, and we can fragment this nucleus, just like you can see there's a waffle pattern here. So that you can use less. So this leads to usage of lesser power because the nucleus is already fragmented using laser. So you just have to separate the fragments and then emulsify. So compared to routine cases where femtosecond laser is not used, we end up using lesser power here. So that becomes beneficial for the endothelium, the zonules, the iris. So once the capsule is separated, the rhexis, we can just proceed like usual. Yeah, see, it was much easier in this to separate the nuclear fragments because they're already fragmented using laser. So if we have this platform at our disposal, it may be a wise thing to do in these cataracts to go ahead and use it. And then again, actively use the second instrument in all cases so that mechanical division can again ensure that you are using lesser phaco and you're reducing phaco time essentially.
Dr. Priyanka, will you please sum up?
Yes, that's it. I just wanted to highlight, this is the last slide. So we need to plan every case in these cataracts. Go ahead with chops more than sculpting can again induce some sort of zonular stress. We must protect the endo.
Thank you, Dr. Priyanka. I think, yeah. So I request Dr. Santosh Bide sir to give his expert comments.
Actually, very good demonstration of both the surgeries. For hard cataract, some tips are that first thing is the choice of surgery. Everyone is not, there is no access to flax to everybody. So I think let's not discuss about flax in hard cataracts. But Ozil technology definitely helps in emulsifying the hardest of the cataracts. Number one. Number two is the proper use of viscoelastic substances. Like there is a very well established Arshinov's soft shell technique is there. So if you use Arsenov's soft shell technique, you will definitely protect endothelium during the surgery. Third thing is that status of zonules is also important. If the hard cataract and the lens is also the zonules are also weak, then you have to be more careful. Uh, the size of capsulorhexis should also be appropriate. If you make a small capsulorhexis, then there is a chance of more zonular damage during emulsification. And chopping technique, of course, chopping helps rather than sculpting. So, very good demonstration all in all. And another thing is that if you feel that the cataract is very hard, the zonules are weak, then there is no harm in converting, and instead of doing phacoemulsification, you can straight away do manual small incision cataract surgery also. With nucleotomy techniques, you can remove hardest of the cataracts through a fairly smaller sized tunnel, and you can give very good results, and you can protect endothelium also, because our aim is to give good vision. It's not the aim is not to do phaco, but aim is to give good vision by keeping cornea clear. So these are certain tips.
Thank you, sir. I request Dr. Pankaj Landre to give his comments as well.
Yeah, as said by Santosh sir, I like to say first thing first that every surgeon know their limits, and every case they can manage how depends, and everybody must be ready to do SICS in such cases where they find it difficult. So wherever possible, we must try to give a better result rather than going for only phaco. Many of the newcomer surgeons find it difficult to judge the cases in such scenarios. I see that it is better to perform SICS. Even though I'm a very much pro for phaco in hard cataracts, I usually use ultrasonic pre-chopper, uh, which I use Dr. Neha Dolaki as IOL cutting scissor uh, as a ultrasonic pre-chopper, and additionally mechanical pre-chopper. Dr. Sohail has it, Dr. Pradeep Mohanta has it. So these type of pre-choppers also help in such hard cataracts. After debulking the nucleus, we can manage it well. Reforming the anterior chamber again with the high density viscoelastic and protecting the endothelium with HPMC is something which is very important. Additionally, I think whenever we are cracking, the left hand use has to be mastered. Somebody has to have a very good control over the left hand maneuvering, and that will help the managing the hard cataract. So another tips and everything is shown by doctor is very good, and the presentation was nice.
Thank you. Thank you, Dr. Landre. And I request Hadi Professor to give his expert comments.
Yeah. Priyanka, you did a good job. I saw your CD was not very high. It was very much within respectable limits. But what I noticed was that you are using an IOP of 30. And at least these are the instances when you're dealing with hard cataracts, you can comfortably be at 40 or 50 because, uh, these are the cases where you want better followability. So you can increase your aspiration flow rate, you can increase your vacuum. I noticed your aspiration flow rate was around 20, 25, 26. It wasn't very high. you could have comfortably worked at high because the nucleus was very hard. It demanded much better followability, and your vacuum structure was like a mountain. Like it would start, and at the halfway it would go to the peak, and then it would come down. So that's a pattern. I don't know why you use it, but then maybe it works good in your hands. But these are the cases where you reserve your burst mode. See, FACO technology has given us such excellent different modes of using FACO. So burst mode is specially meant for these cases where in a burst mode, you chop them into multiple pieces, and then you can come back to quadrant mode and carry on with. Even your FACO power was up to 70. I think these are the cases where you can, anyway, it's on a linear. So you could always work on little more and make it little more efficient or little more faster. I don't know how much time it took you because it's an edited case. But you could have done, not that you could have, I would have done it this way. That's how I would put it. But you have done it very well. Congratulations. And it's a good case. Thank you, Varstana.
Sir, she was using Centurion. That's why she kept 30 millimeters pressure.
Yeah. So
with 30 also she was getting good followability.
I know.
Other basic
For a hard cataract,
problem.
see, you can work at 20 also. People do work, but then if you're, like if you want to be a little more stable in a chamber, 40, 50 is not bad. See, we know that if the posterior pole is not good, your zonules are weak, then you try to stay at low IOP. But then these are the cases which demand little higher IOP than 20, 20, 30.
So she had access to torsional phaco. Suppose you don't have access to torsional phaco. Any tips from your side, sir?
See, well, it's just say like, see, how would it matter? Like if I have to do like this case on my Centurion, for my burst mode, I would always go to longitudinal. See, burst mode works on the longitudinal. And then for quadrant removal, I would come to torsional. But if I didn't have the torsional technology at all, then I would naturally do everything with longitudinal. But in burst mode, in chopping, it's a burst mode, and quadrant removal, it's the other way. But longitudinal should work and probably works better.
The hold is much better with the longitudinal.
Yes.
Pardon me?
The
Hold
hold
better
of the
with
nucleus is very good with the longitudinal, and so the crack is very easy. With torsional, you keep cutting and eating more, so hold becomes difficult.
No, but with torsional emulsification is easier, no?
Yes.
It's much easier with torsion.
Yes, the first job with torsion is difficult. With longitudinal, more power, we can have a better hold and a first good job.
Since we have 6 more minutes, is Nikhil around? Dr. Nikhil, are you there?
Yeah, I think he's there. I can see him.
If you would like to quickly
Dr. Nikhil?
show his video with the iris hooks.
I call him?
No, sir. If he's there, we can.
Sir, sorry, I just shifted the device.
No problem. Don't worry about it. So I think we still have around 5 minutes. One point, of course, not related to cataract. What I would like to mention to young surgeons watching or planning to present is that please always respect the time that is allotted. If you, even before you present it, if you're not confident how much time it is going to take, always take some time, present it, do a practice rehearsal so that you don't shoot the time that is allotted. And more importantly, you are focused on the points that you would want to bring out rather than having too much of information being put into the presentation. Have the slides concise so that you don't overshoot time and your point is driven very clearly.
So this was an excellent session with very practical and clinical relevant discussion. and all the topics, they were extremely well covered and they're highly useful. I'm sure they're very useful for all the cataract surgeons. So I congratulate all the speakers and I thank Dr. Haripurkar sir, Dr. Santosh Bede sir, and Dr. Pankaj Nande sir. Then congratulations to the MOS team, Dr. Piyush Bansal, Dr. Anagha, Dr. Preeti, and Dr. Sumit Lahani. So I thank everybody, and now with Haripurkar sir's permission, we can move to the next session.
Thank you. Thank you,
Thank you
Archana.
so much. Thank you so much, everyone.
Thank
Your speech very well done. Huh? Thank you.
Thank you, sir. Thank you for sharing such lovely, lovely points. Always a pleasure. I'm sure so many young surgeons, senior surgeons alike, they've just been waiting for your expert comments since morning.
Thank you.
Pitamaha, Pitamaha.
Thank you so much. Thank you. Bye-bye.
Okay, okay.
So, Dr. Sumit Lahane and Dr. Aditi Watve will be moderating the next session on oculoplasty. Dr. Aditi is there.
Sumit is also there. I can see him.
Sumit is there.
Our
Great.
panelists and everybody has
Hi,
also
Sumit.
joined.
Good. So over to you, Dr. Sumit.
Unmute, Sumit.
Okay. So good afternoon, everyone, and thank you all of you for being here. And with the continuation of the midterm Moscow, now we are shifting gears to the oculoplasty. And we have a very nice talks and the expert panel. So without wasting much time, I will hand it over to my co-moderator, Dr. Aditi ma'am, to take over the oculoplasty session.
Hello all, and good afternoon to a wonderful oculoplasty session, shifting gears from intraocular to few extraocular or periocular things, I would say. So we have wonderful cases from different areas of oculoplasty. I would like to introduce our chairman, Dr. B. Vidyashankar sir, who is a very renowned and senior oculoplasty surgeon from Mumbai. Welcome, sir. We have our expert panel, Dr. Sonal Yadav from Pune. Hi, Sonal. Dr. Ravindra Ankade from Solapur. Dr. Nirav Raichura from Mumbai again, and Dr. Mangesh Dobekar, who is the faculty at Ganpati Netralaya, Jalna. We have our four cases. The sequence will be Dr. Sumer will be presenting first case, then Dr. Ocean, then Dr. Khushi will be presenting the third case, and Dr. Gaurav will be presenting the fourth case, which will be followed by Dr. Ramesh Murthy sir's enlightening talk on pearls in ptosis management. So without wasting much time, utilizing the extra 2-3 minutes which we have got from the cataract session, we would move on to the case presentation. Dr. Sumer will be presenting a case of extensive conjunctival melanoma, the dark side explored. Over to you, Dr. Sumer.
Thank you so much. At the outset,
Slides are visible.
that's great. I would like to thank Dr. Aditi, Sumit sir, and the entire team who has helped organize this wonderful session. I'd also like to thank Dr. Sujata, without whose support I wouldn't have been able to manage this patient. So thank you so much, everyone. I hope I'm audible. I'll go ahead with my presentation. So as Dr. Aditi mentioned, we are going to discuss conjunctival melanoma through the lens of this elderly lady. She's a 82-year-old lady who was brought to me by her family with a very large black lesion with a pink mass protruding out of it since the last 6 to 8 months. An uncontrolled diabetic, hypertensive, she had history of heart disease and stroke in 2016. And she also had undergone 2 biopsies of a similar lesion in the same location as per her family. We don't have any old photographs and we have minimal reporting of these lesions, but we'll go through in the subsequent slides. She also had a whole body PET scan, which was done in 2019, and the report was normal. The biopsies also I will discuss further. So just to go through her clinical timeline, in 2019, she had a medial canthal mass, which was biopsied, and that report clearly states it was negative for a malignancy. The targeted imaging done then was normal. She was lost to follow-up, and in 2025, she once again had a medial canthal and conjunctival mass, which was biopsied, and the histopathology was suggestive of conjunctival melanoma. Uh, at that point, a whole body PET scan and other further investigation was advised to her, but once again, she was lost to follow up. And she then presented to me a year later with this large, extensive black mass, which had a very large 6 by 4 centimeter mass protruding out of it, which was pinkish in color with necrosis within it and some surface ulceration. I could interestingly see the globe underneath all of this large, extensive mass of the upper and lower lid. The globe was mobile, and she also had a 6 by 12 vision in that eye. However, the mass was, I could see it extending all the way, and it was also palpable till the anterior orbit. At this point, I decided to image her, before which I did a lymph node palpation, where only the cervical lymph node and a large node which was close to the thyroid gland is what I could palpate, but there was no preauricular or submandibular lymph node palpable. So at this stage, we decided to go for a PET scan, which she was clearly non-affording for, and the family was very clear that they could not spend as much money as possible. So we decided to have her undergo targeted imaging in the form of an HRCT chest, USG abdomen and pelvis, and the USG of the neck for the lymph nodes. And also, while I'm aware that looking for a BRAF mutation on an incisional biopsy and also the help of checkpoint inhibitors, immune checkpoint inhibitors would be the ideal line of management, the family was extremely non-affording, and the only armamentarium that I had at that point would have been a lid sparing orbital exentration with cryotherapy, possibly radiation, although melanoma is radio resistant, but these were the treatment modalities that I was looking at considering this patient situation. So now that we look at the imaging, so here we can see that the tumor has invaded the anterior orbit and it is compressing the globe. The HRCT chest, USG abdomen, pelvis were normal. And we also noted that the USG neck had a subcentimetric lymph node on the right, subcentimetric lymph nodes, as well as a node which was there on the right lobe of the thyroid gland, which was highly suggestive of probable malignancy, but of course, because it was TIRADS 4, it warranted biopsy. We went ahead with our orbital exentration, and on gross examination, there was a dark pigmented soft to firm lesion, which we can see as described. All of the margins were free of the tumor except the superior soft margin, the superior soft tissue resection margin was just 1 millimeter away, but all the margins were free of the tumor. We also went ahead with immunohistochemistry where SOX10 and MELAN-A were strongly positive, and all of this pointed to a diagnosis of right eye conjunctival melanoma involving the palpebral conjunctiva, right upper eyelid, as well as the lacrimal gland. And the closest dissection margin, as mentioned, was within 1 millimeters. The post-op plan was, of course, local wound care, aspiration, biopsy, and FNAC of this node, which was performed, but it was just hemorrhagic. So we are going to go ahead with a surgical biopsy for the thyroid nodule and plan a long-term surveillance for her. Just a bit on conjunctival melanoma, the lesion we encountered was T3, And exenteration was chosen as the treatment modality because of the situation that this patient was presented to me with. And sentinel lymph node biopsy is something that is now getting more popular in the West, which could have been a good option for her if it was available. And as I mentioned already, the immune checkpoint inhibitors. So my question to the panel here, as we end, would be to Sonal ma'am as well, that would you consider radiation in this situation, considering a situation and also that melanoma is radio resistant? Thank you so much for this opportunity.
Excellent case, Dr. Sumer. Over to the panelists for the discussion. Dr. Sonal, your comments, please.
Yes, nicely presented, Dr. Sumay. And I would agree with you on the line of management regarding the orbital exenteration, looking at the extent of the disease. This was the congenital melanoma with orbital invasion, right from the get-go, right from your kind of presentation. With respect to your focused question, though, yes, it is a it is recognized as a radio-resistant entity. That's why we don't use radiation as a primary treatment modality or even as a neoadjuvant treatment modality. However, as an adjuvant treatment modality, to take care of those little micro residues, if at all any, we I would go ahead and radiate the orbit to devitalize it and just to have a chance of devitalizing any remnant tissue. Though your specimen, the histopathology reported shows free of tumor, the issue with these tumors is more of a lymphohematogenous spread along with the direct invasion wherever possible. Another important point was yes regarding the sentinel lymph node biopsy. However, I think that point has been crossed in your particular clinical scenario because you kind of have a suspicious node, though it didn't come out on FNAC. Then the biopsy would be a right next step to diagnose and stage the disease completely. I'm not sure when the last whole body PET CT scan was done. Whatever the time difference was there. However, again, very, very important to note that for the tumor to or even distal metastasis to show on the PET CT scan as well, you would need at least 1 by 1 centimeter cube tissue to be present elsewhere. So we might be still in the in between window where micrometastasis might have started happening. Another clinical important question here I would like to ask you, if there were any pagdas visible and were you able to demonstrate any kind of regurgitation or any SAC evaluation was done preoperatively, and what were your steps to negate the nasolacrimal duct during your exenteration? Where did you completely kind of cauterize the nasolacrimal duct and obliterate that passage from the socket to the nose during the surgery, or not?
Right, ma'am. Thank you for that question. So, just before I answer that, just two interesting things about this patient. First was that despite not having any lymph nodes till the kind of the basin of the nodes of the cervical node, nothing was palpable till that cervical node, which was an interesting finding. The second thing that is also interesting is that, as we know, the lungs, the liver, and the brain are the three main sites of metastasis and when it comes to conjunctival melanoma, and this lady had none of the above and happened to have this interesting thyroid nodule, which could definitely be an incidental finding, but we'll see what the biopsy reveals. If it is related to this melanoma, it would be the first case that's, I mean, it's never been reported yet in literature of a thyroid metastasis of a conjunctival melanoma. And to answer your question, ma'am, we did not perform an irrigation because I was not sure. I didn't want to migrate any cells directly, but I did do a probing prior to the exenteration, And the probing did not have any kind of soft stops in the way, but yes, I did cauterize and fulgurate the opening, as we know that lacrimal sac involvement does significantly worsen prognosis in the tumors in general. So I did manage to do that, and the end grossly what I looked at did not appear black or involved by the tumor per se.
Yeah, that is good. So because in such cases, even though yeah, it might not be completely visible, but cauterizing and obliterating the remnant of NLD after you have cut through during your exenteration would be advisable. We have done a series of cases where we have termed this as an onchoria of the because melanoma is histopathologically very a discohesive tumor. So the cellular dispersion through the cul-de-sac is known to happen. That is just to again prevent any direct invasion in the rest of the nasal mucosa as well as paranasal sinuses. And again, going back to what we discussed regarding the thyroid nodule, definitely would be interesting to know if that is involved. I think you talked about a cervical node also being involved. It is not unknown for these lesions to skip the sequence of the lymph nodes. They can directly go to the collecting node. You might not have the most common would be parotid and submandibular. However, without being without completely biopsying them and understanding if the cells have passed through, they can skip the usual enlargement and can lodge into the mother node of draining node, of course. So, for to
Question, Sunil, I would
summarize,
like to slightly
yeah,
interrupt. Maybe we may need to move on to the
yeah,
next case, and
definitely,
maybe we'll
definitely,
discuss it, come back to this again if we have time left
definitely,
for
definitely.
further more
Thank
discussion.
you.
So next case will be presented by Dr. Ocean. You can start sharing your screen by that time. She'll be presenting ptosis, the invisibility cloak, and Dr. Ravindra will be the expert panel to discuss the case. Over to you, Dr. Ocean.
Thank you, Dr. Aditi. A very good afternoon to everyone. And at the outset, I would like to thank Dr. Aditi Watwe, Dr. Sumit Lahane, and the entire organizing committee for this opportunity. After the brilliant presentation by Sumer, this is more of a subtle and quirky case of ptosis, as labeled the invisibility cloak. So no financial disclosures or conflicts of interest. Consent for full face photographs were taken. There was a 65-year-old female presenting to our clinic with painful drooping of right upper lid since 1 year. She had a history of right eye cataract surgery few weeks before these symptoms started. No history of diurnal variation, no complaints of diplopia, and she was not having any known comorbidities, not diabetes, hypertension, or thyroid. On examination, her visual acuity was 6.6. The right eye upper lid showed ptosis with an exaggerated medial droop. Levator function was good. Bell's phenomena was good. Fatigue test was negative. Her extraocular movements were full and free. Pupils were round, regular, and reactive, no RAPD, and there was no proptosis. So what would be the next step? Well, the patient had already consulted elsewhere, and she had come with prior investigations. MR angiogram brain was done probably for painful ptosis, which was normal. Thyroid function tests and ACH receptor antibody tests, again, were normal and negative. So if anybody would like to chip in, what would be the next step they would like to do? I can give 5 seconds probably from the presentation, if that's okay with everyone.
No, I think you can go ahead.
Okay, fine. So let's give you a little hint. Look at the medial droop and the medial superior sulcus fullness. And let's think about whether you want to do CT, MRI, or ultrasound. Well, what about just evert and look at the lesion, which was a well-defined cystic lesion extending from medial to lateral canthus, arising from the foveal conjunctiva, fluid-filled, and transillumination positive. So a provisional diagnosis of right eye mechanical ptosis secondary to conjunctival inclusion cyst was made, and we planned for complete cyst excision. On table, a beautiful conjunctival cyst was dissected, which was lobulated with fibrous septa present, indicating trivial trauma, which has caused the cyst. And the cyst was excised in toto. The conjunctival defect was then covered with amniotic graft and secured with glue. So post-operatively, 2 weeks, the AMG had taken up well, and there was no residual ptosis or lesion. The transition from the pre to post photograph is showing dramatic change. The patient was happy and there was no pain at all. Histopathology showed cyst lined by conjunctival non-keratinized stratified epithelium with goblet cells, suggestive of conjunctival inclusion cyst. These cysts could be congenital or acquired, more commonly acquired. And the common reasons behind them are trauma, surgery, or chronic inflammation, which can introduce loose epithelium into deeper tissues, triggering the formation of inclusion cyst. The management of such cyst is complete excision along with the cyst wall to prevent recurrence. So the takeaway points from this kind of a case is meticulous history taking, including history of past trauma or surgery is essential. A thorough examination of upper eyelid, including the eyelid contour, and superior sulcus palpation as well as upper eyelid palpation can give us important clues towards the diagnosis. Always avert the lid to examine the tarsal conjunctiva and fornix. Complete excision of cyst wall is essential to prevent recurrence of in case of inclusion cysts. So lift the invisibility cloak of ptosis to reveal the secrets underneath it. Thank you from the entire Nandadeep Eye Hospital team, and thank you again to the entire organizing committee for this opportunity. I would like to invite the expert comments and questions, please.
Good case, Dr. Ocean. I think the key takeaway point here, which needs to be emphasized and re-emphasized, is eversion of the eyelid, which most of the times reveals the real enemy behind the lid. May it be some onco thing or maybe just a simple cyst causing ptosis. So over to you, Dr. Ravindra, for the discussion.
Yeah. A great presentation, Dr. Oshin, and very simple case, but interesting case. And typical medial ptosis. Even I have a similar case presentation and a same diagnosis. I have faced one of the case and it was an inclusion cyst, but the droop was quite, complete ptosis. Not complete in the sense, whole of the margin of the eyelid was involved, not only medial. And the most important thing which you already pointed out, ki good examination, eversion, and palpation would be very important in this case. At first sight, I thought it might be just a lymphoid hyperplasia,
Maybe you can stop
something of that
the
sort.
slide share till then.
Am I audible?
Yeah, you are audible.
Yeah.
Just
Okay.
requesting you. Yeah.
Okay. So initial first sight, I thought it is some kind of lymphoid hyperplasia, but the way she presented and everything is clear and the management is good. Over to all the panelists.
Dr. Vidyashankar sir, would you like to add anything, your pearls of wisdom?
One thing is a question to the speaker, Dr. Oshin. Would it always be necessary to operate? Number one. Second, is there any role of any sclerosants in this? Once you have diagnosed what it could have been, because that would prevent the angst of going in for surgery for the patient.
So thank you so much, sir, for the question. I would say no, not always in inclusion cyst. It depends on the symptoms, on the location of the cyst, whether we want to go ahead with the procedure or not. And sclerotherapy is very well and recommended treatment modality. Sclerosants can definitely help in inclusion cysts. Recurrence rate is quite low. But in my personal experience, I think excision gives a very good outcome and absolutely no recurrence post-excision.
Okay, well taken.
And I
Dr.
think
Oshin,
same, sir, ki complete excision would be ideal in this case, I think.
just one
Yeah, go ahead.
question.
Sorry.
Yeah. So what is probably inquisitive about is what explains the pain in this case. Because from the pictures, at least we can make out that it was a simple cyst, probably no inflammation involved there. So probably pain was a symptom which would put you off the diagnosis. You would think of something inflammatory going on in the orbit.
So I think, Dr. Nirav, thank you again for the question. So I think it's basically the large cyst which was constantly causing the pressure of the globe, and that was probably perceived as pain by the patient. And that is why the clinicians or, diagnosticians were going off the route.
Right. Yeah, could be. Like the patient probably experienced some kind of heaviness, which was described as pain. That could be a possibility. Yes.
Great case, simple case, but a lot of takeaway points and good discussion, I must say. So we'll move on to our third case, which will be presented by Dr. Khushi Khurana. Back to normal. Over to you, Dr. Khushi. There has been a bit of change in the presenter. So let us welcome Khushi and please share your screen. Dr. Neerav will be the primary discussant panelist. The earlier thing which you were doing, I think.
Doctor, click on the presentation, please. Just click on the presentation at the bottom.
Yes. Make it full screen, please. Yeah, we can see the presentation. Kindly start presenting.
Doctor, please don't switch the windows. Just click on the presentation and start sharing, please.
You're probably muted.
And just make it full screen in the slideshow mode, please. Thank you. Just click on the screen. You should be able to move the slides. Thanks.
Yeah. Sunilji, maybe she needs to get unmuted. Can you help her in
I'm
unmute?
trying to ask her to unmute, please.
म्यूट ही नहीं हो रहा है. Hello, good evening. Am I audible?
Yeah.
Yes.
You're audible. Just switch to the presentation.
Sorry. Good evening, everybody. Today I'm going to present a case on successful repair of an ocular trauma titled Back to Normal under the moderation of Dr. Mangesh Dubekar, sir. This is a case of 16-year-old male who came with the complaints of pain around the left eye and double vision since last 12 hours, with a history of trauma by an iron rod to the left eye while working at night. It was also associated with a history of single episode of vomiting. There was no history of loss of consciousness and ENT bleed. On examination, the visual acuity was 6.6 N6, pupil was normal in size and reacting, and no RAPD was noted. Posterior segment was also within normal limit. On further examination, the medial canthal injury and medial canthal tendon avulsion can be noted. Upper and lower eyelid tear with involvement of both the canaliculi, and it was associated with anterior prolapse of the orbital fat and medial conjunctival tear. On extraocular motility testing, we can see there is limitation in adduction by -3. Hirschberg showed left exotropia and binocular diplopia was present. CT orbit and brain was advised. There was no evidence of orbital wall fractures. Orbital emphysema can be noted. Plus, as compared to the left medial rectus, the right medial rectus seemed to be bulky. On the coronal section, muscle injury can be seen along with the swelling around it, probably due to disinsertion or transaction leading to hematoma. On another axial section, there was an evidence of muscle discontinuity with the possibility of muscle transaction, which can be seen here. A provisional diagnosis was made of left eye medial canthal injury with medial orbital fat prolapse, with medial canthal tendon avulsion, with upper and lower lid avulsion, with bicanalicular involvement and traumatic squint with diplopia. query secondary to the medial rectus transection. Surgical plan of action of left eye wound exploration and reconstruction was made under general anesthesia. Pre-op counseling was done for residual squint, risk of residual squint, diplopia, epiphora, need for additional lacrimal or squint surgeries. Intraoperatively, the wound was explored. Medial canthal tendon wound was explored. A superficial debridement was done. Anteriorly prolapsed fat was reposted back. Evidence of MR transection at 5 mm from its insertion was seen, which was associated with hematoma. A medial orbit was then further explored to retrieve the distal stump of the MR. Due to associated hematoma and deeper location of the distal stump, it was difficult to retrieve and anchor the distal end with sixovical sutures. Once retrieved, the proximal and distal cut ends of MR were anchored together with sixovical suture. Further exploration was done to locate the distal ends of the torn canaliculi, and they were located on either side of deeper part of MCT. A mini Manoka stent was inserted through both the ends with pericanalicular sixovical sutures, and MCT ends were also anchored together with fivovical sutures. Conjunctival tear were then closed with fibrin glue. Upper and lower lid tear was then closed in a layered manner with sixovicryl. This is the on-table image after completion of all the procedures, and we started the patient on topical and systemic antibiotics and oral steroids post-op. This is post-op 1 week follow-up showing patient in orthotropic in primary gaze, and upper and lower lid were well opposed to the globe with mini Manoka stents in situ and healthy wound. On dextroversion, -1 adduction limitation with no diplopia in primary and down gaze were noted. In post-op 1 month follow-up, patient was orthotropic in primary position, adduction was improved, wound was healing well with no watering or diplopia. This is the post-op 3 month picture, which showed excellent cosmetic recovery with restoration of extraocular motility in the field of medial rectus. Plus, other extraocular motility was also full free and normal in all the directions. This is the pre-op and post-op image, which shows near perfect restoration of the anatomical structures, and the patient was highly pleased with the structure and cosmetic results, ensuring that the patient truly moved back to the normal. What are the learning points? An ocular trauma can present with a challenging clinical scenarios. Misdiagnosis or misdiagnosis are very common in such cases. Primary intervention gives the optimal outcome. Identification and retrieval of the MR is a challenging task. Early intervention of the MCT and lacrimal injuries is of paramount importance. Careful evaluation and thoughtful planning with meticulous surgical intervention results into promising functional and cosmetic outcomes. Thank you for your patient listening.
Excellent presentation, Dr. Kushi, and very well managed surgically, Dr. Mangesh. Kushi, you can stop sharing your screen. Dr. Neerav, your comments, please.
Yes. Very nice case, Dr. Kushi. Very well managed and very well presented. So you have also highlighted the take-home points very well. This is quite rare, a laceration of the medial rectus, you would say, mid muscle or mid belly laceration with, bicanalicular injury. One question that I want to ask you is, was any periosteal fixation done for the medial canthus?
Periosteal, sir, in the sense it was anchored to the posterior lacrimal crest and the
Okay, right.
just the
Yeah,
anatomy.
so that is very important in most of these cases, anchoring to the periosteum. Some method should be used. You could just take non-absorbable sutures like Prolene 50, or if that is not possible, then there are also methods described where you use mini plates. Mini plates are fixed to either the anterior lacrimal crest or the posterior lacrimal crest, and non-absorbable sutures are used to fix the canthus to the mini plate.
Yes.
So this was very well managed, and the outcome was excellent, superb outcome. 3 month post-op, I don't think anyone can make out that patient has undergone any surgery. So very excellent outcome, Dr. Mangesh.
Any other comment?
Another thing is that in the medial rectus injury, again, this to find the stump is very challenging. It was excellent that you have found out the stump and you have anastomosed it, and the ocular motility has also returned back to normal. Here, I would like to mention that the duration, like the time between the injury and the repair, is very important. The earlier you do, you get better results in these kind of injuries. Otherwise, the muscle retracts more, it undergoes fibrosis or it undergoes ischemia, and then the results are not very good. What was the duration between the trauma and the repair? Can you tell me?
It was less than a week. Like
Okay.
the trauma occurred around, yeah, it was less than 5 days.
Okay. Right. Nice. Wonderful.
Thank
Any
you.
other comments from any other panelists, Dr. Vidyashankar sir? Your expert comments, please.
Beautifully managed. I think I should do my fellowship again with Dr. Mangesh. Wonderfully presented, Dr. Kushi. Few things are, suppose here you have got back the entire movement. Yeah. So suppose if the movements are not there or it is less, would you have had a plan B to go ahead?
So we could go for secondary squint surgeries post this, where we can take we can transpose the superior or inferior recti to get the functional outcome.
Of a medial rectus? Hemitransposition, you mean?
Yes.
Because you have already done maximum with the medial rectus. So okay. Probably that I would send it to a squint specialist, probably. To Dr. Aditi, who would also deal excellently with squints. Yeah, great, wonderful.
I think the main important point when compared to the lateral canthus, like with regards to the medial canthus, is the perfect depth which we need to get. So even if you get the 2D thing and you're not getting the depth in the medial canthus, that actually hampers the final cosmetic outcome as such. So as Dr. Nirav rightly mentioned, there are multiple methods by which you need to fix the medial canthus and you need to take care of the 3D position of the medial canthus. In addition to just having the superior, inferior, and medial lateral kind of thing, you need to take care of the anterior posterior point also. So moving on to the next case, which again deals with reconstruction of medial canthus, but with regards to the oncology case this time, resection and reconstructive planning in medial canthal SCC, to be presented by Dr. Gaurav from Nagpur. Over to you, Dr. Gaurav.
Yes, a very good afternoon to one and all. After a very interesting case of medial canthal trauma and reconstruction, I'll be presenting a case of resection and reconstructive planning in medial canthal squamous cell carcinoma. I have no financial disclosures. So presenting a case of a 73-year-old gentleman who had complaints of mass in the left eye since 4 months, which was gradually progressing and was not painful. On examination, it was around 15 into 8 millimeters elevated nodular non-tender mass. It was firm in consistency with restricted mobility. There was ulceration, which was noted, and some mucus debris. However, there was no focal pinpoint bleeding, and the ROPLAS was also negative. On the other ocular examination was fairly within normal limits. The CT scan imaging revealed a very ISO 2 hyperdense, irregular, well-defined lesion with irregular margins. It was noticed to extend up to the nasolacrimal duct. It was abutting the medial rectus muscle and causing focal indentation of the globe. It was pointing towards a neoplastic etiology. and a clinical impression of left eye basal cell carcinoma versus squamous cell carcinoma was made. The patient was planned for left eye excision biopsy with frozen section, reconstruction plus DCT plus cryotherapy. The reconstruction was planned using a paramedian forehead flap. Intraoperatively, the mass was excised and care was taken that it is removed using a no-touch technique. The margins were sent for frozen section after getting a clearance from the pathologist that the margins and the base is negative. We raised the paramedian forehead flap and the reconstruction was started. It was a fairly decent and adequate flap with a well-sutured wound. Histopathological examinations revealed malignant sheets of squamous cells with nest of malignant cells, keratin pearls, which was with infiltration of the underlying tissue. So a diagnosis of squamous cell carcinoma, which was involving the medial canthus, with lacrimal sac involvement was made. This is the patient post-operative day 1 with a healthy wound, intact sutures, with some graft edema which is present. He was referred for EBRT to RST here in Nagpur. The PET scan was advised, but however, due to financial restrictions, HRCT and USG abdomen was done, which was within normal limits. There was no local recurrence. The patient has been under regular follow-up with resolving edema. This is the patient at presentation, post-operative day 1. The edema has seemed to be resolving at around 90 days, around 3 months from the surgery. So the clinical message is clinical examination with radiological image correlation is very important. Excision biopsy by taking 3 to 4 millimeters of margin is of importance again while planning such cases. And follow-up of these patients with adjuvant radiotherapy and PET scan is important. I thank you all for your patient listening.
Nice case, Dr. Gaurav. I would like to invite Dr. Mangesh Lobekar for the discussion.
Yeah, thank you, Dr. Gaurav. Am I audible, Aditya?
Yes, sir.
You are audible.
Okay. So, very well managed case, Dr. Gaurav. And whenever there is any lesion in the medial canthal area, it poses really a problem. It's a challenging task, and the medial canthal reconstruction is a problem because of the associated lacrimal system and the complex anatomy of the medial canthal region. And it was very well managed, but just I wanted to ask you a simple question. There are variety of methods of reconstructing the medial canthal region. So, based on the which factors you will decide that which would be the best one for the given condition for the given patient. What are the factors which will make you choose for this particular method for the medial canthal reconstruction?
Based on the defect size as to how much defect is there, what all anatomical or how much anatomy is disturbed is what we will be thinking on. And that will help us in deciding what kind of reconstruction do we really want. Whether it will be a graft, whether it will be a flap, or it will be a combination of both.
Am I audible, Gaurav?
Yes, sir. Am I audible,
Yeah,
sir?
yeah. My internet connection was unstable for a few seconds. So, did you get me?
Yes, sir. I would want your thoughts also. It will be depending on the defect size and what kind of anatomy that has been disturbed.
I think Dr. Mangesh is facing some network issue.
graft after a combination of, and the thought of the panel also for what kind of grafts are used for.
Sorry, I lost my connection. Sorry for that. Hello, am I audible?
I
Yes,
guess
Dr.
both of you got signal issues, if I'm not wrong. Dr. Aditi, can you please confirm?
Yeah, I guess so. Even Dr. Gaurav's
Internet is
voice
not
was
stable.
breaking in between. Yeah.
Yeah.
So, yes, any other comments, or maybe if Dr. Mangesh wants to repeat the thing?
Yeah. Just my question was that whether we can have some additional points because it is based on the age of the patient, the tissue laxity, the lesion, whatever the if it's a squamous cell carcinoma or the base.
Dr. Gaurav, are you there with the network? If not, then maybe we'll move on to the next presentation. And after this presentation, we can have the discussion. Maybe meantime, Dr. Gaurav may have a better network. Is that
Sure.
fine with all? Yeah.
Yeah.
So we'll move on to the next presentation. Next
Aditi,
presentation.
Dr.
Yes.
Aditi, yeah.
Yes.
I just want to make one point here. We have
Yes,
been
please, sir.
having, I'm okay?
Yes, sir.
Yeah. So my question, we have had two presentations on the medial area. Is there any role of an ENT person coming in or an endoscopic view of the duct to all the panelists?
Any comments by anyone? Dr. Mangesh, you want to take the question? Dr. Sonal?
Okay, we'll come back to it later.
Yeah. No problem, sir. So we'll maybe move on to the next presentation by Dr. Ramesh Murthy, sir, who is a renowned oculoplasty surgeon from Pune. He'll be talking about pearls in ptosis management. Over to you, sir. You can please share your screen.
Also requesting, please switch on your videos.
We can see the screen, sir. Just kindly make it full screen.
Am I audible?
Yes, sir. Please go ahead.
Yes. So, how to start the video? Okay, video is. Yeah. So, thank you very much for this opportunity. I'll be talking about pearls in ptosis management. So we face challenges at every step, right from the evaluation, planning which procedure to do. Counseling the patient is of great importance. The outcome that we face and the complications that we may have. Sometimes I feel it is much more difficult to do a levator resection compared to a phacosurgery. The evaluation and identification of the cause is not easy, and levator techniques are very difficult to master. So the first thing we need to understand is whether it is a simple ptosis or it is a complicated ptosis. Always we need to look out for extraocular muscle problems like double elevator palsy or synkinesis. Always look out for conditions like myasthenia, for any kind of mechanical ptosis or neurogenic ptosis. History is very important. We will need to look out for any past history of ocular surgery, any past history of squint surgery, any craniofacial surgery, any history of trauma. Always we need to look out for myasthenia, uh, look for fatigability, look for jaw winking, and any family history of blepharophimosis. So possibly one of the most important things which we need to look at is the old photographs of the patient to understand how the ptosis has progressed over time. Does this is there any history of allergy is also very important. So we need to examine the patient properly before we make a decision on what kind of surgery we want to do. Look at the patient from a distance, always evaluate the visual function. If the visual function is poor in a child, we need to go for early intervention for the ptosis. Look at the pupil, look for any subtle signs of third nerve palsy. Look at the motility, look again for third nerve palsy or double elytra palsy. The bells is important to know how much post-operative exposure keratitis we may face. Look at the degree of lag of thalamus. Sometimes patient may have lag of thalamus pre-existing and it will exacerbate after we do the ptosis surgery. Always take photographs of the patient. A simple eyes test, as you can see here, can help us elucidate if there is any signs of myasthenia. The measurements are all important. We know about all the measurements. The important thing is to make sure you do the LPS action properly and always look for inferior scleral show, because that is a very big problem which we may face even after do a perfect ptosis surgery. We look at the degree of ptosis. The severe the ptosis, the more the chance we will not do a levator resection. We might end up doing a sling surgery. Always look out for pseudotosis, because this is a very big problem which we may face if we unfortunately or we by mistakenly consider it as a ptosis, the other eye, and operate. So look for any hypotropia, brow ptosis, anophthalmos, or contralateral lid retraction. Now, in a child, we can operate at any age, but preferably the older the child, the better it is, because you get a much better visualization of the tissues and better results. If the levator function is good, then we can definitely go for an aponeurosis surgery. If it is poor, if the levator function is good and the ptosis is very minimal, then we can go for a fascicular serrator or muellerectomy. If the levator function is poor, say less than 4 millimeters, then definitely we need to go for a brow suspension by using a frontalis sling. If the levator function is say between 4 to 10 millimeters, we can still consider levator resection or advancement. Some procedures like fascicular serrat are useful if there is very mild ptosis, but the problem here is that you are shortening the length of the lid, so patient inevitably is going to end up with lag of thalamus. Muellerectomy is also useful when there is any mild ptosis and provided there is a good response to phenylephrine. Again, a lot of accuracy is there. It is very good for mild ptosis. Now, levator repair can be done by an anterior approach or a posterior approach. Because I'm conversant with the anterior approach, I'll discuss that. A few things: always make sure that you make the lid crease properly, the incision, match it to the other eye. If there is excess skin, try to excise the excess skin. In a child with congenital ptosis, always try to overcorrect. Because even if you feel it is very good on table, you will end up having an undercorrection post-op. Again, the question is how much to resect. Here, it depends on whether the horns have been cut, what is the appearance of the muscle, what is the amount of levator action. So the Berkey's criteria is a very useful pointer on how to go about doing lid height adjustment. If the levator action is 7 millimeters, we can leave the lid at about 2 millimeters below the limbus. If it is better than that, we can leave the lid lower, and if the levator action is very poor, we can leave the lid higher. Now, brass suspension is done using the frontalis sling. You can use either fascia lata or we can use a metal like a silicone sling. We usually go for a pentagonal fashion. It's a good surgery, but the problems here again is that there is severe lag of thalamus and patient has to be taken care of in the initial period. We need to put frost sutures and make sure the patient is safe. Question is, if there is unilateral ptosis, should we go for a unilateral sling or a bilateral sling? So these are big questions which we need to discuss with the parents and then involve them in the surgical decision. So in summary, ptosis got numerous options, especially levator resection and tarsofrontal sling are the most common surgeries that we do. Always make the right choice, counsel the patient properly, and you will get the best results. Thank you. So I finished my presentation. Dr. Aditi?
Yes, sir.
Wonderfully presented, Dr. Ramesh, as usual. Uh, any questions for him?
Any expert comments from you, sir?
He has covered everything. As NS Madam used to say, doses is something which will make or break practice. So I think his practice is doing very well.
I think ptosis is my commonest oculoplastic surgery at this point of time. I've been noticing that I've been getting lesser and lesser of other things, like entropions are much lesser, and ptosis is the most common now.
Yeah, people are
As you
doing a
rightly
lot more
mentioned, sir.
selfies.
No, I always prefer unilateral sling because it's very difficult to convince for bilateral sling. So when both the eyes go into severe lack of thermos, parents will come and will stand at your house, at your door house, and ask you what to do. So always go for unilateral sling.
Even the ptosis diagnosis also, many times nowadays I have seen that people with with hemifacial spasms and things like that do present like a ptosis patient. So general ophthalmologists should be very careful in looking at. They have the small twitchings of the lid and things like that. They hold the lid tight by keeping the aperture down and trying to hide that little flurry of impulses in the lids. So that diagnosis also makes a big importance.
Correct. And one more thing, like which I would like to emphasize, in maybe kind of remote areas or smaller cities, there is a tendency of overdoing sling surgery when even when the levator surgery is quite possible. So I would like to add, whenever the LPS action is surely better than 4 or 5 millimeters, levator surgery is a better option because it stays for longer. Like generally, they don't need a resurgery unless it's a congenital ptosis which is slightly undercorrected, which may need a revision. But as sir rightly mentioned, congenital ptosis, we always go for full correction or maybe a bit of overcorrection. Other than that, unless the levator action is less than 4 millimeters, it is not a wise idea to go ahead with the sling surgery. Uh, mm, Most of the places, because it is technically slightly simpler than levator resection, even when the levator resection can be a choice, there are sometimes the option of TFS is opted over levator. So would like to emphasize on that from my experience of places around and in and around Kolhapur.
So Aditi recently had this opportunity to operate on the child of an ophthalmologist who had undergone sling twice, 2 times suture granuloma. So I was doing the third surgery. So I just removed that sling and did a levator resection with pretty good results, very good results, in fact.
Absolutely.
The doctor was sitting next to me on the operating table. So that was even more scary for me, but it could give very good results with levator resection. So maybe sling should have been avoided in the first place.
Absolutely. So we should surely have a very high threshold for actually going for sling. Doing slings only when it is absolutely necessary, when you are sure that levator is not going to work. In my patients, sometimes if the levator action is around 5 to 6 millimeters, with a good counseling, that will go ahead with levator surgery first. In case there is some undercorrection on, like, grossly undercorrected ptosis, then we can go ahead with TFS. TFS is always a choice after any of the ptosis surgery. With that counseling, people are ready to go ahead with levator surgery. And if there are very few times when you actually need to consider TFS after levator surgery, is what I feel.
I agree.
We have that levator tuck also, where you just do only a single suture in the center. It gives a very good curve for as far as the lid curvature is concerned. And chances of slips and all are also less. So I think people who are beginning into their just finished with their fellowships and things like that can probably try these and may be able to give a better result.
Yeah, works
Because
best in the
distance, yeah,
aponeurotic ptosis, those, I think.
correct, correct.
Yeah.
Because there is always a fright that you will cut the levator. Is it going? It's not going to run away anywhere. So it is always going to be. It's one of the safest of the surgeries and muscle surgeries that can be done. So they can probably start with that tuck, which is probably much simpler than the levator.
And even the lid crease and the anatomy of the subbrow region, which we get after the levator surgery, is much better when compared to sling surgery.
Lag of thalmons is also almost not
Yes,
there.
yes. Any other comments by any panelists on this topic or any other
Uh,
case?
yeah. So, Murthy sir, excellent presentation as usual, and very nicely. Actually, you did summarize the points too, and thank you for including parent counseling and this into the points. So, even my takeaway or few points to consider for ptosis. I think very important for pediatric ptosis is having the expectations versus reality conversation with the parents, and making them understand basically the origin of ptosis, where the entire thing is begun because the muscle is not formed properly and there's a dysplastic muscle in our hand. So predictability of any of the surgeries, the range of predictable outcomes have to be discussed, and we have to come to a common ground, the surgeon and the parents, regarding the expectations post surgery. The technique we use, I think, with over the number of years, what I've come to realize is the most predictable surgery in your own hand will will give the most predictable outcome. So and of course that has to be through the with the protocol as well, depending upon the levator function. Uh, I also have a comment regarding Dr. Gaurav's case, if Dr. Aditi, if I may.
Yeah, you're
Yes.
audible.
Yeah. So you did, so Dr. Gaurav, you did show a CT scan of the orbit axial section, and you commented on the abutment of the medial rectus muscle. However, where did you perform an MRI, and were the separate fat planes noticed between the lesion and the medial rectus so as to rule out the infiltration of medial rectus there? The lesion was awfully close to the medial rectus, and this was, though of course involving the medial cancer, this was an orbital squamous cell carcinoma, orbital extension of the squamous cell carcinoma of originating from conjunctiva. That is what we were talking about. So, though complete excision, of course, is one of the modalities, uh, having a pre-margin and making sure the muscle is free, and the post-operative radiation, or if at all patient was amenable, another option of a smaller incision biopsy diagnosis and probably neoadjuvant chemotherapy to get the lesion away from the important ocular structure, so that you can have clearer tumor-free margins post-excision, might have been a treatment of a line of treatment too.
Dr. Gaurav, are you there?
Yes, am I audible? Thank you, Dr. Sonal, for those tips. The MRI was done, and there was some plane which was noted, and hence I went ahead with the excision. But I'll make sure I'll keep it in mind, the line of treatment that you shared. Thank you.
Any other comment?
Hello. Yeah.
Yes.
One
Dr.
additional point regarding all the lesions which are involving the medial canthal part. So we have a custom that if it is we are suspecting melanoma or the common cell carcinoma or the basal cell carcinoma, we take out the lacteal system out. So is it is there any difference of opinion based on the involvement of the canalicular structures or the lacrimal extent? Means, do we take it in all the cases, TCT? We do in all cases? Or is there any difference of opinion among the panelists?
Any comments?
If
I
it has,
shall not
Yeah,
decide.
Sonal, yeah, please.
Yeah, no,
Sonal.
if it any kind of imaging does show involvement, I think Gaurav commented on the involvement of nasolacrimal duct in this case. So similarly, if there is any involvement from the canalicular structures to the lacrimal sac, uh, to the and to or the any part of proximal or mid nasolacrimal duct, better would be to take care of the lacrimal system along with, because sooner or later that is apart from the physical structure being there, it can also serve as a reservoir of those detached cells in the lacrimal sac. So, good practice to take them out if any sign of involvement has been there, any planes have been missed because of the lesion. And this particular lesion was definitely awfully close to a lacrimal system, so that was a good call to perform DCT and to remove maximal length of the NLD along with.
I think it will depend even on the type of the carcinoma which we are
Lesion.
dealing with. BCCI may be
Definitely.
slightly more conservative
Yeah.
if I am getting a good base, but SGC or SCC kind of carcinoma, I would like to be slightly more aggressive and take out the
Yes.
things. And as Dr. Vidyashankar sir was also mentioning, maybe in cases like melanoma or maybe aggressive tumors like SGC, we would surely love to have a like endonasal examination if there is any obvious lesion on that side before deciding our treatment. I think that was the question Dr. Vidyashankar sir
Yes,
wanted
true.
to.
Yes, that was primarily my question. The other thing also which I would also recommend is these cells many times in the sac they float free. So we can do some sort of a syringing, take it with the endoscope, take it into it and send it for cytology. We have had times where we have ended up having positive cells, and that has saved quite of a dilemma whether we need to take off the, because just removing the sac is not going to help. We have to take off the sac up till the NLD, right up to, so
Yes.
it becomes a much more extensive surgery.
Yeah. Thank you so much for great cases, great inputs, a very nice, productive, and interactive session. I would like to thank the MOS office bearers for this wonderful opportunity to discuss and interact with you all. Would like to thank Dr. Anaga Arur Madam, our President, Dr. Preeti Kamdar Madam, our Secretary, Dr. Piyush Bansal, the Chairman, Scientific Committee, and Sumit, obviously, for the excellent planning of the whole meeting. And I would love to hand over the session to the next UVA people. Thank you
And
so
all
much.
the, thank you all the participants. We have ended a little earlier in time.
Thank you. Thank you, Dr.
Thank you,
Vidyashankar
everybody.
sir. Thank you, Dr. Aditi
Thank you.
and the Sumit for the excellent coordination. Thank you so much.
Thank you. Thanks.
Thank you, everybody.
Dr.
Thank you.
Piyush, over to you.
So is Dr. Mayur Morekar, I'm sure he's already joined.
Yes, I'm here.
Perfect.
Piyush, I'm here.
Welcome, Dr. Mayur Morekar and his co-moderator, Dr. Samyak. So handing it over to you, maybe just in the nick of time, and we can start our session now.
Yeah. Samyak, are you here?
Yes, I'm here. Yes, Dr.
Yeah.
Mayur.
Fine, we can go ahead.
Okay. So can we start, Dr. Piyush?
Absolutely.
Yes. Thank you so much. Let me welcome our chairman of the session for the UVA session, Dr. Vatsal Parekh. And and my yes, thank you, sir. You joined on time. As well as I would like to welcome my co-moderator, Dr. Mayur Morekar. Along with that, our expert panel, Dr. Sharad Bomas, Dr. Manish Bapai, Dr. Sasavde sir is here, and of course, Dr. Paritosh Kamdar, as well as our MOS office bearers, Dr. Piyush Bansal, Dr. Preeti Kamdar. Without any delay, it is right 7 o'clock. Sorry, 5 o'clock. So let's start off with the first presentation. The only change is that Dr. Saili will be presenting first, and Dr. Manish Bapai will be on the expert panel. So we'll start with Dr. Saili's presentation and then move on to Dr. Akshita's. Dr. Saili, if you can share your screen.
Good evening. Am I audible?
Yes. Yes.
Just a moment.
Dr. Saili, are you trying to share your screen?
Yes, yes. Is it visible?
Not yet.
Not yet.
Now?
Yes.
Yes. Good evening, everyone. Today, I shall be discussing a case on our diagnostic journey in an eye with a vascular occlusion. She was a 16-year-old female who presented to us with a sudden drop in vision in her left eye, which was there since 3 days. Her visual acuity at presentation, right eye was 20/20, but left eye, she complained about a slight drop. On checking, it was about 20/20 parts. Denied any systemic illness, intraocular pressure was normal, and then she only gave a systemic association of a purpura-like rash, which was present on both her arms since 6 months. On taking a look at her fundus, the right eye fundus was otherwise normal. But when we took a look at her left eye fundus, we can see on taking a closer look that there was a patch of retinal whitening along the superior arcade. Furthermore, there were few dot blot and flame-shaped hemorrhages all throughout her fundus. As we can see in this red-free image, I have illustrated that there are multiple dot blot and flame-shaped hemorrhages, along with the white patch that I was speaking about, the whitening along the superior arcade. We took an OCT along the section of involvement, and we can appreciate that there is hyperreflectivity of the inner retinal layer and marked by the asterisk. Otherwise, the OCT was normal in the left eye. So we went ahead and did an OCT angiography of the left eye to look for any flow void areas, but essentially it was normal with no with a normal perfusion. So with this, we thought that the provisional diagnosis was a branch artery occlusion, which was perfused, and the cause was somewhere we thought could be a cardiovascular cause or a systemic vasculitis, she being a 16-year-old female. So our top differentials were ocular ischemic syndrome, Takayasu arthritis, SLE or the APLA syndrome. So with that thought process in mind, we asked her for investigations such as a routine CBCSR profile, blood pressures, and 2D co-carotid Doppler, out of which all of these were normal except for the raised ESR. At the same visit, we went ahead and did a fundus fluorescein angiography. This is the left eye image showing that essentially it was normal with no as such delay in the arm to retina time or any other specific findings or CNPs that we were looking for
considering our potential differentials. But after which she did not return to us after about 2 visits, to only come back after 2 years with a black shadow in front of her right eye now. The previous presentation was in the left eye. The vision at this presentation was counting finger 2 meters. Left eye was otherwise 20 by 20 and no other anterior segment involvement. So this was a fundus picture at presentation 2 years later. You can see there was a classical retinitis pattern appearance in her right eye fundus. So on taking a closer look, what was different about this presentation was that she had all the 3 variants of CMV retinitis in the same eye. That is a fulminant variant, which was present at the posterior pole. More in the periphery, a slightly granular variant, which could be appreciated. And otherwise, throughout, we could see the frosted branch angiitis. So we went ahead and reviewed her history, but this time she told that she had a Burkitt's, which she was diagnosed with Burkitt's lymphoma in 2021, which was about a year before, and was given chemotherapy. 8 cycles were completed. And what the history that she did not give us 3 years before was that she was on heart treatment for the past 10 years. And considering the chemotherapy that she was already on, she was also on prophylactic Bactrim and antivirals along with antifungals started by her oncologist. So when we did an OCT through her current presentation, we could appreciate the classical full thickness retinitis along with no involvement of the underlying RP or choroid, along with the cavernous form also, which is described in for CMV retinitis with the bridging over hyperreflective inner retina. So we went ahead and managed her with intravitreal ganciclovir injections bi-weekly and started her on an induction dose of 450 milligrams twice daily. This was her 1 month photograph of 20 by 80 improvement of vision with a residual necrosis with the residual retinal necrosis. So with this, I would like to highlight that a branch arterial occlusion can be a sole presentation in HIV, although it is rare in the current ART regimen that we follow. Young adults can also have focal arterial occlusions, though HIV is not the top cause. And mixed pattern retinitis is something I wanted to show in this image. So follow-up is necessary, and where HIV, all 3 things have happened in this patient for us. Thank you.
Thank you. That's a very interesting case, Dr. Saili. I think if the patient had a given history of heart at initial presentation, the thought process would have been entirely different, and we could have possibly guided the patient in a different manner and probably saved the further catastrophe that she eventually had, or at least been prepared for it earlier. So, because, uh, perfused BRAO in a young girl, you would probably think of some cardiac cause or something like even in migraines, they can transient ischemia that might have been there. So, but you did not you did not do anti-DS DNA and other tests.
So she just came to us one time after the first presentation. This was the only test which she got done, and FFA was the only possible thing we did on that visit. But after which she did not follow up. Only when she came with this sudden drop, because I think her vision was fairly good. So
Yeah, okay, because the arm to retina time was 16 seconds, so that ruled out any,
yeah.
disease prior to the choroid or something like Takayasu or other kind of vasculitis. The it was very interesting presentation of CMV retinitis with such a fulminant kind of picture along with granular. So, all forms of this thing were present. Uh, Despite the patient was being on probably prophylactic acivir, acyclovir. So obviously it doesn't work. It's probably valcyclovir and along with ganciclovir injections. That is what is, I think we need to keep this in mind. So I think it is a very interesting case. I think it goes us to tell that if you are seeing a artery occlusion in unusual setting, you need to go little more in depth, and you need to find out more about the history as well as investigate these patients more. Um, the patient did not reveal the history of heart. That's unfortunate, but I think we have to take the point to take home is that we need to be asking for such a thing, and probably even in investigation, you could have asked it, you could have investigated for it. Uh,
Yes, that was a learning for us as well, because a
yeah.
16-year-old and HIV was something uncommon that we were looking at with that presentation. But yes, that was a learning for us as well.
Right. So I think it's a very interesting case, tells us importance of detailed history taking and suspecting this kind of problems or this HIV kind of retinopathy, because once the patient had Burkitt's and CMV, it's AIDS defining for definitely. So she was must have been very grossly immunosuppressed at that particular point of time. Uh, Also, you're lucky that, or she's lucky that she did not develop any retinal detachment with such a fulminant disease. If she developed any necrotic areas and developed, it would have been a difficult thing to manage again. So, great case. I think a lot of learning points. Um, I think we all have learned significantly in this case. Anything from
Riley, what was the CD4 count in this patient when she developed CNV retinitis?
CD4 was around 50, 60 range, about that.
Yeah,
despite
exactly.
heart.
Yes, despite heart.
Yes.
I think it was also the immunosuppression which had added
So the
to.
chemotherapy also probably worked in causing immunosuppression, further immunosuppression. So because she had this Burkitt's that for which she was given the immunosuppression, that must have added to the the chemotherapy must have added to the immunosuppression.
I
Thank you,
have a
Dr. Saili.
question.
Yeah, you have a question. We can
Yes,
quickly go to that question. In the meanwhile, I'll ask Dr. Rakshita to just load her presentation. Dr. Rakshita?
Yes.
Yes, Dr. Saili, you can go ahead with your question.
How long should we continue on antivirals for patients in CMV retinitis and eyes which are immunosuppressed? Not HIV, but only immunosuppressed.
Yeah. I think we need to continue for fair bit long time, until the CD4 counts have improved and they are doing better. And we need to keep these patients on follow-up regularly at 2 weekly intervals. If you are seeing recurrence of CMV, then probably you want to go in again and give a ganciclovir injection. But I think we should be looking at CD4 counts for further this thing to give us a guideline.
Oh, thank you.
They would also be doing CMV viral load systemically for such a patient.
Yes, they do.
Yes, so usually this is bilateral presentation. You should always look at the other eye, because there's one question in the chat box where it said that it is usually bilateral. So yes, indirect ophthalmoscopy, dilated examination, look at the periphery. All those things are very important. And as well as that, look at the CD4 counts and keep on monitoring. I think that was an excellent presentation. Thank you so much. I think we should go on to the next case. Dr. Rakshita, you can start.
Yes, sir. Am I audible, sir?
Yes, Dr. Rakshita.
My screen is visible.
Yes.
Good evening. At the outset, I would like to thank Maharashtra Ophthalmological Society and myself for this opportunity. So, my case is a 53-year-old male who presented to us with blurring of vision in his right eye for 2 weeks. He had history of redness, swelling, and pain in his right eye associated with severe headache 2 weeks prior to onset of his defective vision. He also had past history of acute angle closure attack in his left eye, for which he underwent both eyes YAG peripheral iridectomy, and he also had history of redness in left eye prior to that, which was treated as conjunctivitis. So 2 weeks back, the patient presented to us in emergency with complaint of redness, swelling, and pain associated with severe headache. He had lid edema, diffuse conjunctival congestion, and chemosis. The anterior chamber was void. He had peripheral iridectomy, which was patent in both the eyes, and left eye showed no congestion, and anterior chamber was void. So, considering it to be right eye acute conjunctivitis, he was treated for the same. And since he was non-responding, he was suspected to have ciprofloxacin allergy. After that, patient was lost to follow-up. Elsewhere, he got to be diagnosed as preseptal cellulitis with acute dacroadenitis, for which he was hospitalized for 4 days and received intravenous antibiotics along with oral steroids. He then again reviewed back with us to the emergency, now this time with right eye blurring of vision, and his vision had dropped to 6 by 24 parts. So right eye showed lid edema, dilated episcleral vessels, anterior chamber was quiet. However, the anterior vitreous space showed cells. And in left eye, there was no congestion and anterior chamber was quiet. The fundus examination in his right eye showed hyperemic disc. There were ILM folds at macula and there were multiple hemorrhages and a peripheral 360-degree choroidal detachment was seen. Left eye fundus was within normal limits. The ultrasound B-scan of the right eye showed inferior peripheral retinal detachment, diffuse choroidal thickening, and there was no evidence of T-side. FFA was not much contributory. It showed few areas of pinpoint hyperfluorescence, which did not show placoid pooling. So let's go back to the MRI when patient was diagnosed as preseptal cellulitis. His MRI was suggestive of mild enlargement of right lacrimal gland, and there were hyperintense signals in lateral preseptal and retrobulbar postseptal spaces. And there was thickening of ocular coat and involvement of extraocular muscles. So with this clinical picture and imaging features, we came to a working diagnosis of posterior scleritis. Patient was further investigated for quantiferon TB gold, TPHA, antinuclear antibodies, and PMC, which all turned out to be negative. And then the patient was started on methotrexate 15 milligram weekly once and oral steroid 60 milligram in a tapering dose. At his 2 weeks follow-ups, his best-corrected visual acuity improved to 6 by 6. Fundus showed resolving posterior scleritis and choroidal detachment was resolved. And his repeat MRI showed significant resolution of the preseptal tissue edema and muscle edema and reduction in the size of a lacrimal gland as well. So to summarize, the patient initially came to us in March 2025 when he was diagnosed to have left eye conjunctivitis. And then he had raised intraocular pressures for which he was diagnosed to have acute angle closure glaucoma and underwent both eye YAG peripheral iridectomy. Then he came to us in August 2025 with redness in right eye and was diagnosed to have conjunctivitis or ciprofloxacin allergy. Then he was lost to follow-up, and elsewhere he got diagnosed and treated as orbital cellulitis. He came back to us after 3 weeks and was diagnosed to have posterior scleritis and currently on treatment with methotrexate. So as Professor Peter Watson quoted, posterior scleritis must be one of the most underdiagnosed treatable condition in ophthalmology, partly because its manifestations are so protean and partly because the diagnosis is rarely considered. Literature also shows evidence of misdiagnosis of posterior scleritis as conjunctivitis, angle closure glaucoma, and often as orbital cellulitis. So the take-home points from my case are not every red eye is conjunctivitis. Severe ocular pain with headache is a red flag. Posterior scleritis may masquerade as orbital cellulitis. Absence of classic T sign does not exclude posterior scleritis. And early recognition and prompt immunosuppressive therapy can result in excellent visual recovery. Thank you.
Thank you, Dr. Rakshita. Very interesting case. So, two questions, Dr. Rakshita. This is not the run-of-the-mill case of posterior scleritis. And do you have the OCT of the macula? Because it would have been interesting to see the changes on the OCT.
No, sir, I do
No,
not.
you have a very nice fluorescein angiography. It shows pinpoint dots of hyperfluorescence. What about those white-centered hemorrhages? I mean, were they white-centered? Because I don't know.
No, sir.
No,
They
they
were
were
just
not white-centered.
hemorrhages. They were not white cells.
So how do they fit into the diagnosis? Did you try to chase them? Because that's not classic posterior scleritis again. So you should observe this patient. I think following up over a period of time, maybe you'll be able to unveil something different also. And plus the enlarged lacrimal gland, extraocular muscles being enlarged may not fit into the picture as a classic posterior scleritis.
Muscle involvement is often considered that it can be there in posterior scleritis, but yeah, lacrimal gland enlarged into something.
Yes.
And some fundus photograph and B scan also probably points to detachment rather than choroidal detachment. If you see the fundus photograph, it's upper temporal to lower temporal quadrant, so detachment like picture. So again, choroidal detachment normally would be 4 lobes, and posterior
Yes, sir, there
B
was
scan also.
choroidal
B scan also does not. It shows a like retinal detachment.
Yes, so there was thickened choroid. I mean, there were globally thickened choroids, and the
There
periphery
was a
due to
peripheral choroidal
choroidal
detachment, sir.
detachment.
I have not shown the B scan of peripheral.
That the angle closure glaucoma definitely was one of the red flags because the pressure was 44. So that symptom could have well been associated with angle closure. Any evidence that this patient was on any antipsychotics or any other
No,
medicines which no.
no.
All right, great. Any other questions from our expert panelists? Or
Thing is that she has documented very well, Rakshita. The first episode was clear-cut conjunctivitis. Second time it was adenitis. Then once it was a angle closure glaucoma. And lastly, you come to the scleritis. Every time the symptoms and presentations are different. So previous 3 were not the episodes of scleritis. Maybe such types of cases, young male patients, Posner-Schlossman syndrome also are very common in such cases with the cells. Anterior vitreous cells was the only finding. And that time only you came with the scleritis finding. Previous 3 episodes, there was not a single signs or symptom of scleritis, posterior scleritis. Every time it was a different thing and it was resolved. Conjunctivitis was resolved, even though there was an allergy to ciprofloxacin. Acute closure angle closure glaucoma was also resolved with the YAC iridectomy. So they have no correlation with the posterior scleritis.
definitely one agrees that it was an inflammatory event, and it's the things that the signs that you've seen in the scleritis as well as the other signs may be a spectrum of a bigger picture, which I think will unveil over a period of time. But that's a very interesting case. Thank you so much. And I think we shall move to the next case now. I would request Dr. Hiteshi Jain to share her screen. And we'll have Dr. Sharad Bomas as the expert.
How to click on the presentation here?
Sir, is my screen visible?
Yes, doctor, you can start, please.
Good evening, everyone. I'm Dr. Hiteshi Jain, and my topic for today is the case of tubercular uveitis gone astray. So I had a patient who was a 35-year-old male with diminution of vision in the left eye and congestion on and off episodes for a year. There was no history of systemic illness, including TB or TB contact, but he did give history of taking oral Visolone and injection intravitreal triamcinolone 8 months back. So this was what he showed me. There was a picture of an OCT. He was diagnosed as inflammatory macular edema a year back, for which he was given oral Visolone according to body weight over 30 days with weekly tapering, with no improvement according to him. And then he received 1 dose of triamcinolone and he was lost to follow up after that. When he presented to me, his right eye was completely normal with a vision of 6/6, and his left eye was hand movement counting fingers. IOP was 22. His conjunctiva showed congestion with non-pigmented mutton fat KPs. Corneal sensations were intact. There were 2+ cells. The pupil was non-dilating with synechiae. He had complicated cataract and the fundus was not visible. So this was his slit lamp image. You can see the mutton fat KPs and the 360-degree synechiae. And the B scan showed some moderate amplitude dot echoes. He could be having vitritis at that point. The existing investigations included HBCBC, ESR, RBS, HIV, HPS, AG, which were all within normal limits. His HLA-B27 had been done before, which was positive, and TB Gold test had been done twice, which was also positive. I ordered an HRCT chest for him, which was within normal limits, and TPHA, which was non-reactive. So at this point, we have a patient who was diagnosed, who had intermediate uveitis with macular edema and disc edema in August 2025. He was tested positive for TB Gold and HLA-B27, given oral and local steroids, after which he was lost to follow-up. He presented to me in March 2026 with acute GAU and intermediate uveitis. So my differentials for GAU with intermediate uveitis at this point were tuberculosis. The supporting evidence was a positive TB Gold test, sarcoidosis, but he had no symptoms and his HRCT test was normal. Multiple sclerosis, again, he had no neurological symptoms. He was started on topical steroids, cycloplegics, AGMs, and he was to be started on oral steroids after starting AKT. He was referred to a physician to start AKT, but the physician convinced him that he does not have tuberculosis. He started him on tablet methotrexate based on the HLA-B27 positive status. So after a 2-week gap, the patient comes back to me. He's now on tablet prednisolone 60 milligrams and tablet methotrexate once a week. His CCC has decreased. The KPs were status quo and the AC cells were 2+. The patient was explained again that he needs to start ATT or his infective condition won't decrease and there will be relapses in the future. After which he started ATT and we can clearly see the difference. The CCC reduced, the AC cells had come down and so had the KPs. So my take-home message for this case was that every case of uveitis must have a tailor-made approach for treatment. There should be no blanket investigations or a uveitis panel for all patients. We should trust our clinical diagnosis more than the lab diagnosis. The morphology of the disease must be taken into consideration before we come to our differentiation or differential diagnosis, and a positive test, in this case, HLA-B27, without any symptoms or signs may not always need treatment. Thank you.
So, Dr. Hiteshi?
Yes, sir.
Yeah. So, the physician started the patient on 60 milligrams steroids and methotrexate. And
Yes, sir. Yes.
when you started AKT, how long after the initial treatment by the physician you have started the anti-COX treatment?
So the patient came back to me 2 weeks after starting methotrexate and tablet prednisolone. So when he presented to me, there was a gap of 2 weeks, and then I started him on ATT. After which also he was not.
Steroids were continued and the
Yes, sir.
methotrexate was
So
also
once,
continued.
no, methotrexate was stopped, sir, but oral steroids were started along with AKT.
So actually, in this particular case, HLA-B27 positivity is a very strong kind of supporting diagnosis for a HLA-B27 pan-uveitis.
Okay,
To
sir.
the initial fundus findings as well as the clinical picture, where the fundus was apparently normal and only the cystoid macular edema and a bit of disc edema was there, and the patient responded to whatever steroid cycloplegics was given. Subsequently, the patient was lost to follow-up because he might have got better. And when he presented to you, because of the chronicity of the disease, patient present as a pan-uveitis. So we would not like to call it as an intermediate uveitis, rather it's a pan-uveitis. Now, to say that it is a tubercular panuveitis, we do not have sufficient kind of conclusive features unless you see the fundus. So, on the fundus, if you see that there is a evidence of a pattern of tubercular uveitis, like choroidal granuloma or a tubercular vasculitis or a perivascular choroiditis patches. Along with that, if you see the clinical feature, then we can assume that there is a possibility of a tubercular panuveitis. So because this patient has already been on steroids, he has responded to the steroids. The inflammation has reduced. The type of classical KPs, the type of Synechae which are seen in tubercular uveitis are broad-based Synechae, and there can be some iris granulomas if it is sufficiently chronic. But mainly to diagnose that, we need some findings on the fundus. So this quantiferon TB gold test is not a conclusive evidence to support a diagnosis of tubercular uveitis on its own, because there is a high false positivity rate as well as it is positive even in non-tubercular mycobacteria. So in the absence of specific signs of ocular tuberculosis, the diagnosis still has to be entertained as a HLA-B27 positive panuveitis. So we can do further investigations like vitreous PCR for COX, which has got um, uh, reasonable positivity rate, but it is not positive in all the patients. So the false positivity rate is also pretty high for the vitreous PCR for tuberculosis. And uh, it is known that this HLA-B27 can also present to you as a unilateral panuveitis. It has been documented in the literature. So in the absence of specific signs of ocular tuberculosis in this patient, so what we suggest is that you give him midricaine, atropinize him with an ointment, and if you are able to have a fundus view of this patient, it would help us greatly in deciding whether it is actually a tubercular uveitis. So based on this, because there is absence of the HRCT is normal, and you have not seen the fundus. So in the absence of these two supporting features, it is difficult to categorize it as really as a tubercular panuveitis. Because the steroids are concurrently going on in this patient, this patient of any inflammation, HLA-B27 positive panuveitis, will also respond to the steroids and cycloplegics. So in future, over the period of time, if the patient would not have responded to the initial steroids, and then you can have a look at the fundus, or you have a positivity of the PCR or some supportive systemic investigatory findings, then it is justifiable to start the anti-COX treatment. So it can be both, but there are features of HLA-B27 panuveitis in this particular patient, and there are less features of tubercular panuveitis in the absence of visibility of the fundus and other systemic evidence, as well as the high rate of, we cannot rely only on quantiferon TB Gold test. What it tells you is that the immune system has been exposed to the tubercle bacilli, and there is a immunological response present in that particular individual. More than that, it will not tell you anything. So unless there are classical clinical features of tubercular uveitis, we cannot conclusively say that it is tubercular uveitis. We would like to have the opinion of other panelists also.
Yes, I think it's an interesting case, sir. And what I think Dr. Hiteshi must have been guided by is the presence of keretic precipitates. I think she did mention, if I'm not wrong, Dr. Hiteshi, were there mutton fat keretic precipitates?
She
If
had
they were,
mentioned, but
yeah,
on the slit
probably
lamp photograph which she had shown, maybe it's difficult to capture the diffuse elimination. We can have a better view possibly, but it was not very classical seen on the fundus, on the clinical photograph at least.
right. So that must
And the
have been
synechiae also, they say it is broad-based synechiae and other things. Here, this is an annular plastered iris. Again, it is more suggestive of non-tubercular uveitis. Not that it cannot be there in tubercular uveitis.
right. So I think when these cases become chronic, patients don't follow up, the presentations get mixed, and then one has to sit back and decipher what has happened. Probably a PCR from the anterior chamber could help, like you said. So still a case in evolution. I think Dr. Hiteshi, you can continue monitoring this closely and look for the clues that Dr. Sharad sir has said.
Yeah. One
So
thing
may I
observation that HLA-B27 associated anti-uveitis, usually there are recurrent attacks of hypopion uveitis, and
Exactly, sir. Yeah.
thin fibrin layers are there. No,
Yes,
it's not that this fibrin is not there. Before forming the dense adhesions or synechiae or occlusio papillae, seclusio papillae, it takes a longer time. Before that, the patient develops several attacks of anterior uveitis, and usually they are bilateral.
So
These
also this was
patients
a
of
granulomatous
HLA-B27
anterior
panuveitis
uveitis.
can present to you initially as a panuveitis. It is not necessary that they should have anterior uveitis or recurrent episodes. HLA-B27 is known to present as a panuveitis in some patients.
Agree.
So, irrespective of that, should this patient be quantiferon TB positive, whether it's causally linked with the current uveitis episode or not? If you're going to put this patient on oral steroids as well as polytrixate, would it not merit an investigation into latent TB, considering this patient is quantiferon TB positive?
Yes. Yes, in Indian scenario, see if you have to give a choice, clinical picture, as she has rightly said that there is no substitute to clinical appearance. Clinical appearance, what we have learned during our PGs or even during our experience also, this type of pictures are tuberculosis uveitis type of cases. Secondly, what you have said that latent tuberculosis in the presence of positive TB Gold and an Indian scenario. We will again incline more toward the tuberculosis rather than HLA-B27.
Yes.
And
so
to be
Samyak,
on the
I
other
feel
side, we have seen that the people who have taken the anti-COX course, the recurrences, relapses are almost nil.
No, sir, I'm not talking about this being causally linked, the TB being the the etiology of this condition. What I'm saying is the safety of starting this patient on steroids and polytrexate with quantiferon TB being positive, because as far as the
So this
presentation goes,
patient's
yeah.
MTX was stopped, sir. The folitrexate was stopped, and he was put on AKT by me and
No,
steroids.
no, I understand. My what I want to point out is you should continue ATT in all good faith, because
I did,
this
sir.
patient, yeah, because of this, because as the plan goes, if it really, even if it really turns out to be HLA-B27 associated uveitis, you want to continue this patient on polytrexate, on polytrex, or possibly adalimumab in future, then the latent TB can't be ignored. I mean, that positive finding can't be wished away.
Yeah.
Yes.
Sooner or later, Dr. Nikhil wants to mention that sooner or later, once you start him or her on biologics or any steroid sparing like methotrexate, you might need to give, but that's the different way of looking at it. Yes. But thank you for that intriguing case, Dr. Hiteshi. So let's
Thank you,
move
sir.
on to the next case. Thank you, Dr. Sharath, for your expert comments. So, Dr. Ganesh Bhamre, can you please share your screen and start off with your presentation? I think you need to unmute, Dr. Ganesh.
Just
So while Dr. Ganesh is putting up his presentation, Hiteshi's case, mutton fat KPs which were not visible on the pictures, but she saw them. So that is some, and those broad synechiae, or rather 360-degree synechiae, and plus Mantoux positive, IGRA positive, all in favor of TB. But HLA-B27 positive also is significant. And I agree with Nikhil that if I have to put a patient on methotrexate and all, it's, whether it's a suspected TB or not, but we would one would treat for latent tuberculosis over here in India. Please continue, Dr. Ganesh.
am I audible?
Yes, you're audible, but your volume is low. So,
We can't hear you, Dr. Ganesh.
Just a minute. Audible, sir?
yes,
Yes.
you're audible.
Yeah, okay. Screen is visible, na, sir?
Yes.
Yeah, okay. Thank you, MS, for giving me a chance to present my case. So my today's case is slightly interesting. It's a case of 70-year-old female came with a complaint of sudden painless loss of vision in the right eye since 10 days. She was a known case of uncontrolled diabetes and hypertension, and she was referred by a diabetologist for a second opinion because her sugar level were highly uncontrolled due to a recent IV systemic steroid which were given by other ophthalmologist. So her general condition was her height was around 5.5 feet, weight was 95 kg. She was overweight and mouth breathing on minimal exertion was there. On examination, her refraction was plus 2.5 minus 1 cylinder at 70 degree. With that correction, it was improving to only hand movement. In left eye, it was minus 0.5 cylinder and it was improving to 6.9 in left eye. Extraocular movement were normal. Lid adnexa was normal in both eyes. Cornea was clear. AC was absolutely quiet in right eye. There was grade 1 RAPD in right eye. Color pattern of iris was normal. Lens was showing nuclear sclerosis grade 1 in both eyes. IOP was 15 in right eye and 19 in left eye. This was a fundus picture. So in right eye, the disc was slightly hyperemic and there were multiple subretinal choroidal elevated lesion which were confluent, placoid and yellowish in color. Left
and some pars plana exudate were also there. Left eye fundus picture was absolutely normal. There was no history of any fever, no history of any recent weight loss, no history of similar complaint in the past. There was no history of any low-grade fever or symptoms suggestive of any pulmonary pathology. There was no history of any connective tissue disorder, no surgical intervention systemically in the past. There was no history of any long-standing IV transfusion or catheterization, and no history of any immunosuppressive or immunomodulator drug. So this was a OCT picture of her right eye. We can see there is elevated dome-shaped choroidal elevation. The retinochoroidal complex was totally elevated, and at the macular area there was a small edematous area at the outer retina with small fibrinous deposit at the macular area, which was suggesting some active subretinal pathology and choroidal lesion. Left eye OCT picture was taken, and left eye was normal except age-related foveal thinning. Her fundus fluorescein angiogram was done with standby anesthetic as her sugar were very high. In fundus fluorescein angiogram, it was showing stippled hyperfluorescence in the early phase, and peripheral fundus fluorescein angiogram was showing featureless. The choroid was silent in the right eye. Left eye fundus fluorescein angiogram was normal. There was a late leak in the late stage, which were corresponding to the early hyperfluorescent dot, which were present at the maximum dome of that choroidal lesion. So in her case, my differential diagnosis, because it was a case of unilateral multifocal placoid choroiditis with no associated vasculitis, and it was worsening with the steroid, and patient was intolerant to the steroid. So second differential diagnosis was tuberculoma, third was secondaries, and fourth was endogenous endophthalmitis. Her systemic blood tests were done. CBC was normal, urine was normal, HIV negative, HbSAg negative, VDRL was negative, IgG, IgM, toxo was negative. ESO was slightly raised. HbA1c was 7.8. Estimated average glucose was also high. Creatinine and urea were grossly normal. Her lipid profile was normal. LFT was normal. Her blood culture was sent for any tuberculous bacilli, but it was negative. Bacterial blood culture was also negative. Fungal blood culture was also negative. Urine culture was also negative. X-ray chest was done, which was normal. USG abdomen was normal. USG pelvis was also normal. So it was a big dilemma. The choroid lesion were there. It was not responding in it, and they were worsening with the steroid. So I just thought that we should go and dig the case again. Then her fundus evaluation was repeated again, and we can see small colonies of uh, exudate which were lying at the inferior quadrant of the fundus, and they were linear and discrete and very small. Rest all the vitreous cavity was totally clear. Then on asking repeated history, I just asked her whether you have any medical visit in the recent past 2 or 3 months. Then the patient said that she had some ear infection and it was treated with clearing of the wax. I just asked for the files, and it turned out to be history of external otitis media, and it was fungal otitis media, and it was treated by ENT surgeon with besimethasone and cotrimazole. Then second dilemma was what to do, whether we should go for vitrectomy with sample, but fitness was not available. AC tap was planned for PCR, but aqueous was totally clear in the right eye. Sugar were uncontrolled, so I was not having any fitness for doing any kind of ocular intervention. And pars plana exudate were very scanty. Even if I would have done vitrectomy, the sample which I would have got would have not been conclusive to any diagnosis. choroiditis was a prominent sign in her case, and vitritis was very less in this case. So,
Dr. Ganesh, could you wrap it up? I mean, we will
yes,
have some time for discussion.
blood culture were negative. So finally, keeping all this thing in mind, we just thought of giving a trial of IV fungal. So with consent with physician, I started with fluconazole IV infusion. Doses was 12 milligram per kg for 15 days. LFT, RFT was monitored. Good glycemic control was achieved with insulin, and close monitoring of fundus was done at IPD basis. Progressive vision improvement was noted, and regression of choroiditis lesion were there at follow-up 3, 7, and 15 days. These all examinations were done when patient was in IPD at physician place. So fundus photograph was not able to take. So then she was shifted to oral tablet 4 can 150 milligram once daily for 1 month, and LFT and RFT were monitored. And this was the result. So there were total regression of the pars plana colonies. Then subretinal choroidal lesion were totally gone, and you can see improvement in her OCD picture also. So the dome shape elevation was also regressed. Foveal contour was achieved in right eye, and her vision has improved from hand movement in right eye to 6/9. So it's not always a Maggie which is different. Sometimes choroiditis can present with a different scenario. So that is a take-home message, that digging out the history, and when it's something inconclusive, we should go back again and review your patient and dig out the history with even if it is very non-important for patient, but it could give some clue to you for your diagnosis. Thank you.
Thank you, Doctor. Excellent presentation. Can we have comments from our expert panel? Dr. Kamdar, sir, please.
Yeah, very interesting case, Dr. Ganesh, and quite a googly case also.
Yes, sir.
What I would have tried to do is at least send an aqueous PCR.
Yes, sir. Yes.
Because try to do some because other than ESR and the poor blood sugars, I don't think you found any
Yes, yes.
other positive thing.
Possibilities, yes.
X-ray chest was negative. X-ray
Yes.
chest, any ultrasound abdomen, pelvis was done.
Yes, sir.
Any
Yes, sir.
gynec examination was done.
Yes, sir.
All
X-ray
that
was negative. Then USG abdomen, USG pelvis was also not conclusive.
okay. And any Mantoux test was done for this patient?
No, sir. No, Montux was not done.
Okay, that is one more thing in a diabetic that I would have done. Now, that things turned out fortuitously, good. That's a different matter. But if one
Yes,
was
yes.
faced with this kind of a situation, these were some of the things. Now, few things to keep in mind is that in any metastatic infection, which this presumably was. I mean, we don't have any proof, but
Yes,
presumably it was, and it responded presumably to antifungals. So blood culture, is positive only usually in the first 24, 48 hours. After that, the chances of getting positivity are very low. Then it's a local biopsy, liquid biopsy, or PCR studies which are likely to yield some results, though not always.
Okay.
Talking about fungus and in a diabetic, fungal infections to occur, it would involve significant, at least transient suppression of the immunity. So which could be because of her abnormal sugars and obesity and all, but the HbA1c was not so bad. So
Yes.
I would watch this patient closely or reasonably closely and for a long time for development of any malignancy. Because, uh, uh, for a fungal infection to get manifested, presuming that this was really fungal infection and which came under control with antifungals, not just because, sometimes some infections can come under control because your immunity becomes better and with control of sugars and things fall in place also. It could be any other thing also, a low grade infective organism also. But presuming that it was so, one would watch for development of malignancy in such a patient.
Yes, yes.
Any of the
This
other panelists have got
one point, Ganesh.
Yes,
I
sir.
would have done PET scan also, PET scan to rule out any malignancy. And number two, for a typical fungal endophthalmitis or fungal choroiditis, there is no vitreous involvement. If you see even on OCTs, vitreous is quite clear.
Yes,
So
yes.
these are two unusual things. So probably as Paritosh mentioned, I think long-term observation would be important,
Yes, sir.
So, Dr. Ganesh, very interesting case.
Yes,
Only
sir.
two things.
Yeah.
The red flag was hand motions vision, which usually in choroiditis patient is very, very unusual, and the presence of RAPD. So what I feel is that somewhere the optic nerve must have also got affected by the endogenous here, and it responded well to your antifungals.
Yes.
But
One
good, good,
point is that there.
very
It
nice.
used to have been fungus.
Mm-hmm.
Actually worsens with the steroids. He has given the steroids initially, it was not responding. If the fungus is not responding initially with the steroid, it becomes more resistance to even antifungals or in any form. How it has to be correlated, let us see.
No, somebody else, I think, had started steroids and
Yes.
things were not responding. That is how the patient came
Yes.
to him for a second opinion,
Yes,
or that's
yes.
what I understood.
That's what, once it is the fungus has tested the steroids, then it is very difficult to kill it.
And one more thing that she was a mother of a general practitioner. That the thing is that in her systemic condition and everything was monitored, and even the patient is under follow-up right now for this, as you said correctly, for any malignancy. At present, patient is doing well.
Great.
Yeah.
So, all right. So let's, in the request of time, let's go on to the last presentation. Dr. Nikhil, can you share your presentation? And I think.
Yeah. Yeah. So is it visible now?
Yes.
Hello?
Yes, yes, it is visible, and we can hear
Yeah.
you.
Yeah. So uveitis in the context of anterior chamber intervention. So this is a case of 67-year-old female. She was referred for second opinion prior to the cataract surgery, and she was advised cataract surgery with multifocal implant elsewhere at another center. She gave history of raised IOP with flat AC 1 month back. She underwent laser iridectomy and was on anti-glaucoma treatment with no systemic comorbidity. So on ocular evaluation, the left eye, the involved eye was 636 and 36 best corrected visual acuity. The intraocular pressures were 12 on anti-glaucoma medications. The anterior chamber showed the presence of 2 plus cells, 0.5 plus flare, filiform posterior synechiae, shallow peripheral AC, and presence of nuclear sclerosis with a patent PI. The posterior segment, the fundus photo I'd be showing shortly. So it showed hyperemic disc edema and inferior bullous retinal detachment, which showed a postural shift, so indicating it was a serous retinal detachment, and a choroidal detachment also in the inferotemporal quadrant. So this is the fundus photograph of the so this is the fundus photograph of the right eye and left both eyes. So the left eye showed disc edema, tortuous retinal vessels can be seen in this picture, and she did show some presence of cystoid macular edema even on clinical evaluation. So the clinical impression going thereby was right eye was, at least on clinical evaluation, was within normal limits, and left eye showed active pan-uveitis because of the AC inflammation, synechia, optic neuritis, and a serious retinochoroidal detachment. So we carried out a FFA, and on the fundus fluorescein angiogram, you can actually see in the fairly early stages of the angiogram, the disc leakage has begun early, and we can actually see the presence of choroidal folds also in the arteriovenous phase. And the disc leakage continues to occur when we try to focus onto the periphery in the region where the serous retinal detachment was prominent along with the choroidal detachment. Could actually see pinpoint leakages with mid and late phase pooling in the bullous retinal detachment. So the right eye showed very minimal disc leakage, and otherwise no pinpoint leakages could be found out. The OCT scan showed RP undulation with presence of some subretinal fluid areas, and the B scan showed retinal and choroidal detachment was confirmed, but there was chorioretinal thickening also, and there was no subtenon space fluid around the optic nerve. So there was no T sign. So the clinical impression was non-infective pan-uveitis, left eye. We pondered on the possible differential diagnosis. Could it be atypical Vogt-Koyanagi-Harada in terms of, atypical because it was a unilateral presentation, and the lady was 67-year-old with no history of prior such episodes. And could it be an atypical posterior scleritis? But she had no pain whatsoever. So anyway, we planned for IV methylprednisolone for 3 days, followed by oral steroids and azathioprine. And topical steroids and cycloplegics, dilators, they were continued along with the anti-glaucoma medication which she was already on. So at presentation, she went from 636 N36 to 69N6 after 1 month of such therapy. And the choroidal undulations, the RP undulations, the bulky choroid, it all settled, and the OCT pictures returned back to normal. And on the fundus photograph, in few focal areas, you could actually start seeing the sunset glow fundus kind of thing, indicating thereby that this probably wasn't her first episode to begin with. So eventually, she underwent left eye cataract surgery with a monofocal IOL 6 months down the line while she was on azathioprine and Visolone was given. And she has been recurrence free since last 1 year. She hasn't developed any macular edema or posterior capsular opacification in the post-op period. She tolerated Azoran well at her 67 years of age, barring a single episode of leukopenia following a viral URTI episode. And she recovered spontaneously within a week after transiently withdrawing Azoran. So at the latest follow-up, more than 1 year after the first intervention, after the presentation, she continues to stay 6'6" in both eyes, and the eye looks completely quiescent for the moment. And the only notable finding is this localized sunset glow fundus spots over the posterior pole. So the take-home message: cataract and uveitis, the surgery after the disease, only after the disease is quiet for more than 3 months with or without immunosuppressives. So pre-op, we need to hike the oral steroid cover, either in form of oral steroids or with the availability of Ozurdex. And a very slow tapering post-operatively is required. So the rexes need to be reasonably wide because these patients tend to develop phimosis later. Monofocal implant is preferred because of multiple uncertainties in biometry and the lens placement. And in the back placement is preferred. A good cortical cleanup is required. And postoperative hypotony is to be avoided as much as possible because it would lead to further inflammation and possibility of worsening in terms of choroidal detachment. So uh, she gave history of this angle closure and uveitis, and Dr. Rakshita already discussed part of it. So the angle closure episode 1 month prior to the presentation. So if we could look into the possible etiologies of the possible mechanisms of glaucoma, angle closure glaucoma in uveitic patients. It could be because of posterior synechia pupillary membrane leading to pupillary block, which would have been easily picked up by the primary ophthalmologist. peripheral anterior synechial leading to synechial angle closure as opposed to appositional angle closure as it was suspected in this case. The peripheral anterior synechial could have been picked up on the clinical evaluation. So what possibly occurred where an angle closure attack was precipitated very transiently and which reversed after PI. I mean, so was the assumption. Was probably a anterior ciliary body rotation and supraciliary effusion, thereby rotating and physically pushing the lens iris diaphragm against the peripheral cornea. So this was treated with laser PI, but in my opinion, what worked was steroids, cyclopentolate, and brimonidine timolol combination. This is what actually broke down that episode. It was not the laser PI which worked. And going back into the literature, this actually has been very well documented, and very old papers dating back to 1996 also showed, the ultrasound biomicroscopy picture, how the ciliary body rotates anteriorly. This has been described also with certain drugs like topiramate, but has been reported with VKH and other pan-uveitic entities as well. Yeah, that would be all my.
It is an excellent presentation of unilateral panuveitis, that to a non-infectious type. Usually such types of cases are very rare unilaterally. They are usually bilateral presentations. But as you have pointed out that this is all features are in favor of the VKH, from the diminution of vision, vitritis, papillitis, as well as on the angiography and OCT also. So it can be mentioned nowadays we are seeing such types of cases, even though it is not a classical VKH, but it is called as VKH-like syndrome. But exactly the etiology might be something apart from this one, and which we don't know exactly what it is. Sometimes the people, female patients, after putting a dye on the hairs also, they come with the uveal effusion like syndromes, and they come with the sudden loss of vision with the SRF as well as these types of VKH-like symptoms and findings. On subsequent visit, you have shown the sunset glow also. Moreover, you have told about very nicely about the PI also. PI, if it would have been only not inflammatory in thing, then it would have remained pattern. But because of steroid you have given, it was not blocked again. It remained patent, and steroid work in these cases also. And cataract, as you have mentioned very well, that what care is to be taken, how long it should be quiet, at least 3 months. You have to give a Ozurdex and all those steroids before going onto the surgery, and good clinical cleanup job. Apart from that, post-operatively also you have to keep on longer steroids and high frequency steroid topical as well as in any form, maybe subtenous or intravitreal, or if it is not contraindicated, even for a shorter time, you have to give in the systemic steroids also. All those things you have covered in this case.
I think Dr. Preeti wants to make a point, madam.
Yes. One thing is, as Dr. Baker said, he did an iridotomy. So iridotomy has a role to play only if there is any pupillary block. In this case, it was an anterior rotation of the ciliary body, supraciliary effusion. So he has also sort of brought out the point that PI probably didn't work. It is the steroids and atropine or cycloplegics which will relieve the angle closure. So this is a point which I wanted to break. Any kind, even topiramate induced angle closure or anything where is a ciliary body rotation, PI is not to be done. You give atropine and withdraw the offending agent if it is secondary, and the angle closure will resolve. So that's one point I wanted to bring across.
Very good. I think excellent point and very relevant point to this discussion. In fact, this was not the run-of-the-mill case like Dr. Sasavade was saying. And thank you, Nikhil, for presenting an amazing case and managing it really well. We have
Just
brought out
one question to Nikhil. What were the, how was this different from a classic uveal effusion syndrome? Because the OCT picture looked like that, the FFA did not. But did you think about that?
So I would say that in uveal effusion syndrome, you would not expect such sort of anterior chamber inflammation, which this lady had. She had Sine K and she had cells in the AC. So that would quite be against it. And the FFA picture, I'm not sure whether
not in
such kind
keeping.
of local
Yes.
involvement could be seen
Yes.
with yeah.
Okay. Thank you. Very nice case.
Nicely presented. Yes.
Very nice.
Thank you. Thank you.
Very good.
Take this opportunity to thank you all our panelists, our chairperson, my co-moderator, and all the participants of the UVA session to make it a very interesting session. I think we would still continue for talk for 15-20 minutes if it was not the time that bars us, because uveitis is very intriguing. Run-of-the-mill cases not always present, and they present and respond very differently to treatment. So thank you so much. I also thank our MOS office bearers, Dr. Anaga Erur, our Chairman Scientific Committee, Dr. Piyush Bansal, Dr. Preeti Madam, as well as Dr. Sumit Lane, for guiding us and giving us all the opportunity. And I think I would hand over to the next session. Thank you so much.
Thank
It was
you.
very interesting. Thank you. Thank you, Anga.
Hi, sir. Good evening, everyone.
Good evening. Good
Sundar.
evening.
Thank you.
Yeah.
All the best.
I think all these sessions are going to be really very, very informative and beneficial to all our members.
Correct.
Even later on,
We
if
also
anybody has
learned.
missed. Yes, absolutely.
We also learned. It's so nice. Okay, bye.
Absolutely. All right. Thank you so much, everyone. Thank you.
Thank you, everyone. Thanks a lot.
Thank you.
Thank you.
We'll move on to the valedictory. It's a fantastic 2 days of academic feast, and handing it over to Dr. Preeti Kamdar, General Secretary of MOS, for a brief valedictory function.
So, good evening. And at the fag end of the day, also, we have 128 participants still. And that speaks volumes about the quality of this conference. So, we come to the end of 2 days of power-packed case presentations and scientific deliberations. So, I, Dr. Preeti Kamdar, Honorary Secretary MOS, express gratitude to the chairperson, Scientific Committee, Dr. Piyush Bansal, Dr. Sumit Lane, for coordinating everything so well, and to the entire scientific committee, Dr. Anaga Heru, Dr. Ajay Loya, for all the hard work. And of course, the entire faculty, presenters, moderators, and the viewers, our members, for making this conference so successful. So this was the end of midterm MOSCON 2026, and I now hand over to Dr. Anaga Herur for her presidential thoughts. Thank you. Over to you,
Yeah.
Anaga.
Thank you so much, Dr. Preeti. If you ponder over the kind of presentations and discussions that have happened over the last 1.5 days, the kind of the how it was curated was actually how actually it made it different from others. It was not just didactic lectures, but actually case presentations involving each subspecialty with expert panelists giving their opinions. Nowadays, with a surge in the amount of AI and YouTube and a lot of things that you can already get ready made, such case presentations are very important because they bring out actual case details, which you can, because each case is different. Whichever subspecialty you take, it is the experiences of our panelists with respect to these cases which actually help us in our clinical scenarios. So I think it was a very well thought of kind of seminar. and involving so many of speakers, panelists, moderators, which was all curated and coordinated so well. So it's a great job. Kudos to the entire team. Thank you so much, Dr. Piyush, Dr. Sumit, and the entire scientific committee. They have really worked very hard for this. Also, our team, Dr. Preeti, Dr. Ajay, they have also been extremely instrumental. So it was all in all very well done. And even later on, I think all these cases, if we have the YouTube link, we should share it with our members so that this can be a reference for all of them and even for people outside. So thank you so much once again, and congratulations to our entire team. Thank you. Over to you, Dr. Preeti. Please unmute.
That was our president speaking. And again, she sort of voiced what all of us have been thinking over these 2 days and the positive response that we have gathered from all the attendees, that this is the type of conferences that people want. So over to you, Dr. Piyush, the person who has worked the hardest for this to make this MOSCON be such a wonderful success that it is. So over to you, Dr. Piyush.
Very kind of you, ma'am. Is Dr. Loya there?
I can't see him. That's all.
Okay. So, first of all, thank you for the appreciation. It has been exhausting. And again, for us, me and Sumit, to sit through yesterday and today as well. But frankly speaking, we didn't have to do too much as compared to last year's MOSCON midterm, where we had to make sure that people don't shoot their time significantly. I think that is the way to move forward, wherein we respect the time allotted, come prepared accordingly, and give more time for discussion rather than having any sort of didactic talks. It's more important to share the clinical difficulties or scenarios that you would want to share. Make sure that adequate time is given to discussion and the point is driven across. So that was, it's heartening to see that I think 80% of the sessions were ended on time. I never say before time, because if it's ended before time, it's on time. And I think only 10% sessions, that is 1 or 2 sessions, extended by a couple of minutes, less than 5. And only one session, which we permitted because it was the last session, extended by 7 minutes. So I think that's a good way to move forward. Hopefully, we'll be able to replicate that in the annual conference also. We have a lot of gratitude to express to, first of all, to the scientific committee members, especially Dr. Sumit. All of them have prepared their particular subspecialty sessions. Apart from them, where the representation of subspecialty was inadequate, their different subspecialists stepped in, Dr. Preeti Kamdar included, who prepared the glaucoma session. So that was very nice. And without the help of these coordinators, who were essentially the moderators of all the sessions, I don't think we could have, achieved what we thought that we are setting out to achieve, is to create more people to form sessions, to get involved, and make sure that the content does not suffer. So big gratitude to all of them. I named all of them in the inauguration. I won't take too much time because I know everybody's tired, including me. So big thank you to all of them. And of course, we have a lot of support from the core team, which is President Dr. Anaga Heru, Dr. Preeti Kamdar herself, who's the General Secretary, and Dr. Ajay Loya, who's the Treasurer. So a big thank you to all. And again, last but not the least, a very big thank you to all the speakers who they took the efforts to make sure that majority of the speakers took the efforts to make sure that their talk was concise. They were driving home a point, and almost all the panelists who were there throughout the session. And of course, Zadneo Diotech, Sunilji, who's been there right since yesterday, making sure that everything goes seamlessly. Entod, who did a lot of background work, making sure that the brochure and all of the formatting, everything was done in time. So it's just the blessing of our seniors, and we're just taking it forward. So all our advisors, all our past presidents, all our office bearers, a big thank you to everybody and to all MOS members. Thank you very much.
Till we meet again, MOSCON 2026 at GU, right? So we call